We proceeded. There was an opening ceremony, although the order changed during the implementation. We have put it where it is supposed to have been. You know, this came as the last session. However, we had this session which was chaired by the Vice Chair of the HIV Committee of Parliament, and the guest of honor was none other than the Right Honorable Prime Minister. We had a number of presentations. The first one was by the President, Guild President, Moobs, who represented the principal, and he elaborated on the drivers of the epidemic among students, mainly idleness, poverty, and transactional sex. He also indicated that the university has a skilling programs which keep students busy, and he requested for support for a Grand World AIDS Day function that is to be held at the university on 1st December. Following the guild president, we had Betty Kwagala from Powod. We emphasized the important role of communities, and he appreciated USC for translating the stigma policy guidelines for the sign language and Braille, and then recommended that we strengthen young people's programs, and also recommended a study on the burden of HIV among persons with disabilities. We had a poem by a student from Makerere College, and this emphasized the importance of empowering the girl child. We also had music by Joanita Kawalia, and she presented the historical hit Jim Wange, and this song has always had a strong message on gender-based violence. We had address by the US ambassador, and she highlighted the contribution of PEPFAR globally and to Uganda and the areas of support. She emphasized the importance of equity, stigma and discrimination, addressing stigma and discrimination, human rights, and targeting the marginalized groups and populations such as the LGBTQ community, as well as GBV, as some of the areas of emphasis in the US funding to the national HIV and AIDS response. We also had an address by Honorable Kabuye, who represented the Minister for the Presidency. He reminded us about the Presidential Fast Track Initiative objectives, emphasized HIV testing and HIV prevention, and requested USC to submit the Symposium report as soon as we finish. The guest of honor, the Right Honorable Prime Minister, highlighted the leadership role played by HE, the President, in the HIV response, reminded the audience about the ABC campaign and its previous impact, and on sustainability of HIV financing, she advised that the scaling down of donor support should not be rushed in order to avoid disruptions in the response. And she directed that we should have the Minister of Health and the Minister of the Presidency should submit the report on the discussions about HIV financing as soon as possible, which she will follow. And she also directed that HIV must be mainstreamed in all government programs. We went to session 3, which was chaired by Jotham Mbanjizi from UNAIDS, and we had a number of presentations, one by Eugene Uzagira, and he presented findings from the Karungu cohort studies, especially, which showed a drastic decrease in HIV mortality following introduction of ART, and the higher incidence of HIV among young people below 24 years, proportionately higher transmitters than women. He also showed that migrants to new communities have higher HIV incidence in the first and second years of settling than the host communities. We also got a presentation from Mr. Timothy Muwonge on behalf of his colleague who was away, Dr. Mujugira, and he presented promising findings from injectable PrEP and the pivilin ring, and he indicated one good finding is that there was no drug resistance observed at the end of the cabotegravir study, at the tail end of this study, although we have been having those fears that we might get drug resistance at the completion of those studies. We got Dr. Sise Kityo, ED JCRC, who indicated that JCRC is participating in a study on use of long-acting ARVs for treatment, and he indicated that the world is moving towards cure of HIV, but all the studies on the cure are outside Africa, although we have participated in very many studies before. And she also indicated that in some of those studies, broad neutralizing antibodies or gene therapy those technologies are being used in those studies. But the good news she brought is that JCRC has spearheaded the Global Gene Therapy Initiative, and trials are to begin at JRC in 2024. This is an international collaboration. There were other symposium activities taking place outside this room, and it included the Fire Retire Day or corner activities. You can even hear the music playing from that side. Please have a chance and go and visit that corner before you leave. There are exhibitions going on outside here, and they are going on until the end of tomorrow. And there have also been press briefings. As Chair indicated at the beginning of the session, we carried forward 3 activities: the keynote address by UNAIDS Regional Director, experiences from Mild May on adolescent girls, young women and boys, and young people's voices on ending AIDS by 2030. So today, moving forward, what we need to do to catch up, let's improve on our time management. Chair and members, I thank you for listening to me.
Thank you, Dr. Zephyr. So we can complete our sessions that spilled over. Is Priscilla Nambiru around? Please come to the stage. So we had one talk from the Young People's Voices. So we're going to get that, and also we're going to get experiences from Mild May. Do you have any preference? So you can. All right. So our first session this morning is going to be given by Priscilla Nambiru. Please, you're welcome.
Good morning. I'm so privileged to be representing the young people. Thank you, the organizing committee. Thank you, the development partners. thank you everyone for honoring this, this event. With me here, I'm going to represent the young people's voice. The young people are so honored and so privileged to have you all in their lives because you've done so much for them. We've seen very many implementations approach for us where we see differentiated services like DSDM, where we see innovative approaches, especially those focusing on KPIs. You've engaged the civil society organization and networks of young people living with HIV in social mobilizations and life skill, capacity building. So we are really humbled. But the young people still have a joint statement for all of us where we are seeing a few gaps, and they are as follows. We still have challenges in community to facilitate linkages of clients following HIV testing, and these are still lacking. The young people prefer for these gaps to be filled where we create youth-friendly services in every health centers. For instance, if at all I can give an example, if at all I can go to Baylor, and Baylor still has, like Baylor has youth-friendly services. We want to see this even in other health facilities. For instance, in remote areas. The other point is there's still limited integration of services like family planning, SRH services, PEP, cancer screening, and tuberculosis. We want to see, as young people living with HIV, especially the adolescent girls, boys, and young women, we want to see all these services integrated in one center. If at all a young person comes in a facility, we'd love to see this young person, if at all they have come for their art refill, for instance. Sorry about that. I was talking about integration of services. And the young people still have lack, whereby some services are not integrated in one facility. Like you have to come back to over for another clinic day for another service. For instance, if at all I've come for my review, for my drugs, I'd love to talk to a counselor about relationship because I'm growing up. I would love to talk to a counselor or a doctor for instance, tuberculosis. Like these services need to be integrated whereby if at all I've come for refill, services beyond my refill. The young people also have come with this statement whereby yes, we still have very many human resources in the country, but there's still insufficient number of skilled workers, including the counselors and the lab staff. For instance, we still have mental health issues in the communities. If at all we have toll-free lines that are available, or modern ways of communication like WhatsApp, if at all, for instance, I get any issue, like I have this number with me, that I can reach on if at all I have any issues, like I will not be able to run to the clinic because I have this. I will not be in the queue to wait for a doctor. I'll just text or make a phone call. So the young people would love to see this implemented. The other point is we still have pill burden, especially the young people who are on second line or third line. I'm a person living with HIV. In 2017, I was diagnosed with MDR-TB. That means the more kilos I had, the more pills I had to take. Both MDR-TB drugs with an injection for 6 months. This medication, this treatment is for 2 years. That means I had my ARVs and I had to take multi-resistant TB drugs. It is really a burden. So if at all there's any need, like we plead for the government, we plead for the development partners to really scale up the biomedical HIV integration, whereby, yes, if at all only by 2017 there was a cure, then I'll be like, yes, I'm left with only MDR-TB drugs. If at all there's any way we can really solve this, trust me, it is really hurting, it is really burdening. Because if at all, you cannot really tell the story unless you are the story. Eh? It is really burdening. If at all we can do anything to really solve this, please. It is a humble prayer to you all. My final statement is addressing gender equality barriers, whereby if only we can use such platforms to really use our voices to fight gender-based violence. Because, trust me, this is all brought about disclosure. I have a friend who told me, Priscilla, when you go to the event, please talk about this, because if at all the government or the stakeholders or the development partners bring up a program whereby, yes, this young adolescent girl will grow up into a woman, they'll desire for marriage. But then this young person will desire or will have a partner who is not disclosed to or who doesn't know my status. If only we can have sessions whereby which tackle disclosure, which bring up, like when I walk into a clinic, I'll go to so and so because I have a partner that I want to really bring more light on my status and his status, so that at the end of the day there is no gender-based violence. Because at the end of it, trust me, when I come in with my partner will be like, for all along you've been keeping quiet, and at the end of the day I'll lose it all. At the end of the day I may lose my eye. Who will take me after that guy? So if only this is tackled, like we have, for instance, in any health facility, we have sessions for such programs, for relationship, for disclosure, for stigma. Trust me, this will all end by 2025. My last point is, we would love more for the young people to be involved in such programs, in such events, whereby we are given a voice, we are given a mic. For example, for instance, if at all you're making those very important decisions, young people need to be included, because you will not really know what is on ground unless you include us. Thank you so much for listening to us. Nothing for us without us. I would love to acknowledge, I would love to thank the Uganda AIDS Commission. I would love to thank Baylor Uganda. I would love to thank UNIPA. I would love to thank TASO. For God and my country, thank you so much.
Yes, thank you very much, Priscilla. I think we've all got the point. But we'll have some question and answer session after that. The next presentation is Dr. Catherine Senyimba from Adelaide. Do we have somebody who was supposed to talk about Ebola yesterday? We'll be coming later. Okay, so we'll skip that. I think let's close the spillover of yesterday, and then we start today's program. So.
Good morning, everyone. Yes, I want to start by thanking the organizers of this event, USC, for giving us the opportunity to come here today and share our experiences in the work that we do as Melme Uganda in regard to HIV prevention among adolescent girls, young women, and boys. In today's presentation, it's going to be more about the work that is already happening, not only at Melme Uganda, but I believe with even many other partners and in many other places, but I believe there's something for us to learn even from these experiences that are going to be shared here. So I hope that we'll be able to leave this place having picked something new in that regard. Just a brief background about Melme Uganda, for those who may not be conversant with us. Melme Uganda was established in 1998 as a center of excellence for provision of comprehensive HIV and AIDS prevention, care and treatment, and training services. It's an NGO with a local board, and with time it has evolved to include a hospital, which is at our main site at Lueza on Entebbe Road. We have health system strengthening programs. We have an Institute of Health Sciences, and then the Research Center. And particularly in regard to our HIV work, through CDC support and in partnership with Ministry of Health, we are currently implementing a PEPFAR-funded project on accelerating epidemic control in Mubende region, in 8 districts in Mubende region. So through the HIV prevention, care and treatment work that is supported in the districts, and also through the services provided at the hospital in Lueza, over 140,000 people living with HIV are currently being supported on ART. And 12% of the supported PLHIV are young persons aged between 10 to 24 years. 76% of these young persons are adolescent girls and young women. So Melme Uganda's HIV prevention, care and treatment services target all population groups. That is the adults, the children, and the adolescents. However, today I'm going to share specifically about 2 programs that are focused on prevention among the adolescent girls and young women and the boys. And as we had yesterday, the incidence in this age group is still unacceptably high, so we need to continue doing all that is possible to see that we prevent them from getting HIV. So those are the 2 areas that I'm going to be sharing about the dreams and no means no. Why the focus on adolescent girls and boys? As we all know, the AGYW are the females who are aged between 10 and 24 years, and they are disproportionately affected by HIV and other sexual and reproductive health risks, as we have been hearing since yesterday. In relation to the Youth Year 2020, the prevalence among the young people between the ages of 20 to 24 is higher than among those between 15 to 19, meaning that the older ones had acquired it before, and that's why they have the higher prevalence. And the viral load suppression among the HIV-infected persons between 15 to 24 years is approximately at 50% compared to the adult population where it's an average of 90%. So that shows that even in the issues of viral load suppression, they are not doing so well in that age group. So these observations suggest that HIV prevention and testing interventions need to begin earlier among at-risk adolescents, particularly girls and young women. So I will start with dreams. For those of you who may not be so conversant with dreams, DREAMS stands for determined, resilient, empowered, AIDS-free, mentored, and safe. And this was among the program areas that were articulated yesterday by the ambassador, among those which are supported by PEPFAR. So the goal of DREAMS is to reduce the incidence of new HIV cases in adolescent girls and young women between the ages of 10 to 24 years by bringing together evidence-based approaches that address the structural drivers that increase AGYW's HIV risk and unwanted pregnancy. And so we'll be delving into those practical ways in which we can help the young people remain negative, even as we heard from the speech of the 25th Guild president of MUBS. You know, he kept saying, we need activities that keep us engaged and busy as young people. So these are some of those activities. So for DREAMS enrollment, there's a criteria that is followed. The structure drivers that increase the risk for HIV and unwanted pregnancies are well known to us. And these include poverty, gender inequality, sexual violence, lack of education, and lack of meaningful interactions. So with this program, it seeks to address all those aspects. And as mentioned, the target group are the vulnerable adolescent girls and young women aged 10 to 24. And to assess for vulnerability, assessments are done using a criteria that is based on age categories and characteristics. The characteristics below that is education status, usually those who have dropped out of school early, and then child-headed homes, the girls who have sexual experience, those who have experienced violence, because some of these are still children, then also those who have experienced gender-based violence, and those who have used alcohol and drugs. So we get to meet these girls, or they are mobilized in the communities by the different community resource persons, but also by their peers. So when we get into a community, we work a lot with the community gatekeepers, the leaders at the district and community level, the sub-county level, and we bring them on board to be able to work with them, to support us to identify the girls and young women who qualify for this program. So they really play a very important role in helping to find where these girls are and to mobilize them for uptake onto the program. So the approach used in the implementation of this program is a layering approach. And in layering, a beneficiary receives a package of core services to protect her from HIV at individual level, at family level, and also at community level, because it's not enough to only look at the individual, but you have to also look at the environment in which they are. And so why is it layering? It's because we know HIV spread has multiple underlying drivers. So we need to look at all the different drivers if we are to be effective. So the holistic approach or package of services is needed in order to create lasting solutions, because otherwise we'll do one thing and then still leave the girl at risk and maybe exposed to getting HIV. So the approach uses an asset-based approach to empower the at-risk AGYW by delivering a suite of protective assets and opportunity opening interventions to enable these girls get linked to something that will help them stop being so vulnerable. The interventions focus on building 3 assets. They are categorized into 3, as we shall see. We have human assets about the person, then the social assets, and the economic assets, because we know poverty is a main driver. So when we look at those 3 kind of assets, for the human assets, we have issues to do with the health care. So there's access to quality HIV prevention care and treatment services, because even if the project is aimed at getting the vulnerable negative girls, we also have some who, when tested, are found positive, so we also work with them. We do not take them off the program. They are part of the program, and we link them to ART. So under access to quality HIV prevention care and treatment services, there's provision of HIV testing services. So services are provided to these girls at safe spaces. These are places where they congregate in the communities and are able to deliver the package of services that I have been talking about. So we organize to have outreaches from nearby health facilities, and the health workers go and provide these services to the girls in one place. So HIV testing services, PrEP services, provision of post-violence care, condom promotion and distribution, provision of an expanded contraceptive mix, linkage to ART, linkage to PEP, and linkage of the male partners to VMMC. So we also work actively with the girls and the community members to see that the men, their partners, also come on board and services are provided to them. Then in regard to human asset development, there's AGYW-focused behavior change communication to help them address the issues that put them at risk in regard to their behavior. Then peer-led mobilization for uptake of the services I've mentioned. So peer-to-peer, it's easier for them to identify with their age mates. Peer-led mobilization for safer sexual behavior. Life skills training to avoid risky sexual behavior. So they undergo certain curriculum-based interventions. And these are given to them according to their age groups. So the younger girls between the ages of 10 to 14 undergo a training called Journeys Plus. It's also about life skills and, avoiding risky sexual behavior. And then Stepping Stones is for the older ones from 15 to 24 years. And so they undergo this. It's a series of weeks through which they undergo this. And then their parenting skills training for both the girls. Some of them are parents, but also for them and their parents. And then education support to see, for those who would like to go back to school, to see how we can mobilize their families and them to see that they go back. And then for community engagement, as I mentioned earlier, these engagements really involve the community members because that is where the girls are found. And therefore, we work a lot with the community leaders to form and facilitate peer support groups within the communities where the girls are so that they are able to support each other to adhere to the decisions they've come up with. And then there's community mobilization for norms change because there are certain unhelpful or harmful norms in certain communities that need to be addressed. And even this addresses gender-based violence prevention through the training called SASA that you heard about yesterday. And then parenting education, that is called Sinovuyo. So here we involve the caregiver or the parent of the girl and the girl. So there are sessions that are attended by both the girl and her caregiver to help build the relationships between them because many times things have gone a bit sour. And therefore, sometimes the children are in rebellion against their parents. So we work with the parents as well. And then community level behavior change communication and partner tracking. Then for economic strengthening, since poverty is one of the main drivers, they are provided financial literacy sessions, mobilization for market assessment, selection and planning, and management of IGAs. This is done with the leadership of the district teams, the probation office, the community development offices, to understand what are the marketable trades within that community so that the girls can be supported to select among those that would give them good market, and then they are skilled accordingly. So they are supported to undertake market-led vocational training or apprenticeship, and then they are also provided with startup capital and cash transfers. So we also organize and support the girls through producer groups for value chain addition to see that the products can be sold, and then also mobilizing them to save through the village savings and loans associations. This is just pictorial of the same. I will not go through the same, but it's just showing us some of the girls as they congregate in some of those safe spaces in the communities. These are sometimes at schools, in a compound somewhere, at a church, or in any place. But we also have model safe spaces whereby they are able to have the longer term skills that are imparted to them, which may not be able to happen within the communities. So I'll not go in detail there. So what are some of the successes or things that have been realized from this type of intervention for the girls? The life skills training has improved decision making, communication, safer sex negotiation, and relationships, thus reducing GBV, because many of these girls are in relationships, but they have really been having a hard time, especially in communication issues with their partners, respect, and many other things. So when they get this life skills training, it helps them improve their communication, negotiation, and all this, and the GBV cases have gone down. And then through the improved parenting skills, the children and adolescents who have signs of dropping out of school are supported to return or remain in school because the parents are equipped to identify a child who's beginning to show disinterest in school, beginning to dodge, and so that they can engage with them early enough to talk to them, to counsel and guide them, or to even find out why is it that they do not want to go to school so that the issues can be dealt with. Then the community norms change has enhanced community safety nets because the entire community is part of the support system for these girls. It has improved relationships between adolescents and their parents or guardians, enhanced community support to the AGYW, and facilitated partner tracking because it is being done as a team. Then community dialogues for the boys of male engagement has heightened male involvement as enablers and service beneficiaries. And this has also reduced the GBV occurrences because the men are also called for these talks, and they are guided on what to do and what not to do, how to control maybe their anger and different things. So how to resolve conflict amicably. And this has really also helped. Then social assets building through meaningful interactions at the safe spaces, because the girls come together and they learn to work as teams. Many of them may not have been doing anything like that, but when you have to work as a team, you build certain skills. So the behavior change communication sessions have enabled the girls to develop interpersonal communication skills and the ability to demand for their rights and services. Then through the market assessments, these have enabled the girls the AGYW to identify marketable trades and prioritize a trade with quick economic returns. Because in the past, they all wanted to do the same thing. You'd find the whole team is doing one thing, hairdressing. So you wonder, in this village, how many salons are there going to be? All of them hairdressing sincerely. Even if, how many customers will you get? So encouraging them to think beyond the norm and and stop going with what everyone else is doing. So that kind of prioritizing is being done. And then selection, planning, and management of IGAs has been employed to train them to establish viable and profitable IGAs so that they don't, eat all the money they make, but guiding them in these things to make savings and to sustain their business economic empowerment. So I believe these are skills and tips that are not only for that should be only in the DREAMS program, but everywhere, to all facets, to all of us. We all need such skills and such guidance. So the AGYW have been able to acquire training in male-dominated skills like mechanics, electrical installation, welding, those areas where it was like it's a man's domain. We have had girls who are really skilled and good at that, and they are really doing well. There's a team that has a garage for motorcycle repairs, girls in Busunju somewhere there, and I think they partners. Thus reduction in the number of sexual partners and other high-risk behavior. So that also has been a good thing that has happened. Then the new HIV infections among over 70,000 AGYW who've served over the last 2 years has remained quite low at 0.03%. So we think this is a good thing, and it is working, because these are the girls who ideally you'd think are really at high risk of acquiring HIV, but if it has enabled them to remain at such a low incidence, I think these interventions are worth scaling up. So those are just some of the pictures showing the girls doing different things. Others are into farming, rearing chicken. They're guided on what they can do in their communities so that they can earn and look after themselves with all these different kind of skills that they do. They are the ones who are in some of the male-dominated trades. The motorbike people are there. Welders are also there. And the community is beginning to accept them, because before that they were like, eh? But now they're understanding that, these ones can also do a good job. And then, and some are in the shoe business, making shoes and all. So, and those are the community engagements with the police, talking to the men. Not that the men need police in particular, but but they are part of the family, those teams at the district, at the village level. And I think when they see a fellow man addressing them, somehow they respond. So as I come towards the end, I'll share briefly about No Means No. This is a program that has been designed for youth between the ages of 10 and 20 years that is deeply rooted in empowerment, self-defense, and it is a uniquely holistic, survivor-centered approach to self-protection skills. So we are really addressed here in the No Means No. So this program teaches both boys and girls verbal and physical skills to help prevent sexual assault and other forms of gender-based violence. So it helps to deter assaults by increasing effectiveness of resistance and self-confidence among these young people. So this program has focused on preventing GBV and reducing the risk of acquiring HIV through sexual violence. So it has been recently rolled out by MELD in the areas we are working in Mubende, and we are now scaling it up even in the other districts where we have a DREAMS program. So it is for girls and also for boys. So at least in this, the boys are also being reached with a variety of things that are unique to that particular gender. And particularly for the girls, something about saying no, because many times the men say that a woman's no is not really no, things like that. Those excuses, I don't know if it's an excuse, but for them to give a no, which is communicating no, not only the words, but also in the action and everything. So boundary setting, assertiveness, empowerment, and all that. And even the physical self-defense skills are given to them. They know how to protect themselves. And then for the boys, awareness, personal safety, positive masculinity, helping them know that being a man doesn't mean be aggressive and, jump onto, anyone, but protect the people, look out for those who are having issues, be a role model in the community. Even redefining gender roles, debunking rape myths and culture where people say, she was dressed badly, so I had to. I'm justified in what I did. No, changing that. The cycle of force, consent, and bystander interventions. Because even the boy might not be the perpetrator, but he may be passing by. So what can he do to help the situation? So my second last slide is this, just a few what we have experienced in the time we've implemented No Means No. The girls and the boys are available, and they are so willing to participate in these sessions. It's an interesting training, it's fun, it's attractive, therefore their participation is guaranteed. It's just a 1-week training, so it really brings them together well. And caregivers in the community appreciate the program, so they are very happy because gender issues had really increased, especially in COVID, if you remember. The caregivers and school administrators have requested for involvement of the boys in that program. Initially, it was mainly for the girls, but with more, they said, no, even these boys, many times they are either perpetrators or something. Let them get onto the program. So it has been adjusted to address them. And then the sub-county leadership has also been supported. It was during COVID that we rolled this out, but they were availing us with masks and other things. Then the in-school approach, because we also deliver it in schools, was really recommended because it has a diversity of students it reaches, and the learners are able to share their skills when they go back to the communities. So, and this has also increased confidence among the participants who feel they can defend themselves if attacked. The boys' attitude towards the females has also changed. The disclosure among those who have been assaulted before has been reported, and there's improved linkage of the HYWV to those in authority for support. So that is just marking the end of the presentation. Thank you so much for listening.
Thank you, Dr. Senyiba. Okay. Is Berry?
Since I was tested HIV positive. My name is Fiona Barrow. I am a young woman living with HIV. I am a peer educator at a medical center, and this greatly affected my adherence. If I had been assisted in disclosure, I would have passed through the counselor to make this known to my mom. Within this period, I dodged my family, my friends, my lectures. I never used to attend lectures because I thought maybe they would see me falling sick. They would see me because I'd lost weight, and then they would start asking me, what's wrong with you? Are you sick? So I tried to avoid anything. Doctors Club at the facility where I get treatment. That is Alive Medical Services, Namuongo. Life Medical Services is a non-government organization and health center which offers comprehensive free HIV services that include treatment, care, and support, and they serve us with love and dignity. With the different sessions we had, I embraced the fact that I was not the only one going through the same situation. I also joined the Y Plus Music Band. That is a group of young people infected and affected with HIV with the aim of advocating for a stigma-free society for people living with HIV. In 2020, I got to know of the Y Plus Beauty Pageant hosted by a Uganda network of young people living with HIV/AIDS, that is UNIPA. This is a pageant that focuses on eliminating stigma and discrimination towards young people living with HIV, and also promotes their inner beauty by empowering them to live as advocates and change makers in their societies. And our theme for the Y Plus pageant this year is "We Have Got the Voice, Pass Us the Mic." In 2021, I participated in the pageant, and I made it as the Miss Y Plus Central Region and second runner-up at the national level. I have used and still using my crown in various aspects, like creating safe spaces for adolescent girls, young women, and prioritizing more on their needs, prioritizing more on their mental and psychosocial well-being. I have been hurt, but I wouldn't want to see a negative young person be infected. And that is why I have done my sensitization on HIV prevention in the grassroots, remote areas, churches, on television, radio, newspaper, and social media as avenues in the drive of the message. Today, we are here under the theme, Ending Inequalities among adolescent girls, young women, and boys. These inequalities indeed affect us, and they are driven culturally, socially, and economically. As girls, we have been raised as economic sources, whereas boys have control over the source. Structurally, our cultures have given chance to men to have power, while for the girls to get our experiences, it turns into sexual exploitation. This is, sadly, inequalities in the social, cultural, and economic setting, and also be able to fast-track PrEP and family planning integration in our services. My appeal to the development partners and key stakeholders, that is PEPFAR and Global Fund, is to invest meaningfully in the areas that address our needs. For example, funding for the expansion of the DREAMS program to other districts with high HIV prevalences so that we can be able to fight this epidemic. We as young people are committed to continue raising our voices, to share our stories of pain and success.
And at the back, the gentleman at the back, and
Good
the
morning.
lady at the back. I think
Good
we'll have
morning,
those three, yes.
Good morning to everyone here. My name is, I'm Dr. Lydia Mungerera, and I'm a board member on Uganda AIDS Commission Board. I just wanted to say that I'm really happy to see the DREAMS program expanding to reach out to the young boys, and it's very good. But one of the things that I noticed, and even in your photograph, on your pictures, you need to also put them through entrepreneurship and skilling. And so their pictures also appear in entrepreneurship. And as much as, of course, I know the vulnerability of young girls, and I think they need to do that. But also some of the issues we've been having are the health-seeking behavior of boys and men. And I think these areas of health-seeking behavior have affected so much access to services for boys, and when they grow up, they are men, they're the same men, and their health-seeking behavior has brought many challenges that you see. The face of HIV mortality is actually men. So that issue of stigma is very important, and I think it's very critical. Then the other thing I want to talk about is the time when we started ARV treatment in Tasso. I was working in Tasso in 2004, and we started ARVs. And I think one of the things that we were concentrating on at that time is to train the treatment supporters. Even before we allowed anybody to get treatment, we actually had to train the treatment supporters. And this is very critical. So for young people going to get access antiretroviral therapy, the counseling, we attached every client who came to Tasso with a counselor before they left Tasso, so that everybody went through that counseling, the treatment supporter was trained, and that's why I'm very happy with caregivers programs, because somebody leaves the treatment center when already they've been counseled and they know what to do.
We have those two. If there is an extra minute, because Lydia took some time. So that gentleman and the lady at the back there, those two want to get their voices. If there's a minute, sir, I'll come back to you.
Yeah, thank you very much, Chair. I want first of all applaud Maldive for the DREAMS project. That the DREAMS project has improved the young girls making decisions, negotiating for sex. How do you track this? Do you manage? Thank you.
Okay, thank you. The last person there, the lady, with the red, with the red armband, yeah.
Good morning, everyone. My name is Awuma Helen. I am the face of HIV in the organization where I work. I am living with HIV and positively. I just want to relate to the point that we had yesterday and even make a call. Even as we do our work as a ministry, as Uganda AIDS Commission, as a church, let's get time. Yesterday somebody talked about commercialization of HIV activities. Even when you go to your home, take time and reach that person on the street, that person in your neighborhood. When you go to your villages, take time and go to that primary school and reach out. All of us. The person yesterday talked about the Sarahs. I am a Sarah that was redeemed. And there are many Sarahs out there waiting for you, each one of us. Remember, God is looking for just one person to reach out, and that one person is you. Get time and reach out.
Okay, thank you. I think most of these were comments, but we have some few questions. Can we have them addressed? Was your question very short, sir? Was it a very short question? A very short, burning question? Very brief.
Very brief one.
Half a minute.
I wanted to ask my daughter there about the Y plus beauty pageant. I wanted to get whether they get some public opinion on that beauty pageant. If they get, are they supportive?
Thank you. So some of them were just comments, so thank you for the guidance about the boys having entrepreneurship skills as well. So that is something to be considered. And then the issue of addressing the health-seeking behavior among boys. So the program we have for boys is the No Means No. For the dreams, it's not for boys. The way it was designed, it is for the girls, since they are affected more by HIV. And so I think because of the donors' focus on the most pertinent group to address, they began with girls, but hopefully with time they'll also go to the boys. So the issue of health-seeking behavior being addressed even through the No Means No program is taken note of. And then at what level do we involve the boys in the dreams? We reach out to the boys. So when we are looking for their partners, that is when the boys come in, but otherwise the dreams program targets girls. But however, the boys come in as partners, we get them to be tested, go for VMMC, and any other health interventions that they need. And also issues of course, GBV and managing their relationships better. Then for the issue of the young girls negotiating for safer sex, we track this through the routine engagements we have with each of these girls and document this in the case files. And then at the end of the period, we are able to understand how their practices have changed, even the sexual practices. So we keep taking note of this and documenting it over time. And then we are able to see how this is changing. And then the last one was about an AGYW who has been under dreams, initially negative, and then turns positive. So we continue with her. She does not get exited from the program. As long as she is still within the age group, she continues on the dreams program for the duration she's supposed to be there, because we have them for a year each. And then even while she's on the program, we link her to ART services. That's why we also had something about ART. So those who need ART are on ART and get all the rest of the full package alongside the dreams interventions. Thank you.
Thank you, Dr. Senyimba.
Thank you for Professor Richard. Well, you asked if the public opinion is supportive of the Y Plus Beauty pageant. As far as I'm concerned, yes, although there is a little bit of the negative, which will always be there. And then maybe what we need in the drive of the Y Plus Beauty pageant during the campaigns, we need more resources in making this more public, like for everyone to get to know that it happens and this is why it happens. So that is where more resources are needed. Thank you.
So sorry, I can add on something small. Like, I'm a former Y Plus ambassador. Basically, where I come from SETA. But then when I went for the competition, I think some people saw me on television. Trust me, even the chapat seeker, like the people who fry chapats, got to know that Priscilla, they call me Pizza, got to know that Pizza has HIV. Trust me, they were waiting for that day, maybe I get sick or die. But right about now, they're the same people calling me to help their children, to enroll them to, like, they inquire from me to be like, Priscilla, Pizza, my child has this. Could it be HIV? Could it be, what can I do? So it is really bringing more impact. Yes, the world will see the bad, but we as the young people, we have to stand strong and change their faces. Thank you so much.
Okay, we'd like just to thank our presenters this morning. Please give them a big clap. Thank you very much. Yes. And I'm told those of you who may have missed a cup of tea, you can quietly pick one just in the tent there. So the next, we'd like to invite the next speakers to come. The presentation on the UPHIA and EMTCT impact. I think here we have Dr. Joseph Musinguzi, but I think Dr. Wilfred. And I'd like to invite Dr. Sabrina as well to come over here. So those are going to be our next speakers. So welcome. And do we have the presentation from the UNAIDS? I think we'll do that after these great guys. Please take your seats. I'll invite Dr. Wilfred. Dr. Wilfred will talk about himself, but he's going to give us the detailed presentation of this morning. Thank you, Wilfred. You can use this gadget if you know how to use it.
I might need a bit of training, though. I'm saying. Good morning. Am I on? I'm still going through a bit of training. Okay. His behalf. So I'll be giving you key highlights about this UPHIA, which is in full Uganda population-based HIV impact assessment survey that was conducted between 2020 and 2021, and also some highlights about the PMTCT impact evaluation that was also conducted between 2017 and 2019. I have a big problem, Mr. Chairman, because you have only 20 minutes. Each of these big surveys, they're big national surveys, and I'm sure each of them requires more than a day to present all the findings. So I can only afford to give you highlights. So please, I apologize in advance if the flow is not as good as you would expect it. I'm just picking highlights that I thought that were important for this audience. Now, these two national surveys were conducted by the Ministry of Health, working with partners, supported by the United States government through PEPFAR and CDC. These two surveys aimed to assess the impact of overall HIV services. We have been implementing HIV services, a wide range of them. The question is, are they having the impact that we want to have? The PMTCT impact evaluation also sought to do that for PMTCT services. Now, UFIA 2020-2021 was a national population-based survey of adults. This time we conducted only adults. I've indicated it was conducted between 20 and 2021. It characterized the HIV epidemic in Uganda at population level, because most of the data that we have is from facilities, but we recall that there are some people who don't come to facilities. So we occasionally go to the population. It is one of the second generation of FIA surveys that are being conducted in the region. It follows on 3 previous surveys that we conducted in 2016-17, AIDS indicator survey 2011, and also another AIDS indicator survey that was conducted 2004-2005. So I'll be presenting some trend information based on those. The PMTCT impact evaluation was facility-based, it was not population-based, and it also characterized MTCT rates and a wide range of PMTCT indicators. But you must bear in mind that this was facility-based. There are some women that may not be going to facilities and so could not be picked by this particular survey. So what were the primary objectives of the surveys? UFIA 2020, the primary objective was to determine viral load suppression at population level, defined as less than 1,000 copies per mil. That was the primary objective, and the survey was powered to determine that. But we had secondary objectives of determining new HIV infections or HIV incidence, national and subnational prevalence, behavior risk factors, uptake of HIV services. We determined HIV drug resistance, and also the 95 at population level. While the PMTCT impact evaluation, primary objectives were to determine MTCT rates at baseline and after breastfeeding, to estimate maternal HIV incidence or new infections during the breastfeeding period, because we have already indicated before that quite a number of infections, vertical infections, arise from mothers who get infected during breastfeeding. So we wanted to determine that level of incidence, and also determine mortality among HIV-exposed and unexposed infants. And there was a host of other secondary objectives, many of which perhaps I may not have time to go through them. I want to skip this slide, which was abridged methods, but maybe just to summarize so that you know the data where it's coming from. Once again, UFIA was population-based, only for adults. We picked the sample from 313 enumeration areas that were spread across 11 survey regions and 11,000 households. The households were selected through a 2-stage procedure. The data collection was through face-to-face interviews, but also blood draws from consenting adults tested for HIV and a range of other biomarkers. Field data collection started in 2020 in February, but no sooner had we started than COVID mitigation measures came in, so we paused the survey until October and completed in 2021. The tests for HIV were based on the national testing algorithm, but we added genus testing for confirmation. HIV incidence was based on a Lagervita assay. The algorithm involved subtyping, viral load suppression, and plasma ARVs, and I'll be presenting that. We also determined HIV drug resistance and also plasma ARVs, because we wanted to see if people are reporting correctly. And we also conducted CD4 enumeration. We had quality control procedures in place for all interview and biological procedures, and the survey was approved by relevant institutional review boards. PMTCT, on the other hand, had 2 components: baseline in 206 facilities. These were children coming for routine immunization between 4 and 12 weeks. We picked their mothers as well. The sample was meant to be 20,000, and collected baseline data, including biological data. For a sample of exposed and unexposed children, we followed the mother-infant pairs for 18 months, coming every 3 months for interviews and biological sample collection. We wanted to determine HIV incidence as well as seroconversion among children. This is the schematic, a presentation of the PMTCT impact assessment, as well as the upturn, how it turned out to be. So I will now go to results. First of all, response rates for the population survey were very good. We were able to locate over 95% of the households. Within the households, interview response was very high. Over 90% of men and women responded. And blood draw was equally good. Over 97% of the people approached agreed to give us samples, so that the overall response rate for the population survey was 88%, which makes us very confident about the results that we are presenting. On the PMTCT arm, again, the response rates and the follow-up rates, as summarized here, were very good, all of them above 75%. If we had anything less than 75%, we would throw away the data, would think it is not representative. HIV in the households in 2020 was 13.5%. In other words, 13.5% of households in Uganda at the time we interviewed had someone living with HIV. Not very different from 5 years before. Urban households, as you can see, were more likely to have HIV-infected individual. This is, I think, will inform our care and treatment programs, especially the home-based care. Now, the prevalence of the head of the household being the one infected was about 10%. Again, not very different from 10 years before. The household being headed by a woman who is HIV infected was higher, 15%, which was twice that of the household being an HIV-infected male head of the household. I will now turn to HIV incidence, and I want to remind everybody what HIV incidence is. This is the rate of new HIV infections. It is a very important impact measure. All our prevention programs, the aim is to prevent new infections. Are we succeeding? Well, the most important measure is HIV incidence. At the population level, we determined HIV incidence among adults of reproductive age to be 0.32%, or 3 per 1,000 per year getting infected. In other words, if you have 1,000 uninfected adults, 3% are getting infected each year. As you can see there, the incidence rate was higher among women, about 4 per 1,000, while among men, it is 2 per 1,000. By age group, that's where the story is. I think we have all heard about adolescent girls and young women. 6 per 1,000, compared to 3 per 1,000 for that age group of 15 to 24. So this is a serious problem, and I think the focus on adolescent girls and young women is well informed and continues to be well informed. The highest incidence among men, as you can see there in the blue graph, is among 25 to 34-year-old men. And again, this is the story that we've had since yesterday from Rakai and others, that men are getting infected around that age group. It's not every year that we conduct population surveys. Actually, we do it every 5 years. So what we do, we compare this estimate from the population with our annual estimates that we obtain using mathematical modeling codes using Spectrum. So our estimate for that period was 0.25, or 2.5 persons per 1,000 years, compared to 3 per 1,000, which are very close. The confidence intervals are overlapping, which gives us some good confidence about trusting our mathematical modeling estimates, which give us annual estimates. Now, with this level of HIV incidence, taking the population into account, this turns out to be well over 50,000 new HIV infections in the country per year. And I think that's what Bagambe presented yesterday. The estimates are similar. This is from Spectrum, age group specific HIV incidence estimates. And again, you can see adolescent girls, the older adolescent girls, 15 to 19, and the young women, 20 to 24, having the highest incidence and also the highest numbers of new infections. So just again to restate, the focus on adolescent girls and young women is very well informed and well justified. The PMTCT impact assessment, as I told you, tracked HIV negative women to track the rate at which they were turning positive. And this is what we have. These are breastfeeding women who were initially negative. By 6 months, 1.7%, or 17 per 1,000, have turned, sorry, this is per 1,000, I'm sorry. This is per 1,000, not percent. 1.7, nearly 2 women who were initially negative and are breastfeeding have turned positive. Of course, the risk of transmitting the infection is very high given the viremia. And by 9 months, 2.3. By a year, it is about 2.6, which is similar to the incidence estimates that we indicated. And by 18 months, when breastfeeding stops, about 4 out of every 1,000 women have turned positive. Of course, if you don't test them during breastfeeding period, they will continue breastfeeding and putting the children at risk. So that's the cumulative probability of new HIV infections or HIV incidence. Of course, the question would be, these are breastfeeding women, and this is sexually transmitted. How do they get it? Or why should they get it? They are breastfeeding, they are not attempting to get pregnant again. But perhaps the answer will come from qualitative interviews. Now, the lowest graph there is disaggregating this by age group and showing the highest cumulative probability of new HIV infection being among the 25 to 29-year-old breastfeeding mothers. This is not general population. So to summarize just on incidence, because incidence is very important, the incidence appears to be high, but compared to previous estimates, it is falling. Adolescent girls and young women continue to have disproportionate incidence. HIV incidence during breastfeeding period is still high and should continue to be focus of our MTCT programs, and that's why you might see that PrEP is being recommended for breastfeeding women. Numbers of new infections have fallen in recent years, but still very high, about 54,000. That's not what we want to have in the country. And population-based HIV incidence estimates and our spectrum modeling estimates are similar. And we have also indicated that the high burden of HIV at household level remains high, including among heads of households. I will now turn very briefly to HIV prevalence. Now, prevalence is different from incidence. This is the proportion of people who are infected at any point of time. Now, some of these may have got infected 5 years ago, 10 years ago. Incidence, it's in the past 1 year. I hope you get that difference all through. So this is our estimate of HIV incidence in Uganda during that period. Overall, 5.5% among adults of reproductive age, 5.8% among all adults over 15 years. The map shows the geographical distribution of prevalence, highest in South Buganda region, followed by Mid-North, least in the Karamoja region, around 2.1%, followed by West Nile, and this has been the picture that we have had over many of the previous years. Right here is the age and gender group distribution of HIV prevalence, peaking among women in the age group 50 to 54 years. That was not the story 15 years ago. They used to peak around 30s. So we are having an aging epidemic. The men are peaking around 45 to 49. What remains constant, if you look at the 15 to 24 year age group, a ratio of about 1 to 4, and that has been the picture for quite a long time. Now, this is simple bivariate distribution of HIV. We have not adjusted for confounding. Urban areas, the prevalence, especially among women, has continued to be higher than rural areas. Individuals who are previously married or widowed, prevalence is highest in that age group. About 1 in 6 are infected. HIV prevalence falling, as you can see, by education attainment. So perhaps very good to keep our children in school. And the pattern with the wealth quintile is not very clear, but tends to indicate some kind of trend as well. Now, those are the people that are infected. Do they know? Do they know that they are infected? Actually, not many of them know. Because as you can see, about 20% are not aware that they're infected. And this is worse for men. About a quarter are not aware. The story does not end there. We have a small percentage of about 4% that are aware, but for reasons they know themselves, they are not enrolled on ART much as we have rolled out ART free to individuals across the country. So these individuals are not linked, especially men. The good news is that the majority of people are aware and told us that they were enrolled on antiretroviral treatment. But there is a testing gap and there is a linkage gap for programs to focus on. This is how that picture shows by gender and age group. Nearly half of young men are unaware. About a third of young women are unaware. We have a significant, well, not significant, but some proportion of concern among middle-aged men who are aware and are not linked to treatment, antiretroviral treatment. This graph here is summarizing previous treatment history. It's a tired graph, but it's an indicator that we have tracked for a long time. Nearly between 70 and 80% of adults out there have ever tested. And about 40%, slightly less than half, told us that they had tested within the previous 12 months. But when you compare that with our test results from the FEAR, individuals who tested positive were more likely to have ever tested than those who turned out to be negative. But in terms of recent testing, which are these other lower graphs, there isn't much difference between those who tested positive in our survey and those who tested positive and those who tested negative, or those who have never tested, or who did not test. In other words, who did not test within the survey because we had some level of non-response. Now, I'm glad Canon Vyamugisa is here. This graph disturbs me a lot. What we have here are individuals who tested positive and we detected ARVs, who did not detect ARVs in their blood. So about a quarter we did not detect ARVs. But there were people who were not previously diagnosed, who told us they have never tested, they are unaware of their HIV status. Many of them we did not detect ARVs, which is good. Which is expected. But it's not 100%. Including those who said they were previously diagnosed, but they are not on ART. A good number we did not find the ARVs, and that's what expected. But not 100%. We have that number where we detected ARVs when they said they were not previously diagnosed, or they were previously diagnosed and not on ART. And we think this is perhaps disclosure issues, and I'm glad I had a testimony just before we came in here about challenges of disclosure. Perhaps this is what is at play here. So, in the next graphs, if I still have time, Mr. Chairman, we overruled self-report if we detected ARVs. If we found ARVs in your blood and you had told us you are not aware, we overruled your result. So when I'm going to the cascade, knowledge of status is not necessarily what you told us. Of course, if you told us and we found ARVs, that's good. But if you told us you don't know, but we found ARVs, we just assumed that you're having a disclosure problem. So let me turn to viral load, and I will remind you that for FEAR, this was the main objective. And here is the good news. Compared to 5 years ago, the population that had viral load suppression had increased from nearly 60% to about 75%. In other words, about 3/4 of HIV-infected people out there had achieved viral suppression. And that is the distribution across the country. I'm glad you clapped. But then there are some regions, Mid-Eastern and Mid-North. Do you remember this was 2020? We expected at least 71%, according to the triple 90s, to have a viral suppression of at least 71%. Mid-Eastern Uganda and Mid-North Uganda appear to be lagging behind. And perhaps we need to focus there. But also, of course, we could do better. But at least we met the targets for 2020. This is viral load suppression by gender and age group. Individuals aged over 55 and 60, very good levels of viral suppression. But our young people, both men and women, as we have already indicated, in fact, for men, less than half have achieved viral suppression. I'm glad we have specific programs, the YAPs and others that are looking at adolescent girls and adolescents and adherence. Those are well-informed programs, but you still have a big gap to cover. We estimated population viremia, and let me define it. Population viremia, we used a cutoff of 1,000 copies per mil, but we said everybody, whether you are HIV positive or negative, what percentage out there, positive or negative, have viral load below 1,000, above 1,000 copies per mil? And our estimate turned out to be 1.4%. In other words, at population level, regardless of HIV status, 1.4% have unsuppressed virus. But it ranged between 0.5% and 2.5%. And the regions that had the highest levels of population viremia, mid-north, northeast. We went a step further. That is population viremia in maroon. And we went to spectrum and picked our estimates of HIV incidence by region. And I want you to see that very striking correlation, ecological correlation. So clearly, population viremia is driving HIV incidence. Now, there's a lot of discussion about low-level viremia, and there have been discussion as to whether we shouldn't shift the cutoff point from below 1,000 copies to perhaps 200 copies per mil. And we have the results here. So if you use the cutoff of 1,000, I've already indicated viral suppression was at 75.5. But if you use the lower cutoff so that you take into account low-level viremia, viral suppression falls to 71%. And across the regions, similar story, maybe apart from northeast Karamoja, where it remains not affected, but otherwise, when you use the lower cutoff point, viral load suppression falls by between 5 and 10 percentage points. Now let me move to the HIV testing and treatment cascade. This is our cascade as determined at population level. Knowledge of testing, as I've already indicated, was not universal. It was actually about 81%. Our previous estimates up to that time were hoping that we had reached the 90%. The target for 2020, 90%. So unfortunately, we did not meet the first 90. There is a bigger testing gap. In fact, I'm glad that PEPFAR and others who had restricted the testing numbers based on these results have since then relaxed to allow for more testing so that we identify the 20% at 96% and viral load suppression again over 90%. So the challenge here was the first 90, we had attained the second 90. And when you go to the non-conditional cascade, because the first 90 is very limiting, then you find that we did not reach both the second and third 90, because you cannot get on ORT unless we know your status, and even viral suppression is out of question. So we really have to invest a little more in identifying individuals that are still out there in the population level. Here we are comparing the cascade 5 years ago and 2020. Good news is that for all elements of the cascade, improvement across all gender, but the testing element, the first one, across men and women and total, remained below the 90% target for 2020. This is how the cascade varied across regions. Again, you can see that there are many regions that did not meet. There's no region, maybe apart from Northeast, that met the first 90. And the third 90, some regions like Mid-East, Mid-North, even Karamoja, and perhaps East Central was borderline, Central North, North Buganda, they did not meet the second 90. So again, across regions, we have to identify areas of focus there. Now let me just present very briefly some data on HIV drug resistance, advanced HIV disease, and comorbidities. We started by subtyping the virus strains that are circulating. Uganda has traditionally had a high proportion of subtype A, which was 63%, followed by subtype D at 23%. But we had a high proportion of recombinants, about 10%, and we also had subtype C. This was important when we were estimating HIV incidence, because the mean duration of residency varies by subtype. 2020, 2021, 2022, 2023, 2024, 2025, 2026, 2027, 2028, 2029, 2030, 2031, 2032, 2033, 2034, 2035, 2036, 2037, 2038, 2039, 2040, 2041, 2042, 2043, 2044, 2045, 2046, 2047, 2048, 2049, 2050, 2051, 2052, 2053, 2054, 2055, 2056, 2057, 2058, 2059, 2060, 2061, 2062, 2063, 2064, 2065, 2066, 2067, 2068, 2069, 2070, 2071, 2072, 2073, 2074, 2075, 2076, 2077, 2078, 2079, 2080, 2081, 2082, 2083, 2084, 2085, 2086, 2087, 2088, 2089, 2090, 2091, 2092, 2093, 2094, 2095, 2096, 2097, 2098, 2099, 2000, 2001, 2002, 2003, 2004, 2005, 2006, 2007, 2008, 2009, 20 We detected antiretroviral drug resistance through genotyping, and we used samples, a cutoff of 200 copies per mil. We successfully amplified 78%, and among them, and that's not very good news, 42% exhibited some form of drug resistance mutations. 42%. And this was variable. For individuals with detectable ARVs, it was as high as 65%. For those with no detectable ARVs, it was about 35%. But that's any form. When you go to individual ARVs, 17.3% had mutations to NNRTIs. I think this is what has been for a long time, and we have since moved on, applied that evidence. 7 or 8% had both NRTIs and NNRTIs. But important to watch is the 5% that had some mutations to integrase strand transfer inhibitors, INSTIs, 5%, and about close to 5% who had both INSTIs and NNRTIs. Fortunately, this does not translate into automatic resistance, but reduced susceptibility. We need to keep tracking this, and we have our HIV drug resistance technical committee to do that work. Now, CD4 T cell counts were conducted. Shocking at this time of the epidemic to find that about 9% had CD4s under 200. About 34% had CD4 T cell count under 350. And the distribution of between 350 and 500 and above 500 is as shown. So those under 350, we are considering that to be advanced HIV disease, or immunosuppressed, and those under 200 as advanced HIV disease. This is the median CD4 T cell count among men and women. But shocking again is that people are aware but not on ART. Their median was even lower. Again, this is the question of they are aware but not on ART. Fortunately, the number is not very big, but we still need to find out why they are aware and are not linked. Our programs have been working to integrate management of non-communicable diseases. One of them is cervical cancer screening. We asked women who turned out to be positive whether they had been screened for cervical cancer screening. This program was just rolling out. A quarter of them indicated that they had, and about 4% indicated that the findings were a bit abnormal. When you take the age group that is of interest, 30 to 49 years, fortunately, a higher proportion, 27%, had been screened, and about 4% indicated that the findings were a little bit disturbing. We asked individuals that were seeking treatment whether they had been told that they had any of these NCDs, and this is the distribution. High blood pressure, 2%. Sorry, high blood sugar. High blood pressure or hypertension, 7.3%, and the others, chronic heart disease, kidney disease, some tumors, chronic lung disease, depression or mental health, just about 1%. Of course, this is reported data, may not be necessarily accurate, but it just shows us an idea of the magnitude of comorbidities. Now, I just have 1 or 2 slides on PMTCT. This slide here is coming from PMTCT impact assessment. The MTCT rate, baseline, was determined to be around 2.1, 2.5. In Spectrum, we have slightly higher because we also estimate for populations that are outside of health facilities. Seroconversions were very few, so that the overall transmission rate stood at around 2.7%, again, lower than what we have in Spectrum for the reasons I've indicated. The lower table compares infant mortality among HIV-exposed and unexposed infants, and the story is there for you to see. 4, 5, 6 times higher mortality among HIV-exposed infants than those that were not exposed to HIV. Now, this graph here is reported data. On the left-hand side, we are talking of women who delivered within the previous 12 months. 81% indicated they tested negative. 3.6% said they were already aware of HIV, and about 1% tested positive, and all of them were linked, apart from 1%. We have a disturbing 13.6% who told us at population level that they didn't know their status in PMTCT settings. And we thought that we are providing treatment, or rather prophylaxis, to 100% of women. So this is 13.6% is disturbing. I want to believe that it is a reporting bias, disclosure bias, but there it is. Now, how about virus suppression? That's what we have on this other graph. Among women who were pregnant at the time of the survey, only 64% had suppressed virus. Of course, you know the risks there. Those who were never pregnant had slightly higher virus suppression. Those who delivered in previous 12 months, we found them having slightly higher virus suppression, and those who delivered at any time during the previous 3 years, it was. You can see a steady decline in HIV prevalence, and this is not incidence because we don't have adequate numbers for incidence, but it's as the girls delay onset of sex or their sexual debar, the HIV prevalence appears to be falling, and that is driving the total. That's not so much the case with the boys. I don't understand the story there. Again, the other problem, we have not conducted full regression analysis yet, but look at the danger of having more than two partners, two lifetime partners. If you're a woman, your HIV prevalence is 11%, almost twice the general population. If you're a man, HIV prevalence is about 5% or 6%, which is higher than obviously the average. And the total, again, speaks to that very fact. Obviously, we are going to analyze this data further, adjust for confounders, and come up with better explanation. High-risk sex or casual sex is having sex with a non-marital, non-cohabiting partner. This practice has persisted. About 45% of men and about 36% of women. And condom use among those individuals is not universal. It's actually very low. Less than a third have failed the B, and they're also failing but not failing the C. About 2/3 are failing the C. They are not using a condom, even in those risky activities. When you restrict this to sexually active age group, 37% reported sex with a non-marital, non-cohabiting partner, but only 31% used, or 32% used a condom. I'm glad I saw Mudiope here. I think we still have some work to rejuvenate our prevention programs, the behavioral component. This is how high-risk sex or casual sex are varied across the regions of Uganda. Northeast, perhaps very good, but condom use there, again, is not very good. So we have challenges across the board. I just have 1 or 2 slides on male circumcision, starting with the good news. When we conducted the survey 5 years ago, 42% of adult males were circumcised. This has increased to 54% by 2020. And there was increase across all regions. That's where the good news stops. And we ask, how about those not circumcised? Almost 45% are not circumcised, and in some regions like Karamoja, like Mid-North, like % are not yet circumcised. And that's where we saw viremia very high. So some of this data should inform local HIV prevention programming. This graph, I'm sorry, I have to apologize right away. I mislabeled the axis, about 30%. So again, we still have a big gap, and we must invest more in male circumcision. Why do I say this? We modeled what it would take to achieve what we call HIV epidemic control. And PEPFAR defines HIV epidemic control as that point where new HIV infections will fall below all-cause mortality among people with HIV. You know, if you have fewer new infections than the deaths, not necessarily HIV deaths, but all-cause mortality, because people with HIV die from many things: floods, road traffic accidents, gunshot wounds, earthquakes, everything, malaria. Okay? So if you take all that, so that new infections fall below that, then the number, this 1.4, will stop increasing. And before the survey, we had projected that we were on the verge of getting there. We had thought that between 2023 and 2024, new HIV infections would fall below HIV, rather all-cause mortality among people with HIV. Unfortunately, the survey indicated that we had been underestimating new infections. And so what we have now is this situation, which shows very good news: new infections falling, all-cause mortality falling. But we need to bend that curve of new infections more. So we have to bend that curve more to achieve epidemic control as we go forward. So to summarize, these two big studies have demonstrated that we have made a lot of progress in our national response. We have achieved high levels of viral load suppression. The coverage of many HIV prevention treatment services has increased. HIV incidence might have declined, but remains high and was previously underestimated. HIV burden remains more or less level, as would be expected, but we still have gaps in our HIV response, especially testing, case finding. We need to address that. Suboptimal coverage of many of our prevention interventions, including circumcision, behavior interventions, and others.
We thought we are getting towards epidemic control, and you are showing us that we are getting away from it. And we have many young people who are going to join, children now who are going to join that high-risk age group. So isn't it going to elude us even more? I think this is very worrying data. We need to, we'll have some discussion on that. So thank you very much, Dr. Wilfred. And our next presenter is Dr. Sabrina. She's going to present to us groundbreaking research on ending inequalities among young people. Dr. Sabrina.
I must say, speaking after Dr. Kirungi is very challenging, because what I'm going to say is not even groundbreaking research. My slides, please. I'd like to thank the organizers of this symposium for inviting me to talk about ending inequalities among young people. We've heard a lot about young people, and I'll just say that the new global AIDS strategy of 2021-2026 seeks to reduce the inequalities that drive AIDS, the AIDS epidemic, and puts people at the center to get the world on track to end AIDS by 2030. We know that there's been decades of experience and evidence from the HIV response, and it shows that intersecting inequalities are the ones that are going to prevent this achievement. We know the difference between love and hate, and the varied differences between love and hate. And these inequalities are what are going to drive this pandemic. We know that there's a lot of discordance, and discordance has led to further inequalities. We know that ending AIDS is actually possible. It's been 40 years since AIDS was announced, but we need a course correction to make this ending AIDS a reality. So as we say, stop AIDS, keep the promise. Each of you think in your minds, what are you doing about ending AIDS in your generation? We know that worldwide, 1.8 million adolescents are living with HIV, and sadly, 85% of them live in sub-Saharan Africa. 60% of those adolescents living with HIV are girls. You've recently seen slides from the OFIA report. This is an older slide. But in Uganda, there are nearly 1.4 million people living with HIV, and nearly 130,000 are adolescents. From the data that Dr. Kirungi presented, we heard that 50,000 Ugandans get infected with HIV on a yearly basis, If you translate that into days, that means that at least 150 Ugandans become HIV infected on a daily basis. Do not become a statistic. It's not ironical that we are seated at MOBS, a university, where a lot of sexual activity happens. So do not become a statistic. There are many gender-specific disparities, and I'll talk about these a little. The global scale-up of antiretroviral therapy has led to an expanse of HIV treatment and prevention across Africa. However, there are gender-specific and even age-specific disparities, which have led to lack of fulfillment in the Sustainable Development Goals. And here, I'd like to talk about the SDGs 3 and 7, achieving healthy lives as well as ensuring equality for all. There's a study that I read about done in Tanzania, which showed that young pediatric and late adolescent age groups are at an increased risk of late diagnosis of HIV, and we've seen that in the data from Uganda, early deaths because of poor adherence, and delayed treatment initiation. And we know that as long as there's delayed treatment initiation, there's going to be increase in transmission and loss of continuity in care. And males are likely to die earlier. Die because they don't adhere to their treatment, die because they do not disclose, and die because they don't go for testing. So we need to change that statistic as well. This is not new to all of you in this room. We know that there's been an evolvement of HIV treatment. When I started to treat patients living with HIV way back, maybe 23 years ago, we had to give our patients lots of pills. I still remember a little girl who was 8, and she had to take 15 different tablets on a daily basis. Today, fortunately, people need to take just 1 tablet a day, and isn't that improvement? There's a lot of need and possibility for people to adhere to their treatment. And currently, the test and treat strategy has ensured that when people are tested, they are started immediately on their treatment. But do they adhere? We don't know. The treatment cascade, even for young adults, includes first HIV testing. But we heard from the OFIA report that only 70% of Ugandans are tested. I'd like you to reflect, by a show of hands in this room, how many of us know our HIV status? When did you last test? Okay, so after testing, if you're positive, you have to be enrolled in care. And obviously, if you're enrolled in care, it's important for you to know that you must be on lifelong treatment. And this includes retention of care, but also ensuring adherence and ensuring that the supplies at the health facilities are present. This distribution of treatment at the Baylor Uganda Clinic was shared in 2020, and it showed that nearly 1% of our patients at the Baylor Clinic are already on third-line treatment. If people do not adhere, they are going to have to be on third-line treatment in larger numbers. Of course, the majority are on first-line treatment, and for those of you not conversant with the regimens, when people are started on treatment, they are put on a first-line regimen, and then if they fail on that, they are put on a second-line regimen, and then on the third-line regimen if they fail on that. After the third-line regimen, we'll have to refer you to a team that's headed by Professor Sali, so that they decide on if they put you on megahertz or on no treatment at all. And that should scare you. We know that adherence among adolescents is limited. Sometimes they fail because they are not adhering well to their treatment. And these are data from all over Africa that show that with increasing time on treatment, there's increasing lack of adherence. And there are many barriers to adherence. One of them is stigma. I was really happy to see Fiona and Priscilla coming up here to talk about their decline for stigma. And it is important for all people living with HIV to destigmatize. There's a lot of problems with poverty and side effects, even presumed side effects. I know patients who have come up and said, I think that if I take antiretroviral therapy, it's going to disfigure me. But that is not true. As healthcare providers, we will always monitor the side effects. Disclosure, as you've already heard, is a challenge, especially for girls. And disclosure is worse when the patient is older, if the patient is an orphan, if they are contributing to a family income, or if they have to do regular visits to the clinic. And when there is greater support with peers, there is less fear for disclosure. This gentleman, ladies and gentlemen, is actually a 16-year-old. I allowed him to sit on my office clinic computer to understand what antiretroviral therapy means for him. And if we increase patient knowledge, we know that it will also increase patient adherence. It's important to break down the complicated medical terms and break them down to a level that even a P3 child can understand the education surrounding why they are taking their antiretroviral therapy. Of course, there are other issues, including behavioral and psychological concerns, and then transition. At this time, I'd like to applaud Dr. Andrew Kambugu, who runs the transition clinic to date, a clinic we started in 2008. And we learn many lessons from this particular clinic. Transitioning, ladies and gentlemen, means that you move the children to the adult clinic when they become adults. I am a pediatrician, and I know that many patients don't want to leave our service. They want to stay because pediatricians, as you know, are very kind, motherly, fatherly, and they don't leave. But they have to leave. They have to leave so that they can become responsible for their own health and their own disease management. We know that it won't be possible in many of our settings because of structural, financial, and spatial reasons. The sexual and reproductive health needs for young people show that actually not all young people are having sex. And so we need to recognize that. However, those who experience sex early do it out of a result of coercion and violence. And this is a disparity and it's an inequality. And between 3 to 23% of adolescent girls and 0 to 13% of adolescent boys have reported sexual violence, which became intensified, especially during the COVID-19 pandemic. The sexual and reproductive health challenges for adolescent girls are quite obvious, but at the Baylor Clinic, we learned that the power struggle between boys and girls and men and women is real. Of the 420 girls who we studied who became pregnant, only 6% disclosed to their partners their HIV status. And yet 100% of the HIV positive male adolescents disclosed to their partners. This tells us a lot, that the power struggles result in inequality, even of disclosure. There is a huge unmet need for contraception. And this has resulted in many women having unplanned pregnancies and even pregnancies that are repeated. This lady, as you can see, has 2 children below the age of 5, and she's expectant. Many adolescents and young women in Africa are faced with economic, social barriers, lack of access to health care, gender-based violence, and an increase in their risk for unwanted pregnancy. And this also results in HIV infections as well as school dropout rates. I thought I should talk about mental health challenges. Celia Okoth recently in the New Vision shared a story where she headlined that nearly 1 out of 5 Ugandans are mentally ill. So if you count 1, 2, 3, 4, 5 in this room, 1 of 5 could be mentally ill. But when they talk about mental illness, it's not about throwing stones or running around naked. It's anxiety, it's panic attacks, it's depression. And as long as people are depressed, they are not going to adhere to their treatment. They are not going to disclose their HIV status to their partners. There's also the challenge of parenting children in the digital age. And this is a real challenge. Even as adults here in this room, people suffer from a syndrome called FOMO, the fear of missing out. And they are constantly on their phones, and not part of the solutions. And even when people are attending dinners and wish to disclose to their partners, they're probably talking to other people that are not with them. We've heard of the equivalence of undetectable equals untransmittable. That if people are taking their antiretroviral therapy properly, then they are not going to transmit virus. If pregnant women are taking their antiretroviral therapy properly, they are not going to transmit virus to their unborn babies. In Uganda, this was data from 2018, but now we've heard that 76% of Ugandans who are on antiretroviral therapy are suppressed. Yesterday we heard from Dr. Bagambe that nearly 200,000 Ugandans remain virally unsuppressed, and that should concern all of us. 17 out of every 100 pregnant women enrolled in PMTCT are lost to follow-up, and this gives a higher chance of their children becoming HIV infected. If we are looking at ending AIDS in the next 8 years, we are not going to be able to do this if mothers who are HIV infected are not adhering to their treatment. Many vulnerable people, there are many people who are vulnerable, and those are because they have personal and structural problems, and others are newly infected, and then there's non-disclosure. So we need to find solutions, and these solutions are going to include providing financial independence. I know that nearly 30% of Ugandans live on less than $1 a day, but we should try. And we need to provide self-support for adherence to medication and provide correct transitioning from pediatric services to the adult services. We need to push for the power of hope. We need to see that as a country, we are going to end AIDS within our generation. Recently, the Uganda National Academy of Sciences launched a report, and it was called Reimagining Being and Belonging in Uganda. It was really talking about equality and inequalities. And I'll just give you a summary of what we recommended in this report. It starts with data. As long as we don't capture data, we are not going to be able to have solutions. And then the second thing is that knowledge is power. As long as you're knowledgeable, you shall be powerful, and you'll be able to find solutions. Thirdly, it takes more than just me. It takes all of us. Knowledge helps us to empathize and appreciate the circumstances that people are undergoing. And fourthly, practice for better and not perfection. Whereas we are saying that end AIDS by 2030, that's an aspiration, and that's a desirable goal, but it may not be possible. And finally, that public goods are for public benefit. If you're a service provider in this room, please make sure that you're actually offering a service and not being corrupt. As I summarize, I'd like to say that as a provider for young people and children, we need providers who are knowledgeable. We need to ensure confidentiality and provide consent when we are taking care of adolescents. And we also need to cater for their socioeconomic issues, including how do we support them when they're in school, how do we support them at home, how do we make sure that their transportation problems are sustained. We need to empower youth living with HIV, with mental health, their mental health challenges, with their HIV care and prevention. And if you forget everything I have said, please remember the competency donut. And it includes respect, a non-judgmental attitude, and having skills and knowledge. I'd like to acknowledge my parent department of pediatrics, the management and staff of Baylor, Uganda, and then the organizers of this symposium. And I'll put a question to us again. If we are saying we must stop the AIDS epidemic and keep the promise, what are you doing as an individual? Thank you.
Yeah, I think we should give Dr. Sabrina a louder hand clap. Thank you very much, Sabrina and Dr. Chirunji. Now, I've been told there's some speakers who are here for the next session that we could move a little bit within this session because their presentations are very much related to what we're going to discuss now, so that we have them here. And then after their presentation, then we fire the panel questions all at once. So one of them is Stephen. Stephen, I think you can give us the other aspect. We've heard about the growing up. We want to tell us whether you're still growing. Or, so please, Stephen. You can have a seat there. And I'll also ask Dr. Martin Mudu, is he around? Dr. Martin? Martin was supposed to make, on NCDs and HIV. Is Dr. Martin around? Please come forward if you are. And then Advanced HIV Disease by Dr. Watch. Is Dr. Watch around? Yeah, please come over. So all you three, will ask you to keep time. We are going to compress you in this next session. Very scary country data. I think if I was in charge of the program, I would consider PrEP for all HIV negative young women who are breastfeeding, and consider, what else I would consider? Testing all young adults, and bring down circumcision to children, so that we do it before they get into trouble. Stephen, please. Dr. Watch, are you around? Please come and sit.
Okay. So good. Is it good morning? Good afternoon, everyone. I am going to talk about aging with HIV in 10 minutes, but it takes a lot of time to age. Those of you who have aged and those who are still young, you're going to discover it's going to be a long time. My friend, when I listen to Sabrina talking about pediatrics, I wish I could do that, but then, of course, I have to talk about the other side of it, of the opposite of pediatrics. My next slide. I always, oh, it's here. I'm supposed to do it myself. I always start with this because that's not, okay. Yeah, that should be the one. I always say this, and I know people get bored, but because many of the people think I am, one of my patients told me that, are you really sure you are on ARVs? Because or we have been paid a lot of money by the Americans so that we swallow this medicine. And so I always move with my ARVs. When time comes for swallowing, I show them to my patients when I have an opportunity and swallow so that they are convinced. I did my first HIV test in 1986, but I did not pick those results. Later on, I discovered we had HIV in our family, and I lost my wife in 1994. I have had the very unenviable experience of suffering from most of the very bad diseases like severe bacterial infection. And for one time, I had renal shutdown for about 2 days. And then I suffered from MDR TB. When that young lady talked about TB, I felt it, because I've suffered from TB about 5 times, including MDR TB. I've also suffered from cancer. I'm a cancer survivor. I had Kaposi-sarcoma. And I also did have cryptococcal meningitis. Those are the ones I can mention. But I've suffered from many other less formidable diseases. So it's by God's grace that I am here. I've been... and looking good, because if you see people who of my age in my village especially, they look quite spent. I've lived two lives really, because I've lived with HIV for close to 36 years. Next year in May, I'll turn 70. I have been writing since I started understanding HIV. I didn't write for publication. The first book, I wrote it for my daughter because I thought I was going to die. So I kept writing a journal for her. Later on, when I didn't die, I tried to share it with others. I also written another book, which is Conquering HIV. My personal experience, you can get it on Amazon, but I should have come with some few copies if you want, but you can get them. I am writing another one, which should be ready next year, Aging with HIV. I think I should say aging gracefully, because I think I'm aging gracefully. Now, as you have seen from the statistics, most of the new infections are among adolescent girls and young women, or young people. But again, when you listen to them, the medicines are working, and when you swallow medicine the way I swallow them, even if you have had a very difficult past like myself, you can be sure that you're going to live long. So I want to talk to young people, especially those living with HIV, that you prepare to live for a long time. Because, and prepare to live for a long time means you have to do the right things now. Because if you don't do the right things, like building a house, if you are going to build a storage house, you must dig very deep. So if you don't do that, then you may not be able to listen to me in 20 years' time when I come back here, when I'll be 90. Most of the people living with HIV are going to be older people. And so, because with the advances, I believe we are going to stop these pediatrics. So Dr. Sabrina runs out of business. But then the question is, where are the geriatricians? They are not there. Most of the time, I have to go to Mildmay, where I get my medicine, to pick medicine for older people, because they find it difficult to pick this medicine, and from children who, very nice doctors, by the way, who at Mildmay and other places. Then also the emergence of NCDs. It's that we have these diseases like the high blood pressure, the diabetes, and cancers, and depression. Now, talking about depression, this is a big problem. Yesterday, I was talking to an older person whose boxes are all ticked, the other boxes. Viral suppressed, he knows his data, he's swallowing, but he's depressed. And he came to me, one of the things he says he couldn't say at the clinic is that he now no longer can have sex. And this is disturbing him, but I said, but do you sleep? He said, yes. So why are you worried? Said, because if you go to bed and sleep, why don't you sleep? He said, but my wife, so, but anyway, he has used all these concoctions, Kamanayamba, but things have not worked. I remember what my friend told me about the sex try weekly, or you try to have sex weekly, or have sex but weekly the other week, W-E-A-K, weekly, have sex. This man is better, I can't even have it weekly. So he's disturbed. So he might soon join the group of people who are not suppressing. And his wife, who is not infected, might get infected during the process because of that. There are also the issue of long-term use of drugs. I've been on these drugs since 1999. Of course, a lot has improved. I remember the first regimen I was on was a saucerful. It was like eating binyogo. I was swallowing about 18 tablets. Yeah, but now it's one tablet which I swallow once a day, and now I'm told there will soon be injections. So there's a lot of what? But the truth is nobody knows the long-term effects of these drugs. And so in 20 years' time, you might see me having things. So the importance of pharmacovigilance is very, very important. And that's the reason why I want to leave quickly, because I want to join a group of people who are doing developing treatment literacy materials for people living with HIV. We must make sure that these people are empowered with the literacy. Then also lack of palliative care services. It's something that we must prepare, because as these people age, they're going to need to die eventually, but they need to be helped as they land. Like when you're about to land, they tell you put on your what? Stop doing everything, put on your, but where are these belts? We are not preparing them. Many older people are being given very futile, useless, and expensive treatments when what they need is actually palliative care. This is something that we need to think about. So we need to invest in health promotion, and this I want to talk about this to young people. You have to to avoid going to hospital. How do you promote health? How do you prevent disease? I know in HIV we have talked about preventing cancer, preventing TB, preventing depression. That's why I have so many friends. Everyone I meet, I want to be friends with them so that, and they call me so I forget that I have HIV. Sometimes I have so many friends, so many times. And all these services must be there as part of universal health coverage. Then my second last issue is the issue of stigma. You know, recently I went to talk to a group of people, and the person who invited me said, no, here we have no stigma. People are living very openly with their disease. And he was so happy. I said, then why did you call me to talk about stigma? But as I was going, another man who was sitting in front asked for a lift. So as we were moving, then he asked me, but your skin is looking very nice. Which one are you using? I said, why do you want? He said, I'm also on this treatment, but you know. So I said, but why didn't you say so? Here is a person who is on treatment, but he didn't want these people, and he was a big person, to know that they have HIV. So until we overcome this thing that makes people live in fear, people live in shame. People are more proud to talk about typhoid, that they are banzudem typhoid, which is a very shameful disease in my opinion. And they can't say that banzudem HIV. I mean, this is something that we should be working on. And then they are going hiding. This is something that we work on. We need to empower people and see what makes this. What causes this disease? And we have a lot of science. We know what causes it. How it spreads, we know it. When Wilbrot was talking about, I wish we could explain to this. In my mother tongues, in our mother tongues, how it affects the immune system and how eventually people die. Now when you hear, like Dr. Watch is going to talk about advanced HIV disease, the unit here, people are dying, and these are very important Ugandans. And they should know this. So where are we? Why can't we go and do this? So in conclusion, because I don't have a lot of time, I hope next time when I come in 20 years' time, you give me more time, because you're really talking about aging, and then you give somebody 10 minutes, and you give Dr. Kirungi a lot of minutes, which is very important. I think it's not fair. So until we have a cure, all people, and especially people living there, but especially young people, need to know that they are going to live and age with the disease for a long time, and therefore make right decisions. We must make the correct decisions. ART, antiretroviral treatment, is treatment for life. The problem is that when people improve, they know stop, I was almost dying, they go to eat life and they forget they are supposed to be on ARVs. We must invest in eradicating stigma, because stigmatized people living with HIV effectively live two different lives. Like this man who was in my meeting, I was talking to him, and yet he was not listening. The big man declared there was no HIV, but when no stigma, when I went down, so this man had two people in him, one who was not stigmatized. So, and this is, I think, a psychiatric condition called schizophrenia, when you have split personality, maybe. So we have so many Ugandans who are living two lives. And some of them are in very important decision-making places. So we must work very hard to do this. We must have as much social capital as possible. I want to say this, one of the things that really I think has made me live for this time, and I'm going to live for a long time, is because I have social network. I believe in prayer. So when the Chinese are sleeping, the Americans are praying for me. When the Americans go to sleep, the Africans are praying. So really, nothing can go wrong. And they sometimes call me when I don't look nice, say you're not looking nice, so they support me. This is social network. I thank you.
Thank you, Stephen, for that talk and for keeping time. So we can have Dr. from Chirudu. Dr. Watch. I hope you will keep time like Stephen. How much time? Maximum is 10 minutes. I'll alert you when you have 3 minutes.
Good afternoon, everyone. All protocol observed. My name is Dr. Darius Wachi. I am a physician working at Chirudu National Referral Hospital. That is a tertiary level hospital that provides specialist care, mainly in the medical field. So my field of work is predominantly internal medicine, or in other words, treatment of adults. I'm a bit different from Dr. Sabrina, who majors in pediatrics, that is children. So the adult version are what they call the physicians. So I am glad to be here to present to you part of the work we are doing at the hospital. We have a support program called the Advanced HIV Disease Program. It provides support to admitted patients who are living with HIV. We realize they're admitted with different challenges, different problems. So this program was started in 2020 as a collaboration between Chirudu Hospital and support partners including IDI, MJAP, with support from PEPFAR. So I think we have listened to different presentations about the impact of HIV in the country, and we still see lots of new infections taking place. And sadly, also, we see a number of deaths which are happening in the country. And I'm just going to present to you the story that's happening in Chirudu. I hope it doesn't scare you, but that we can pick some important lessons, especially for those in positions of influence. So we're going to describe what factors contribute to deaths in the patients who come to Chirudu Hospital, and if we can do anything to address that challenge. I've already explained it's a partnership between different partners, and the main objective was, number one, increase in screening for patients. So whoever comes to the hospital, we try and make sure we screen as many as possible for HIV. We also provide support in terms of diagnostic and treatment tests, and strengthening capacity for the health workers to support these patients. I will try to make the presentation as simple as possible. Some of the terms may be scientific, but I will explain along the way. So what we're mainly interested in is the deaths that occur at the time of discharge and what factors contribute to these. And from the data that we have so far analyzed for the past 2 years, from March 2020 to March 2022, we have admitted 4,200 patients. That comprises about 20% of the hospital admissions. So you can see the burden is still quite big. And I'll just take you to the images that are highlighted in yellow, where you see median CD4. That means majority of the patients will come in with very low CD4, and that's what we call advanced HIV. That's if the CD4 is below 200. You also see that a good number of patients are not on ART, so they're ART naive. And that agrees with the UFIA survey, where they found a good number of people, about 20%, are not aware of their status. So you can see that number also translates into the hospital admissions. Some people do not know their status, or they are not on ART. But also worryingly is some patients are what we call defaulting on ART. I don't know if that's the most current term, but they have interrupted treatment for longer than 3 months, and that is also another worrying trend. Nearly 25% of these patients are not on the ART. So this is also a point of concern to worry for the policymakers, for those who are engaged in providing care at the primary or community level, that we need to really increase our efforts to look for those who are going off their medicines and those who are not diagnosed. Functional impairment, was also highlighted there. The disease leaves a very big mark on the livelihoods of the patients. So these are patients who either come in bedridden or come in unconscious, so they need extra support from different people to carry out their daily activities. And you can see almost 40% are functionally impaired. Like I said, majority will have very low CD4. And this slide shows you the dual burden. I call it the dual burden of opportunistic infections together with non-communicable diseases. So 40% will have a dual infection with either an opportunistic infection, for example, tuberculosis or cryptococcal disease, but they might also have a comorbidity, for example, the non-communicable diseases. So the tide seems to be shifting from the opportunistic infections more towards the non-communicable diseases. And these are just the common conditions we see. Tuberculosis is still highly prevalent. It's the most common condition we see in the hospital. We also see sepsis and infections. These are non-opportunistic infections. For example, very bad pneumonias, COVID-19. We're recently dealing with Ebola, so it also falls under that category. And the third most prevalent are cardiovascular disease, such as hypertension or strokes. The outcomes, some of them are encouraging, but some are not. We still see lots of deaths. About 1 in 4 patients sadly will lose their lives. And there are a number of factors that contribute to this high death rate. The factors which are in bold are the factors that I want to draw your attention to. If a patient defaults on their ART, if they stop taking ART, their chance of dying is very high in the hospital. Likewise, if they are significantly functionally impaired. Now, functional impairment is a sort of a proxy indicator to show you how severe the disease has impacted on their livelihoods. We also see that such patients don't do so well in the hospital. The opportunistic infections, according to our data, don't appear to be contributing much deaths despite being highly prevalent. What we see is the burden is within the non-communicable diseases. That's where we need to put more emphasis on. Conditions like malnutrition, kidney disease, liver disease, anemia, sepsis and infections, including COVID-19. All these factors had a very big impact in determining whether a patient lives or dies within the hospital. Mental illness, for some reason, was protective, but I think the teams in the mental experts will help us to understand if that is really a true picture. So what have we done for the hospital? So we identified CD4 undocumented status was an important contributor to the mortality of these patients. So we embarked on increasing the CD4 coverage. It was very low at the beginning of the program, but gradually over time it has increased. The current coverage is about 90%. And we also see it has had a positive impact in reducing some of the deaths that occur at the hospital. So we believe CD4 shouldn't be forgotten, even in the primary hospitals. We should continue doing CD4 because it can help, it helps with the diagnostic algorithm, helping clinicians screen for certain infections, and in that way they can be able to avert some of these deaths. We are also focusing on ensuring those who are discharged return to their hospitals, return to their clinics where they're getting ART, and we have increased the linkage and linkage at discharge to above 95%. So we hope the patients actually return and continue remaining in care, because we see that those who default tend to have very bad outcomes. Majority return to their primary health centers, 90%. About 10% remain with us in Chirudu. At discharge, the patients determine which center they want to go. So we ask them, would you want to return to their former center or would they want to change? So it's based on their choice. So as a summarize, I just wanted you to appreciate the burden of disease. There are lots of infections, but also lots of non-communicable diseases. We are short of some of our targets. For example, those who are unaware of their status or those who are dropping out of care. These factors seem to have a direct impact on the survival of patients. And we hope by addressing these factors, maybe we shall reduce the deaths which occur in the hospital. So we encourage you continue following up those who default on their ART. Please re-engage them in care. Let's look for those who are unaware of their status so that we can start them. If we start treatment early enough, we can avert some of these complications. We also screen for those who have comorbidities. If it is not routinely done in your hospitals, this would be a chance to start doing it. If we can detect most of these conditions early enough before they result in end-stage complications, it really improves the survival outcomes of patients, as well as not forgetting to screen for the common infections such as tuberculosis. So this is the last slide. Some might say the findings may not be generalizable to all hospitals, which we agree, because the hospital is a specialist hospital, so it's going to predominantly receive referrals from the community centers. But what we're telling you is the patients that you refer, these are the risk factors that we are seeing, and we hope that you can address them at your places of work so that you can reduce the deaths that we're seeing in the tertiary hospitals. Yes, I want to appreciate the different stakeholders who have supported the hospital and supported the admitted patients. Thank you very much.
Thank you very much, Dr. Wachi. As you go, did these patients fall within the risk age group, or are they older patients?
Sorry, majority between the age of 30 to 50 years. Those are the patients we are seeing. We don't see very many adolescents. I think that may be a good thing, but we hope we can reduce the poor outcomes that we are seeing. Right, thank you.
Good. So thank you. I would like to say thank you. Can you give him, Dr. Wachi, a clap? So I think we're now open to questions. We've had the whole spectrum. You have had the whole country data. You've had the adolescent data. You've had the experience of aging on treatment. And also you've had what happens when patients wait until they are just carried to hospital. Dr. Wachi's patients are largely brought to hospital. So that's why we're having these bad outcomes. So we'll invite questions. MC? Yes. Can we take, yes, Andrew, take, and then Reverend, and Lydia will take a question from you. There's a gentleman at the back there behind the camera. No other questions? No other hand? Okay, and there's a gentleman in a gray jacket at the back there. Yes. Oh? Oh, and they are also, so that one you'll take advantage. Okay. So Andrew, please.
Thank you very much. Andrew Kambugu from IDI at Makere. First, let me congratulate the organizers for a really nice blended session with great First, a clarification. The 1 in 5 that don't know their status, is it true that you corrected that statistic based on the findings of ART in the blood? Or is the 20% before the correction? Second question, I was struck by the association between circumcision and viremia and the risk of transmission. The question is, for status of circumcision, were you having a PEEP or was it self-reported? Thank you very much.
Thank you so much for the presentation. Mine is Dr. Kirungi. I'm called Henry Magala. I work with HF Uganda Cares. In the conclusion, Dr. Kirungi highlighted that the new infections, incidences that you are experiencing among the adolescent girls and young women could be because of gaps, HIV response gap. And so I want to raise an issue of policy. We all know that we had sexuality education in schools. In 2016, Parliament of Uganda, threw it out. And so, however, I think last year, Chief Justice Lydia Mugambe ruled that it's appropriate that our young people are empowered with information that can help them take care of their lives. And I think the emphasis is giving, they should have appropriate, age-appropriate information. So we want to know from that time what has taken place, because Minister of Education was asked to, come out with a policy that guides, sexuality education in school and out of school. This could be the reason why we're having young girls coerced and, sex predators are also, everywhere. So this could be the reason. So perhaps Minister of Education officials could be here to highlight us on the progress on this. Otherwise, I think it's a policy gap that you're observing. Thank you.
There was a gentleman at the back there. Oh, Reverend, please, Reverend. Raise your question.
Thank you. The question is that the 4 presenters, is there a possibility of reconvening? And they are bringing them, 2 more, they are bringing it to 3 more on the panel. From the legal expert, the religious leader, and the cultural leader, to discuss the cross-cutting issue of stigma. Because, Professor Chair, we have an issue. People think stigma is something about social structure. We've not gone, if you study the presentations, you can even see that basic science and how they present the data can help us into that problem. Yeah. I still, 40 years later, I still find it problematic for science to present that just having one wife or one woman or one husband is a protection. That could be a good indicator in low prevalence countries, but not in here, where you don't even need 2 people. One person is enough. First sex, first infection, first night of sex. So we could really examine and say, this variable that makes people think you are positive because you have had a second pattern. And then stigmatize this whole issue about casual sex. Casual sex means a sex you have had with a non-married person. When actual casual sex is any sex you have had without putting HIV in consideration. Correct. That's a casual sex. You've not calculated the risk. You've not prepared yourself for the risk. You have not, And so for us who use condoms correctly and consistently are blamed for promoting immorality.
when actually we should be one of the first people to be awarded in the response.
Yes.
So there is a gap. I'm seeing the same gap also in the discussion around the key populations. Men having sex with men. It's not a man having sex with a man that causes infection. It depends on the knowledge, the consciousness, the competence, and the resilience of the man having sex with the man to protect themselves and their partners.
Yeah.
The same thing with the commercial sex workers. Otherwise, we would have the same prevalence levels in France. But because the conditions of commercial sex work here are dangerous, are not supported, the legal environment is difficult, we have unsafe commercial sex work. So the problem is not commercial sex work. The problem is how that work is done without supportive environment. So I would really love a day when Wilbrod, you combine a group and say, can we do a multidisciplinary study on stigma? And we inform one another so that the behaviorist, the biomedical interventionist, and the structural drivers interventionists are speaking to each other. We are sitting here right now when last night something happened. People in the legislative environment are still not convinced that there is something called an deliberate transmission. They still think if I'm positive and I have given the virus to someone, I am to blame. Instead of also looking at this other variable. I'm sorry, Mr. Chairman, I've taken a long time.
Yes.
But this is something I'm requesting, that we cannot continue singing about stigma, 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 without really addressing the cause. Where is it coming from? I'm Dr. Chitaka finally. You are a person who is treasured everywhere. And I don't know, your Twitter handle must be having a million people plus. Can you kindly help us and put across one new message that we have a situation in the country where people are engaging in sexual behaviors that are as unsafe as they are unlawful. So people know that there are two issues being involved. It's not just that you have had sex before marriage or outside marriage. It's that even the way you are having it is unsafe, and people have to protect them both ways. Thank you.
Thank you, Reverend. I think you've provided us with actually some solutions, and also you're providing us with some key issues that we need to research in, again, to find more precise solutions to these issues. Lydia, I think, oh no, there's a gentleman there at the back. Please raise your question. Yes, he was. I counted you. I still, no, Lydia, I still have a good memory.
Thank you.
Sometimes.
So my name is called Lokonga Mesha, the coordinator of people living with HIV/AIDS in Napaka district. Yes, I'm appreciating the organizer of this special occasion for this day, and also the presenters for having taken us through. Yes, it is good and fine to share the situations around. I want also to appreciate our Pili Lutaya for making us celebrating his advocacy activities today. Yes, we are able to be alive today because of Lutaya advocacy. Because during his days, drugs was no longer there. But after him, drugs became in place. So we are now fulfilling our lives. Okay, what I want to talk about the vulnerability. So I already talked about the much vulnerability among the people living with HIV/AIDS at the grassroots level. The question is, how can we help these vulnerables, and when, and who can help? Why do I say like that? Because most of the partners, when they come at the grassroots, they target on the side of sensitization, prevention measures, but there's no budget for supporting the vulnerable groups. After when we synthesize, we teach, we do what minor supporting. As I talk now, when I was leaving from Napa, so one of the expert clients was reporting 2 death reports due to hunger. Now when we go on teaching and doing that, when people are dying, now what shall we be doing? Thank you.
Thank you. So we'll have 2 very brief questions. One question from Lydia, one question from Major Baramira, and we'll close the question session. We'd like to get responses to the questions that have been raised. Please be very brief with your question.
Thank you so much.
But I had not chosen you, had I? I think it was here, the chair. Please give the mic to Lydia. We'll give you another opportunity this afternoon.
Excuse me. We needed to hear a voice from a young person.
Yes.
But I was the first. I know my number, so let us follow the line, please.
Please, let's have order, young people.
Yes. No, let me tell you that for me, I'm a human rights activist, so when I know my number, I know.
So Lydia, be brief.
And doctor, really, you are cutting the time for some of us, and yet others asked questions. I will catch one of my questions, but I think I have a right. I want to talk about the mothers. And Dr. Chirunji, you always give these wonderful statistics, but sometimes I ask myself that I wish you'd give the statistics and some of your proposals and recommendations together with them. Many mothers are turning HIV
Lydia,
positive.
please face the camera.
Many mothers are turning HIV. We have a worrying number of mothers who are turning HIV positive when they are breastfeeding. And I really want to say that while we're talking about this, the Ministry of Health needs to consider what the reason is. And one of them, of course, very important, is disclosure and how we are going to handle disclosure. Because these mothers are tested, when they're in antenatal, and they haven't disclosed to their partners, so it's very difficult to take treatment when a mother has not disclosed.
Right.
So we need to do a lot of more sensitization in the community and working on disclosure. Of course, I'll end with my very big one. The other issue is mental health. And one of the issues and one of the problems is that diagnosis of mental health is a problem. Those percentages you have put up there for mental health will not work when most of us don't know how to diagnose mental health issues. And this one, we need to do a lot more sensitization amongst the community, amongst the health workers. That's all.
Okay.
Geriatric care. I've got 2 more points. Geriatric care is lacking in this country, dealing with older people. Because however much you talk about caring for them, we don't have geriatric care. And lastly, the issue of male involvement. I'm glad Dr. Mudiope is somewhere here, hiding somewhere behind. He's on the Male Involvement National Technical Working Group in the Ministry of Health, because we need to do a lot more to engage men, and that's where each of your presentations brought out these issues. Thank you.
Good. So I'll have Major Ramira, please be very brief with your question, and we'll have the last question from the young person, and we'll close this for responses.
I want to first applaud Professor Nyamusha for his comment. The problem is not the act of sex. The problem is how much do we know we are causing a danger by having sex in the way we have it. I also have just a small issue on the pre-exposure prophylaxis. Now, it sounds good, and in the context of HIV, it is very, very right. But what about the context of the social norms of society? where you prepare young people, give them medicine to go and have sex. And we are Christians. And in the Bible they say, thou shalt not commit fornication or adultery. So we have issues. It's not only the thing about HIV, but it's also the societal behavior. That's why you have this problem of stigma. Stigma is caused by fear of certain people, because certain people also fear them, because they think they have an issue that is a problem. That is why I have always insisted, why don't we take HIV to the home states, to the homes, discuss with the families, because there is where education starts for health. Whatever else you talk about, education starts at home. Thank you.
Thank you, Major Bamira. Last question from the young representative.
All right. Greetings, everybody.
That's the last.
Yes, all right. Greetings, everybody. All protocol observed. My name is Emojel Trevor, the current reigning Mr. Y Plus Central, and I'm very honored to be here. So I'll go straight to my questions. I have two questions. Last year, I had the honor to be able to go to Parliament and have a one-on-one exchange with parliamentarians of the HIV committee. But my major observation was, we have an HIV committee, but most of those people on the HIV committee are actually negative, and yet they handle issues that affect us directly. So my question is, what plan do you have to have more inclusion of people living with HIV in governance or in active leadership of their own matters? So my second question is, I hear my question actually goes now to Dr. Sabrina. You're talking about how young men living with HIV are more likely to die earlier than, let's say, the female counterparts. I personally work in a facility and I've experienced this. Men or boys in general are less likely to seek services than their female counterparts, which means men are actually going to have higher viral loads. They're actually going to be sicker or have more issues than their female counterparts. So my question actually is, what interventions do we have to cater for males to enable them to catalyze their need to seek services, to encourage them more to seek most of these services that are actually missing? Because when you look at the chain, men are sick and they are the ones that are in the chain of spreading the virus. One man can give to about 6 ladies, and then you find that it continues spreading. So those are my two questions. Thank you so much for listening to me.
So thank you very much. I think questions are now open to a panel. You can answer the questions that you feel very comfortable with. Oh, you? All right. Ladies first, okay.
Thank you, Trevor. My son is called Trevor as well, so I was really happy to hear you also called Trevor. We know that men are generally a neglected population. Right here, I'm sitting among men, but the usual would be many women and just one man today. So Uganda, we need to rise up. It's good that we're encouraging female engagement. We are also doing a lot of engenderization, but we should not forget about the men. The boy child is at risk of dying. The young man is at risk of dying. The older men are at risk of dying as well. So we need to do something urgently. In adolescent medicine, we teach a course called Young Men's Health. And the first thing we usually do when we are doing a training is ask the doctors if they know the details of their male sexual organs. Starting from the head to where the prostate gland is, 50% of the doctor students fail that question. So men in this room, doctors, activists, healthcare workers, please understand that men are at risk of dying. And they are at risk of dying even from when they are created. In utero, there are studies that show that the Y gene is weaker than the X gene. So we need to actively support this population. So what interventions are we doing? We are doing training, We're encouraging peer leaders, just like you, to come out and support the men. We are encouraging men in their football clubs as they are watching Chelsea versus, which team beat us? So that they discuss issues that concern their health. We know that women are more likely to go to hospitals because women become pregnant, girls get dysmenorrhea, they are likely to go to the hospital. But men are generally healthy. So when men are faced with issues of chronic care and illness, they are likely to say, we will not go because we are the stronger population. But there is strength in being weak. So men need to understand that by being weak and going to the hospital, they're actually being stronger. I think that was the only question I had. Now my question to Dr. Kirungi. You mentioned that if ARVs were found in the blood, then these people were deemed to be HIV positive. HIV aware, but also we know that there are people on PrEP who are not necessarily positive. So how did you correct that?
Okay, thank you, Chair. I have quite a number, so I'll try to run through them very quickly. But before I do that, Mr. Chair, I will seek your indulgence. I skipped one slide, the last slide, and I very much apologize, but I would want to seek the indulgence of those guys handling the equipment. As I respond, if you could just help me and screen the last slide. This data, I never collected it alone. I forgot to acknowledge the many institutions that supported this work, or these two surveys, UNICEF, PEPFAR, CDC, and all many partners, ICAP. So I'm really sorry that I forgot. I was intimidated. I thought I was running out of time. Thank you for that. I also want to start by thanking Dr. Sabrina. I think in her presentation, she helped me highlight things which I left out because of, I had little time. I knew I had 20 minutes. She brought out the issue of unmet need for family planning. This is a real issue. The PMTCT impact assessment highlighted this very well. Incidentally, the report for the impact assessment for PMTCT was already published. You can Google it up anytime, read it. You will see the extent of unmet need for family planning. She also raised the issue of mental health. We assessed mental health in the population survey. We had a screening tool for some mental health. Of course, people with no cognitive ability, we did not interview them, but those that passed that test, we had a screening tool. And if they tested HIV positive, then we checked association with, for instance, adherence, and we have some results about that. And clearly what she raised is what we found. When the report comes out, you'll see the association between mental health and adherence and outcomes of treatment. Now, turning to the questions. Yes, Dr. Kambugu, you indicated that, did we really correct for presence of antiretrovirals in plasma? Yes, we did. So when we are working out the cascade, if you told us you don't know your status, and yet you found the ARVs, we overruled you. So we adjusted that. So the knowledge of status in the cascades is based on either you're telling us or not telling us that you know your status, but we found ARVs. Because we know, how else did you get these ARVs? Surely not from mineral water, not from salt, so there must be a reason. Now that leads to what Sabrina has asked toward the end, if you're having PrEP. Now I indicated, in the presentation I indicated that we tested for 4 ARVs, and none of those currently fits the algorithm, the regimen for PrEP. Yeah, so we had to overrule the reported status if it was discordant with our biological finding. Dr. Kambu, again, you raised the issue of VMMC. Did we confirm? Unfortunately, we didn't confirm. We took the reported, but of course we know that's an undercount, because even when someone thinks that they've been circumcised, especially the traditional, and sometimes it's just a snip. You go to a traditional surgeon and he takes a snip, not removing the whole prepuce, and then you walk away thinking that you're circumcised. So observation would have been better, but this was not possible in the settings that we had. So we might actually be underreporting the coverage of circumcision. Sexuality education, I think I will steer clear of this question. I will just make one statement. That obviously sexuality education has a very, very big place in the fight against HIV and also generally. But I know there was some controversy around some materials because I think the content went a little beyond what was considered acceptable and was not launched. But otherwise, I think the Minister of Health, the Minister of Education, all of us agree that sexuality education should be promoted. I think we just need to have consensus on the content of that. I may not have the latest information. Perhaps the DG USA at one point will just make a comment as we go along. Now, I like the discussion raised by the Reverend Canon Biamugisha and Major General Rangaranga about, finding these findings. But let me be clear. I kept talking of association. I did not talk of causality. When I said there is association between casual sex and HIV or multiple partners and HIV, it is saying that's what we have found. There is an association. If you had more than one partner, you are more likely to be HIV positive than one who had one. I'm not saying multiple partnership is causing that. It's just association. And we have not regressed, because if we did additional analysis, we may find that the explanation may be something else. It could even be age. Maybe those with more partners are perhaps older, or maybe they are residing in rural areas, in urban areas. That could be the risk, not the age itself. But the association is what it is. And why did I share that, knowing that there is that limitation? It's because for our programs, if you are testing individuals and you want a high yield, somebody tells you he's had more than one partner, that should be a candidate for testing. Although the multiple partners may not necessarily be the cause. So I'm not talking of causality here, I'm talking of association. In other words, this is what we found. We need more discussion. We need more analysis and more discussion to find out what is causing this. So that is the limitation I can say about that. Again, somebody raised issues about pregnant breastfeeding. So breastfeeding mothers and HIV acquisition. And again, let me state this. Because of the design of the impact evaluation, we started with women who have brought their children for immunization. If we had started with pregnant women, we would have also found new infections among pregnant women. So, but here, we just presented about breastfeeding. And I did not go beyond presenting the data to give recommendations. I wanted this to be a discussion. What should we do about this? This is a finding. What should we do about this? From the minister's standpoint, we already have some policies. High risk pregnant and breastfeeding women, we're recommending PrEP. But we are not going to give PrEP to the 2 million pregnant women in Uganda. That may not be affordable. So who is this high risk pregnant woman? I think that discussion needs to happen. And then what do we do about the others? Because we have already seen, the data has shown us, they are acquiring new infections. So what can we do about that? Repeat testing is one thing, but then when you do repeat testing, you are actually picking those who have been infected. Fine, you do something about it to prevent vertical infection, but the infection has occurred. So what can we do? For me, from my point of view, that's why I asked a rhetorical question. These women are breastfeeding, for goodness sake. They've delivered. So why don't we leave them alone to finish breastfeeding? Why are the men disturbing them? Leave them to complete the breastfeeding. You'll go back to them when you need another child. Mental health, I think we've talked about that. Male involvement, it was referred to Mudiope. I think at an appropriate time we will comment. But again, if you look at the report for PMT City Impact Evaluation, the limited male involvement is well documented. You'll be able to find that. Now for PrEP, I do not understand what the Major General was raising, but yes, I think when we give you
a tool. Major General, you're a soldier. When we give you a gun, we don't say go shooting everybody. You know, it has a role, it has limits. So if we give people prayer, I don't think we are telling them that's go and have sex. But we are picking those that are having sex in a risky situation, and we are trying to protect that. Obviously, if they can abstain, the better. But the ones that we give in prayer, they're already not abstaining, and we are not convinced that they are going to start abstaining tomorrow. Thank you, Mr. Chair.
I wanted to talk to the young man, but unfortunately he has gone out. But let me still talk about the issue of advocacy. And then, of course, he mentioned the issue that he was interfacing with the parliamentary committee, and all of them were negative, which I don't know how he tested them. It's difficult. I think as for living with HIV, we have to work with people not living with HIV, or people living with HIV but not open about their status for various reasons. For those of us whom God has given the grace to be able to talk openly, I think we should not assume we are the only ones talking. I get amazed at people testimony telling that I've helped so and so, but of course I can't come out the way you have come out, and I respect that. I think they're doing a lot of work. We need to work together. We need to push this animal together. And I want to say especially my brother and mentor, Canon Gideon, we who come from the side of faith. You see, our friends from the other side, they are sure they know it, that it is demons pushing this. He's saying maybe it's hormones pushing this. And then you're saying it's ignorance pushing this. And he's saying it is the viral load not being suppressed pushing this, but it's all these. So we need to bring all these. Indeed, hormones may push you, but if your viral load is suppressed, you will not transmit HIV. And indeed, they are demons. Let's accept. They are demons. So these people also, we need to listen to them. But we therefore need to agree. The problem we have had is that we who think we have seen it, we think this is it. And that is why we have lost this. But on the other hand, we have done fairly well. We are doing very well. That many people are not dying as much. That's why I'm able to talk about aging and promising to come back here in 20 years' time. Because I know there is a future. So this is the message. I think the big problem we had is the issue of, when I first listened to adverts by what? Major. It was about death. But thank God now we are not seeing this. We are talking about hope. Do we still need to scare people? Yes, we must scare them, but we're not scaring people for it. It is not sustainable. That's what I wanted to say. Thank you.
I think yes. Okay, take on.
I don't think I had any question addressed to me, but I sort of appreciate everyone for exchanging ideas and for the message to reach home that the fight against HIV is still work in progress, but I hope we can increase the effort everyone puts in their part so that we can bring the epidemic under control. That's my message. Thank you.
Thank you very much. Can we just give a very loud clap to our panelists today? Thank you very much. We've had actually 3 sessions in one, but thank you very much. So I think we can have the next, maybe the last. The next session chair, I think, is going to. Do we have another session chair? Where is she or he?
Thank you very much for that wonderful session. I think our chair deserves another round of applause. He has done a tremendous job running. How many sessions? 3 sessions in one. And we do not take that for granted. Those were wonderful discussions. So the arrangement that we're going to do, we are going to have our sessions continue running. However, we cannot break fully for lunch. So it's at that point that I'm going to request we continue with the sessions. If you feel you're so hungry, feel free to step out for a short while and come back, then you'll find us. We are doing that to save time. We are all aware that yesterday we were a little bit caught up, and we wouldn't love to leave other sessions unattended to today as well. Just a reminder, as I'm calling through the next chair, our conversations are online. Follow the conversations through hashtag EndAIDS2030UG. But also visit the Twitter handle of Uganda AIDS Commission to follow the conversation. The session chair for the next session is one person that most people have interacted with. She is the executive director of Nafofano, Madam Stella Kentusi. You're welcome. She will lead us in the next session. I'm very sure you will like it, so don't worry about having missed out on lunch, but you can still step out. Thank you very much.
Thank you very much, my fellow ED. We've had doctors, so the teacher is now in the house. So welcome, welcome, welcome. We are going to have back-to-back. And therefore, as a few of us go out for lunch, I hope we can do it in an orderly manner so that we don't have many people going out at the same time. So we are going to have a few presentations here and there, discussions here and there, so that we do not also cheat our afternoon session on filial tire. So I call upon my co-chair, Dr. Mugaga, the richest man in the house, Dr. Mugaga. He works with the World Health Organization. He's in charge of care and treatment. I would also call upon Dr. Andrew Kambugu to come over. He will be the first to make a presentation. So from there, we're listening to our pre-recorded presentation, which we should have had yesterday from Ms. Anne Gizuk Shongwe, our regional coordinator. Then we'll have Dr. Shaban coming in, briefly to talk about the legal, environmental, and environmental assessment report. And then again, because we want to really catch up on time, we are able to consider our panel discussion. So may I call Dr. Mugaga to come over. Dr. Kambugu, please come over. And then the IT team, let us have the first presentation from Dr. Kambugu. Dr. Kambugu is here on behalf of Professor Barnabas Nawange, who is the Vice Chancellor of Makerere University. Thank you for being a dangerous substitute. So, colleagues, one announcement, please don't go for lunch yet. They will come in, give you a coupon, so that we have an orderly way of getting out to go and eat. And please, when you go, come back within very few minutes so that we don't miss out on the nice things that are lined up for you. So, IT, I hope we have our presentation ready. Okay, thank you so much. Role of research in ending inequalities among young people, the experience of Makerere University. Thank you so much. Over to you, Dr. Kambugu.
Thank you very much, the chairs of this session. On a very personal note, when I got the opportunity to lead the IDI and needed to be grounded by somebody from the communities, I was directed to Stella, and we had a very great conversation, and in a true African sense, she invited me to lunch. So, Stella, thank you so much. The board members of the Uganda AIDS Commission who are present, including the Honorable Aliek, the Director General of the Commission, our senior colleague from the Ministry of Gender, our mentor, and also once a board member of the Institute, Reverend Canon Professor Byamjisha, colleagues from UNAID who are present, other agencies, colleagues from the ministry represented by Dr. Chirunji. I would also like to recognize Dr. Sabrina Chitaka, as you will hear. She has many key roles at the university, some of them touching on research. I recognize you. Other implementing partners and all protocol observed. I was tasked by the VC himself to represent him at this very important meeting. And please permit me to convey congratulations from him to the Commission for reaching the 30-year mark. You will recall that the university has been celebrating 100 years, so I believe the Commission can borrow from the university on how to make it to 100 years. In the same breath, allow me to congratulate the Commission on zeroing in on a theme that I think is fitting, and as the data from Dr. Wilford Chirunji has shown, we are right on the mark. And therefore, as a Commission, I want to thank you for playing your alignment, coordination, and direction role in the national response. Already you can see the benefits. I should, however, provide a disclaimer that I am a member of the organizing committee, but I want to reassure you that I had nothing to do with influencing the decision for this theme. Before I go into my presentation, permit me to also recognize and salute Fiona and Priscilla, the young women who have had the courage to share part of their journey. I also took note that they mentioned that they've been served with love and dignity from the Alive Medical Service. I wonder whether my colleague from the Alive Medical Service is still here to stand up for recognition, for treating our young people with love and dignity. Thank you very much. So I hope I can navigate this now. All right. So I have to say, to be delegated by the Vice Chancellor to be here is a career milestone. And I have also to say that looking at the program and realizing that I've been assigned 20 minutes for this topic on the role of research has been a challenge. So I will borrow from Dr. Wilford's disclaimer, who said, please forgive if there have been some oversights. I have taken my 20 years of programming experience in the field of HIV and applied it to this question as best as I thought. So I thought I would show you the roadmap that we are going to follow. I will make reference to the UNAIDS Global AIDS Strategy, and I think it's appropriate since that is the global body that gives direction. And also, Dr. Chirunji, as I already highlighted, I will be giving some highlights of the UFIA, because as you know, UFIA is self-research, and I think it's the initial contribution to the response. I'll also give some context about the 100-year celebration that we are having at the university as part of the context, so that we see that the university has already been contributing and will only be focusing now on the area of these vulnerable populations. Finally, in my career, I have championed data science, the use of data, and how we can harness it, and hopefully we can also use this in the fight against HIV.
So it's appropriate to recognize the global AIDS strategy and in the same breath realize that the current executive director of UNAIDS is a countrywoman, and I think we should appreciate that observation. And I know all of you can read this statement, so I'm just going to highlight one or two words. The one word I want to highlight is bold and new. Dr. Shirunji showed data that shows that the curve is not where we want to be. And the business as usual as we know it is not going to get us there. So the UNAIDS director, through this global strategy, is telling us that we need bold approaches, and I hope as I give my talk, I'll give you some of the bold things that we are doing as part of the university, as an institute dedicated to HIV and AIDS. And also the last statement, prioritize people who are not yet accessing life-saving treatment, including those in the UFIA survey who are not even aware about their status. So you may not be able to see this framework that is in that global AIDS strategy, so I will help you to walk through it. In the center, we are being encouraged to look at the response through the lens of inequality. The data is showing some inequalities, as we will see. So we need to do some root cause analysis. And I think Reverend Canon Biamjisha was alluding to some of these. Let's get to the bottom. The most encouraging thing about the guiding framework, ladies and gentlemen, is that it provides for research and science as a cross-cutting issue. So I don't know if you can see. There is a quotation on the left side of the slide that talks about science generating new products, new technologies, and also highlights a role for innovation. So, ladies and gentlemen, this talk is very easy for me because even the UNAIDS framework already provides a role for science. So our role is really to follow through. So now let me turn to some data coming out of UFIA. And Dr. Shirunji has already made my life very comfortable. So here I want to highlight the disparities, the inequalities. And Dr. Shirunji has already told us the disparity by gender, up to age about 50. So we can see that at the different age bands, for HIV prevalence, that is people who are already living with HIV, we see that women are clearly more affected. This is also true for new infections. All of us should worry about new infections. And all of us should worry that it is our sisters who are getting new infections. So even as we talk about the role of science, the issue will be how are we targeting these young women, protecting them where we must, and also providing treatment for those who are infected. So this has already been covered very well by Dr. Chirunji. And it's also nice to build on the existing momentum of the good news coming out of UFIA. So this is a regional analysis. Again, Dr. Chirunji showed us this slide, showing that we have made great progress. And as a leader of an implementing partner, I'm very proud of this slide because it means we've not eaten the money. The money is going to the purpose. And even though we are not yet there, we are well on our way. If you're familiar with the 95, 95, 95 cascade, what it means is that the number that we should be targeting is about 87%. So in 3 years, we moved from about 60% to about 75%. We just now need to work innovatively to go to the 87% mark. One of the challenges is HIV testing. HIV testing is the entry point into the HIV cascade, whether you're positive or whether you're negative. And so I think highlighting this slide again is a very important thing, as I will show. If we have 1 in 5 people not knowing their HIV status, I think we have a problem, and I think it means that business as usual for testing is not going to get us there. So I will be highlighting some of the approaches we have been using to find these untested individuals. And so again, we need to close that curve, and I won't spend much time on this because Dr. Chirunji explained this. So in terms of what the data is telling us, and let us remember that euphoria is really research. Dr. Chirunji mentioned rigorous methods. I hope you're able to see how careful they were. I hope you noted that the study went through a regulatory process. It had to be signed off by IRB. So already research and science is contributing. So what is the data telling us? Because the data is the initial point. We need to find cases of HIV. That's a primary task. We need to do something about the coverage of HIV services, and we need to address those persistent gender and regional differences. So this is setting the stage for where can science then contribute to the response. So you will notice on my coat I'm wearing a commemorative pin for Makerere University at 100 years. And I should also mention that I'm a proud alumnus of Makerere on 2 occasions, both at undergraduate and postgraduate. I suspect that there are many alumni. Should we do a show of hands so that I convey back to the VC that I was in friendly? Thank you very much. So I hope over the next few slides I can make you proud of your institution. I've really, in my leadership role, have been reflecting a lot on the role of institutions. And on the centennial dinner for the 100-year celebration, we had a talk by Professor Ezra Suruma, who really highlighted the issue of institutions and why we need to treasure them. So I hope that I will convince you that the Commission and other institutions, we need to take care of these institutions, just like we take care of children. We need to nurture them, we need to treasure them. So on that note, I hope you will be proud and will commit to nurturing Makerere University. So the university has celebrated 100 years. Those events are still ongoing. And I want to highlight the role the Vice Chancellor has played in focusing on Makerere as a research leader. So traditionally, the university has 3 roles: research, education, and service. But I want to say that in the current strategic plan of Makerere, which is highlighted here, the #1 goal, which the VC has been very vocal in articulating, is for Makerere to be a truly research-led university. And I mention this so that as we examine the role of research, we can see how the institute that I lead is contributing to that broader goal. Okay, so as a show of that commitment, the university management has actually convinced government to put aside a pot of money dedicated to research. And this fund is known as the Research and Innovation Fund. And I really think we should not take it for granted that our government has really committed to putting resources for research. And I want to recognize Dr. Sabrina Chitaka, who's a member of the Grants Management Council. She's the acting chair. Please stand up for formal recognition. Yeah. I really believe, because I believe there's no other tertiary institution that has this kind of fund, I really believe this is a catalytic opportunity for Makerere to lead the way in terms of providing investments that lead to research and innovation. So it's a 30 billion per year fund, and I think that that figure will grow. And to the credit of the fund, they've given away successfully 3 rounds of funding, and they're currently doing a 4th round, and that is a very notable development. I should also indicate that in the 4th round of this fund, they've entirely dedicated resources to students at the doctoral level. So I can imagine a year from now, 2 years from now, we'll have results of studies that are done at a very rigorous level. And I hope that many of them will be facing HIV and addressing the disparities and inequalities. So I salute the fund. And I also, let me use this opportunity to message to Dr. Sabrina to sponsor multidisciplinary studies, because the issues we are facing will not be necessarily medical, but will have anthropological, sociological. We need to do cross-disciplinary studies. So now let me turn to the university's contribution, and I hope you can permit me, because I will be a bit selfish by zeroing in on the work that the institute that I lead has done. Before I do that, let me acknowledge that there are multiple entities at Makerere that are involved in the HIV response, and I could highlight quite a few. We have the Makerere University Johns Hopkins Research Collaboration, we have the Makerere University Walter Reed Project, we have the Makerere Joint AIDS Program. There are so many, but I have chosen to just highlight work that we have done at the Institute because it's the work that I'm most familiar with. Before I go into addressing the specific disparities that we want to address going forward as a national response, let me also highlight that, again, as a university, we would not be building from scratch in addressing the inequalities we see among young people. Makerere has a very strong track record of contributing to the HIV response. And here, it's not just national or regional, but a truly global contributions that shape guidelines and policy. So on this slide, I've highlighted a few. Again, we could flood this slide with all sorts of publication. But for example, the groundbreaking description of slim disease and associating it with HIV was really done by professors at Makerere, specifically at the School of Public Health, Professor Serwada and his colleagues. Again, up the hill, our colleagues in the Johns Hopkins collaboration led by professors at Makerere, again, Professor Francis Miro, Professor Philippa, demonstrated that you could protect babies using a single pill. And I think this is a contribution that was really went global, and I see that Canon is very happy. You're a beneficiary. I will convey those sentiments to Professor Musoke. I also show on this slide, if you look carefully, there are two publications highlighted here in what is called the New England Medical Journal. Now, those of you in the medical fraternity know this is the #1 clinical journal. I mean, if you have a paper in this journal, then your career is made. So we've been privileged at IDI to make several such contributions. One is quite recent, looking at second-line treatment, the NADIA study, comparing dolutegravir with darunavir. And already our colleagues at the Ministry of Health have expressed interest in seeing how these results shape second-line treatment. But earlier, we also did another study called the EARNEST. Some of you will remember, in partnership with our colleagues from JCRC. The point of this slide is that the university is ready and has a solid foundation for contributing to research. So turning to the institute at Makerere, which really focuses on infectious diseases, but our initial contributions have been in HIV. Our work is always guided by strategic documents, and I show you in this schematic the 4 areas we have been committed to contributing since 2018. So I will only discuss the first one, and I hope the Commission and the Ministry will be encouraged by this focus. So at IDI, we have committed to looking for catalytic roles towards epidemic control. It's in our strategic document, it informs our work plans, and also our opportunities to look for resources. So in light of that strategy, I also wanted to tell you on behalf of the university that Makerere has gone out to the community
You know, universities are referred to as ivory towers because the professors stay there in the university teaching and doing research and sometimes not aware of what is really going on. When I show the VC this slide, he's very, very happy that as an institute, we have really taken the university to the community to be able to pick up what the issues are and then subject those to research and other interventions. So we have programs in West Nile. I saw a friend from Napak. We have programs there in tuberculosis. So I hope this slide encourages you that the university has a finger on the pulse. We are not in the sky dreaming about equations and sample sizes. We are on the ground and implementing. And I hope you're also encouraged that we are not working alone. We work with a lot of organizations and we even give sub-grants because we believe in building institutions. These institutions will do some of the work we can't do, including community-based organizations. So going back to this framework to then highlight what contributions we want to make. Because of time constraints, I will spend time on the strategic priority 1, which highlights equitable access to HIV services. And I hope I can be quick. So this is the strategic priority in the plan, and there are 3 areas. So I will just give one example of each because of time constraints. So the first result area is around key populations. Let me pause and maybe tell a story related to this before I go into the results. When I'd stepped into the office of Executive Director of the Institute, in barely weeks, I received what I call an adverse communication saying, we are going to expose you as an institute because you're doing illegal work with illegal populations. And I had to seek the intervention of the ministry to back the work that we're doing. I believe that that communication came because we really do work with key populations, as you will see. I start with key populations because HIV prevention, if we don't have enough resources and we can only put it in one place, this is the place. And the canon talked about the approach to prevention. We all know that there are 3 areas: biomedical, behavioral, structural. Many times we limit ourselves to biomedical or behavioral because sometimes the structural ones are complex. But if we are really to get success and if research is to contribute, we really have got to work across those. So what are some of the things we are doing at the Institute for Prevention Research as an example of a contribution? So IDI has a satellite unit at Kasangati. It's next to the health center. And that unit is actually dedicated to HIV prevention research. This unit is busy. I hope you can see that in the slide. And this unit also has a way of getting what I think are sexy names to studies. So they have a peer study, Tuongere, Align, Empower, Obumu. So all these are studies. And if you look carefully, I've underlined some things there. There are studies on adolescent girls, discordant couples, male partners, female, male and transgender sex workers, African sex workers, transgender. So we have these populations, and I just wanted you to know that as a university, we are interacting with these populations. We are generating data. We will share this data at fora like this, and also share this. So this work mostly focuses on PrEP. So yesterday, my colleague, Dr. Timothy Muonge, and by extension, Dr. Andrew Mujigira, provided some of this data. And in this slide, I just show 4 pieces of work that were highlighted. One is on using long-acting injectable antiretroviral therapy for PrEP. So the previous chair mentioned that if it was up to him, each young person should be on PrEP. And I really do think that injectable PrEP, long-acting,
will be a game changer, particularly for those young people who are disempowered and who face very difficult decisions. There's ongoing work around a vaginal ring. There's ongoing work around dual prevention, where you take one pill, but it has both a contraceptive but also ARVs. And then there's also a pipeline of products that are underway, and an institute like us, with the networks that we have, we will then be able to bring some of these products and do some pilot testing within our populations. Again, yes, I don't know if this was covered yesterday, but we do have some studies trying to understand discordant relationships. We really think that this is an area to help people make informed decisions, including the choice to stay together. So we've gathered some insights around what factors enable people to stay together, what burdens people face, what are the issues, and what enables couples to stay together. So I hope these insights can then be fed into programming. I'm going to move to the second area around, so I'm moving away from prevention, going into care and treatment, and wanting to highlight at least one instance related to these priority populations. So yesterday we had a compelling talk from colleagues from the Rakai Health Sciences program, talking about the cohort and incident data. So I would like to make members aware that at the Institute we have a dedicated academy for health innovation. And that academy has been in existence for about 5 years. And what I wanted to note for the benefit of the Commission and the Ministry is that the Academy runs an annual meeting on health innovation alone. And there's a meeting coming up in December, just looking at health innovations. But to go back to the point, this Academy for the last 3 years has been really in a research setting, trying to understand the acceptability, utility, and costs of using a medical drone to deliver antiretroviral therapy to fishing communities in the islands of Lake Victoria, and also sample delivery. So this work is underway. It has received a lot of press. The initial results are encouraging that you can actually do this, and that possibly you would save not only money, but also lives. So I was surprised, for example, to learn that a lot of fisher folks and fishing communities don't know how to swim. So when there are tragedies on the lake, people actually drown. So the map there shows some of the routes that are being used by the drones to deliver antiretroviral therapy. And I hope that we can have an opportunity to share the definitive results. So I hope this is a good example of thinking outside the box, not business as usual. How do we take a vulnerable community and make sure they have access to antiretroviral drugs? How am I doing on time? Yeah. So this is the last area I will highlight, where we want to look at structural interventions. We've talked about the data from UFIA has highlighted the problem of young women. And also my colleague, Dr. Catherine from Mildmay, has really done a good job of talking about the DREAMS project. And I also wanted to highlight it because as a partner, as an implementing partner for Kampala and Wakiso, we are really engaged in these structural interventions, and I'm very glad that Dr. Senyimba already highlighted a lot of this work. And I must say, it's an opportunity also for us as leaders to see how other leaders encourage these structural interventions. It's been my observation that the current US ambassador, for example, and the current director for CDC in Uganda have been very keen in making sure that these structural interventions, and I think we should recognize that leadership by women for women. And I hope that the women leaders here are encouraged to also stand up. If an issue is affecting women, it's really good to see women in leadership. So Dr. Senyimba really highlighted the details of the DREAMS project. My role, since I'm talking about the role of research, is to say that as we roll out these programs, we need to include robust evaluation so that we know what works, what doesn't work, so that we channel the money to the things that really work. These structural interventions, I believe, should also be on the radar of government, because to do them sustainably, they necessarily need more resources. And so I think our development partners will be greatly encouraged if we also get into this space. As I come to the end of my slide, and I could even dare say, for me, this might be the most consequential slide if I look in the future. So let me do a census. How many of you have a mobile phone? Yes. I suspect many of you in the audience have had a mobile phone for more than a year. If that statement is true, someone can locate where have you been the whole year, minute by minute. And that is gold. If you sat in a taxi which has a known TB suspect, and that phone tells me you were there for 30 minutes, then I know there is a certain level of risk to you for tuberculosis. I hope you get what I'm saying. So the data science revolution is here. It's a combination of powerful computers, access to large data sets, and the rise of artificial intelligence and machine learning. And it's going to change our lives. It has already disrupted industries. It's going to disrupt health. I was talking to my doctors, and I asked them, and let me also ask the doctors in this room, do you know a butterfly? I'm not talking about the insect. I'm talking about a handheld ultrasound device that is going to replace the stethoscope, and which already medical schools in the United States have transitioned away from the stethoscope to the butterfly, because the butterfly can see the heart directly. It can see the lungs, it can see the intestines. But most importantly, it records data. It takes pictures. So, I want to urge the Commission and the Ministry that this revolution should be harnessed for targeted interventions. If we're talking about young people, where? Geographically, age-wise, so that our interventions are targeted. So I'm glad to inform you that at Makerere in 2019, we launched the second African Center of Excellence in Data Science and Bioinformatics. And it's the second one in Africa, there are only two. And I'm proud to say that it is hosted at the IDI on behalf of the university. And you can see in the bottom panel, the VC trying on some virtual reality. We have a virtual reality lab there. It has a high compute facility. But this is really going to change the way we do research and even science. Machines will begin to give us insights on the basis of analyzing very large data sets. So let us not get left behind. I want to end by acknowledging the various partners, development partners, the Office of the President, and by extension, the Commission, for giving the university a great platform to not only highlight what we have been contributing in the past, but also what we can potentially contribute. I say all of this, as we say at Makerere, we build for the future, for God and country. Thank you for your attention.
Thank you so much, Dr. Kambugo. By the time the VC says, please go and represent me, then it means in the next 5 years, you may be our next Vice Chancellor. We have so many mentors, and I had not seen one of these huge mentors who is present with us. Mero Duka, I'm not sure if people know that you are one of those huge mentors. Please, Mary, it has been long, but we are glad you are back into our field from the land issues, now back to our HIV. We missed you So we are happy we are back here. And thank you, Doctor. Please, if you have something you want to ask, you want to say, you can put it on paper. Because of time, we're not be able to really go back a lot. But as you can see, we are looking at, can we have research funds so that we can be as innovative to have those butterflies? When you mention butterflies, like, oh, the various cycles of the butterfly, but also the robust evaluation. So before Dr. Shaban comes in, we are going to give him only 5 minutes. I would request the IT team to play the information from Anne so that we can have this out. And in case you have something you'd wish to say, wish to ask, wish to comment, we'll have an opportunity after that. And the lunch team, we are moving slowly but surely, so please keep hanging in there. Thank you. Over to the IT team.
Good morning. My name is Anne Githukushongwe, and I'm the Regional Director for UNAIDS Regional Support Team based in Johannesburg. My apologies for not being able to be there physically. Let me greet you, the Honorable Prime Minister of Uganda, Rubina Nabaja, Honorable Millie Babalanda, the Minister in charge of the Presidency, all Cabinet Ministers present, Your Excellencies, members of the Diplomatic Corps, Your Excellency Natalie Brown, the U.S. Ambassador to Uganda, honorable members of Parliament, my colleagues from the United Nations system in Uganda, Uganda's AIDS Commission Board and Management, religious and cultural leaders, civil society, young men and boys, esteemed adolescent girls and young women, the media fraternity, ladies and gentlemen, all protocols observed. My sister, the Right Honorable Prime Minister Rubina Nabanja, I'm very pleased to see you gracing this important function. This is a clear testimony of the government's commitment to end AIDS. Through you, I would like to recognize the important contribution that Uganda has made to the HIV response. We in the UN value the contribution that His Excellency President Museveni has made to the HIV response by showing the world that the battle against HIV and AIDS cannot be won without the highest level of leadership. We thank and recognize His Excellency's leadership. Thank you for inviting me to speak at this national symposium under the theme, Ending Inequalities Among Young Girls and Boys. The theme is fully aligned to the 2021 Political Declaration on HIV and AIDS, ending inequalities and getting on track to end AIDS by 2030. This declaration that was adopted by UN member states, including Uganda, is based on evidence grounded in human rights and will serve as an important roadmap to advance the global HIV response over the next 5 years. We are left with only 8 years to our goal of ending AIDS as a public health threat and to ending gender inequality by 2030. We congratulate Uganda for the significant strides you have made. In Uganda, 89% of adults living with HIV have been aware of their HIV positive status. Among adults living with HIV who are aware of their status, 82% are on antiretroviral treatment. Among adults on antiretroviral treatment, 78% have achieved viral load suppression. Congratulations. Uganda is well positioned to achieve 95-95-95 targets by 2025, and all data has been moving in the right direction. We appreciate the steadfast leadership of His Excellency President Yoweri Museveni, who has championed HIV from the start and continues to do so, as evidenced by the Presidential Fast Track Initiative for ending AIDS by 2030. Right Honorable Prime Minister, Excellencies, ladies and gentlemen, adolescent girls and young women, HIV, violence, and teenage pregnancy have been prevalent in many of our countries, driving HIV. Of particular concern to us in East and Southern Africa is the magnitude of HIV incidence among our adolescent girls and young women. Between 15 to 24-year-olds, 37% of all new cases of HIV in 2021 were amongst adolescent girls and young women. The In Danger report that UNAIDS released in September of this year reveals that every 2 hours in 2021, an adolescent girl or young woman was newly infected with HIV. In this region alone, in 2021, we reported 3,236 new infections each week amongst adolescent girls and young women between 15 to 24. Uganda alone reported 298 infections in this group. The tragedy is that these infections happen to underage girls below 15 years of age as well. We have 15,498 new infections amongst adolescent girls and young women, which means that they account for 28.9% of all new infections. Importantly, there is a significant difference between infections amongst young girls and their counterpart boys. Girls in Uganda are 4 times as likely to be infected than young boys. So we're not leaving boys behind. It is the data that tells us this. It tells us clearly that the infections among young girls are not coming from their age mates, but rather from men who are 10 years older, who have more power, who have disposable income, and prey on girls who may be desperate for practical and economic needs. COVID-19 has taught us how quickly gains made in the HIV response can be erased, particularly for populations who have been left behind. Many countries reported a decline in numbers of people testing for HIV and starting on treatment, high levels of gender-based violence and schoolgirl attrition. It is also very important to note that very high numbers of teenage pregnancy, 378,000 teenage pregnancies for girls aged 10 to 19 in 2021 alone, which can be linked to HIV incidence rates amongst this group. The majority of the teen pregnancies are as a result of rape, of defilement, and of abuse. Yet somehow this part of the narrative is not substantially covered in our reports. Also, we have completely normalized that specific abnormality of teenage pregnancies, which is a crisis in and of itself. Honorable Minister, Honorable Prime Minister, we must hold perpetrators of this violence against our children accountable. Let us find ways of connecting the schools, the health systems, the police systems to ensure that teenage pregnancies are investigated. There are a number of countries that are making considerable progress in this regard, and perhaps there's a learning to be had. For instance, the Department of Basic Education in South Africa introduced a policy for schoolgirls to go and report to the police should a girl younger than 16 fall pregnant. This could be expanded to mandate health facilities as well as, depending on country-specific context, of course, informed by a thorough analysis of the implications of such a move. We have to do all we can to protect the gains made in the HIV response. It has not been easy to reach here, and it will be even harder to get back if we slide backwards. We simply cannot afford to do so. Let us turn to men and boys and HIV. Right Honorable Prime Minister, prevalent toxic gender norms that equate illness with weakness lead to poor health-seeking behavior and lower health service uptake among men in their diversity. The men in our region are therefore in a vulnerable position. We have more men and boys dying of AIDS compared to women. Men who are on antiretroviral therapy programs are 70% more likely to die than women because of their poor health-seeking behavior. While HIV infections have a young woman's face, HIV deaths have a man's face. Engaging men and boys is both critical in preventing new infections and averting deaths. Male engagement and interventions around positive masculinity is also a critical pathway to ending gender-based violence. Uganda has incredible interventions on positive masculinity that include working with traditional and religious leaders. Congratulations. It is also important to roll out interventions that address health systems bottlenecks. Some countries have enhanced men's service uptake by interrogating the health system to ensure that services are delivered in a manner that cater to the needs of men. shifting clinic opening times, and delivering male-tailored mobile clinics are some of the interventions that have proven to work in this area. Let me turn to an area that is often difficult to discuss in our region: HIV amongst key populations. Despite these gains, the fight to end AIDS is far from over. According to the AIDS Update 2022, Eastern and Southern Africa records a high incidence among key populations. And who are these? These are gay men and other men who have sex with men. These are sex workers and their clients. These are transgender people, people who inject drugs, and prisoners and other incarcerated people as the 5 main key population groups. We must talk about these groups and their vulnerability to HIV. The difficult legal and cultural environment in many of our countries, including stigma and discrimination at societal as well as legal level, makes it very difficult for us to reach these key populations with the required health services that they require. Ladies and gentlemen, health is a right for all human beings. It is a human right for which we've all subscribed to. UNAIDS has got evidence, and this is included in the Global AIDS Strategy, that the HIV response does not make much progress in countries that have punitive laws and where stigma and discrimination affecting key populations is widespread. Your Excellency Prime Minister, I implore you and your government to take leadership in openly challenging stigma and discrimination that's perpetrated against key populations in Uganda, particularly as they seek health services and other services. Distinguished participants, so what should we prioritize? This region is not short of scientists. It's not short of policy guidance and instruments to shift the HIV and AIDS trajectory for our young women and boys. We have the Maputo Protocol, the Beijing +25, ICPD, and other SRHR policies that countries have adapted and signed up to in a bid to create a conducive environment for the improvement of the health and well-being of young people. The East and Southern African Ministerial Commitment on Education, Health and Well-being for Adolescents and Young People is another important guiding instrument that brings together ministers of education, ministers of gender, youth and health, and attempts to consolidate all these intersectional policy instruments. This is crucial for the intersectoral nature of the HIV prevention and response. I applaud the government of Uganda for efforts in creating an enabling policy environment for young people to access quality HIV, SRHR, and GBV information and services. Commendable and progressive laws, policies, and strategies such as the universal primary and secondary education, re-entry into school, the national strategy to end child marriage and teenage pregnancies, the national plan of action for gender-based violence, sexual and gender-based violence, and violence against children, all of which are to improve the lives of adolescent girls. We urgently need to scale up targeted, integrated, evidence-based interventions, such as Education Plus, to scale. A few months ago, Your Excellency, I was in Uganda where the First Lady and Minister of Education launched the Education Plus initiative. I applaud the country for commitment to this initiative, and I call upon partners and government to expedite full scale up of Education Plus. Uganda is also home to many community-led organizations for decades that contribute substantially to the response to HIV in the country. Their efforts in advocacy, participation in accountability, service delivery, and community-led monitoring must not only be sustained, but also scaled up. We cannot reach the 2030 targets without placing communities at the center of all our efforts. Right Honorable Prime Minister, we know the urgency. This symposium theme, Ending Inequalities Among Young Girls and Boys, is timely, as the data shows us that the inequalities are affecting attainment of the 95-95-95 targets in all population groups, but in particular amongst children, amongst adolescent girls and boys, and our key populations. So what should we do? Girls' secondary education is important. In Uganda, it is characterized by lower access, higher dropout rates, and lower transition rates compared to boys. About 25% of girls drop out of school because of pregnancy, and data that was revealed that in 2021 districts like Namisindwa in Bugisa region, Amudat in Karamoja region, Kitagwenda in Toro, Rwenzori region, each registered over 50% increase in teenage pregnancy numbers. Completion rates for senior boys stood at 40% compared to 36% for girls. The disparity widens at the transition point to senior 5, with 34% of boys and only 24% of girls transitioning to upper secondary. And to be frank, while the gap concerns us, the transition rates for boys is also far from fantastic. The main reasons for a girl dropping out of secondary school is pregnancy, early marriage, and cost of schooling. The share of women who married before the age of 18 was 43%, according to the latest demographic and health survey. A more recent study supported by UNICEF indicated that child marriage in Uganda is even more pervasive, with 20% of girls suffering from having to deal with early marriage. 1 in 7 women aged 18 to 22 have their first child before the age of 18. The probability of completing secondary education for a woman aged 25 to 34 who married after 18 is 12.9 points higher than for a woman who got married earlier. Evidence suggests that keeping children in school delays marriage. This must be accompanied by appropriate policies to be implemented by schools to prevent early marriage and pregnancy. This should also include violence against children and gender-based violence prevention interventions that contribute to creating a safe school environment that protects girls from the risk of falling victim to sexual violence. Additionally, distance to lower secondary schools for young adolescents, especially girls from poor families, tends to raise opportunity costs for families and physical risks. We know that increasing access to lower secondary schools, reducing the cost of education for poor households, and providing incentive for girls to stay in school creates a positive effect on education access and attainment. Education also has a protective benefit of reducing the risk of sexual violence, GBV, and HIV infection. In fact, completion of secondary education by adolescent girls has reduced HIV infection by up to 50% in some countries. I applaud the government of Uganda for the return to school policy, which presents an opportunity to enhance and enable girls to return back to school as soon as they can, as we address the period of mother's stay at home, breastfeeding. There is undisputed evidence from countries across the world that criminalization of same-sex sexual relations, sex work, drug use, or HIV exposure and transmission drives people away from HIV services. Recently, for example, Angola decriminalized same-sex sexual relations through a new penal code, an important move in a context where men who have sex with men face far higher prevalence than the general population. In fact, Botswana is celebrating a year for the same decision. As long as some groups of people are driven underground and are unable to access HIV prevention, testing and treatment services, AIDS can never end. By guaranteeing the right to health for all without discrimination, Uganda can beat AIDS, beat COVID-19, beat Ebola, and prevent future pandemics. As I begin to conclude, the financing landscape for the HIV responses across the developed and developing countries, looking at the past 5 years and projecting the future up to 2030, are of concern. Globally, UNAIDS has called attention to the significant decline in funding of HIV. This is a result of global shocks and the accompanied refocusing of funds away from development into emergencies and security, among others. Low and middle income countries, including Uganda, will need US dollars 29.3 billion in order to meet the 2025 targets. There is a significant shortfall of this funding, estimated at US dollars 8 billion. Unfortunately, the HIV response in Uganda remains heavily donor dependent. Data from the National AIDS Spending Assessment indicates that over 90% of funds used in the HIV response is from external donors. The Global Fund to Fight AIDS, TB, and Malaria, which is one of Uganda's main funders, did not manage to achieve its financial replenishment target in 2022 and raised only 13 billion of the 18 billion that was targeted. This will mean that countries get less and less funds to use for HIV programming. With Uganda's estimated 1.2 million on ART and annually 54,000 are added new, if this continues, it means we will have 1.9 million people needing ART by 2030. An individual needs about $170 to be maintained on first-line treatment and 200, which is 204 million US dollars for 1.2 people living with HIV. This trajectory is not sustainable. More funding is also needed for prevention, and UNAIDS estimates that a quarter of all HIV financing should go to prevention. Uganda and other countries that are reliant on global funding will be negotiating negatively affected by this shortfall. And this is why the national financing dialogue is critical. It will allow us to think together as a country and develop plans for sustaining the HIV response. The financing dialogue, which I understand will be taking place after this symposium, will therefore be an excellent opportunity to engage deeply on these issues. My sister, the Right Honourable Prime Minister, ministers present and delegates, I applaud the government of Uganda for efforts in creating an enabling policy environment for young people to access quality HIV, SRHR, and GBV information and services. Commendable and progressive laws, policies, and the need to fully integrate services for HIV, TB, and COVID, and other services have been prevalent across the country. Congratulations. On behalf of UNAIDS and our co-sponsors, I would like to thank you for this symposium that will discuss and explore options for sustainable financing to cushion the excellent gains made in the response to HIV and other public health interventions from epidemics and other shocks being experienced at global, regional, and national level. We will also be analyzing the cost and the cost of inaction that influences and will impact on the adolescent girls and the young boys who are also impacted by this epidemic. I want to thank you for your attention and all the best for this symposium. Thank you.
I hope the UNAIDS team will take appreciation to Anne. It is really, really important. I'm glad our keynote, our guest speaker, Dr. Andrew, was able to make a reference to the UNAIDS framework, because we are talking of ending inequalities. And for those who have been privy to the Global AIDS report, you will be able to see that even the cover is red. We are in danger. So we really need to work around that and be able to work on programs that have been successful, such as the Education Plus. So within the next 1 minute, I will give only 5 minutes to Dr. Shaban to talk about the legal environmental report, the assessment. You'll make a reference to where we can find it, but you have only 5 minutes. Thank you.
Thank you very much, Madam Chair and your co-chair. Our Vice Chancellor here represented, the Director General, Uganda AIDS Commission, and board members. Allow me to say the rest of the protocol as it stands in the interest of time. Can I request the Secretariat to load the presentation? So I want to say, Dr. Shaban Mugerai is my name. I'm a management, business, as well as public health specialist. I am coordinating the equity response at the Uganda AIDS Commission. I want to thank and congratulate the Director General upon organizing this and our team. That this is no mean achievement, but to say that the theme of this symposium is just in line with the kind of people I speak for. And I want to say that right from the selection of the theme, right from the JAR report and its conclusions, the speech delivered by most speakers yesterday, including Her Excellency the Ambassador, but not forgetting the Vice Chancellor, who comes from a great institution. For your information, I'm an alumni and I'm also celebrating with you the 100 years, and but also and a former employee of IDI, Makerere University, Johns Hopkins University. I've been associated with those. The IT is kind of sabotaging my 5 minutes. I want to say that right from all the speakers that have so far spoken to us, they kept nibbling into my presentation. That's the beauty about it. On the lower side, I want to say that even within the room here, as we are gathered here, there are a lot of inequalities. You can see it from the kind of time allocation that has been given to this presentation. And yet, in my view, this would have been one of the key presentations to be shared within this symposium. But that said, it's not all lost. And I want to thank the chair. I will strictly stick to the time allocation, what has happened to technology. Just to say that I want to put a disclaimer. Uganda's commission received support from mainly PEPFAR and the UN family to conduct a legal environment assessment for the provision of HIV services across board. But also we received specific funding from, again, PEPFAR through CDC, and that came through Makerere University School of Public Health for us to conduct a legal environment assessment specific for the key and vulnerable populations. And the disclaimer I want to put is that I don't put on legal lenses, because most of the aspects, the kind of insights I'm about to share with you involve a lot of legalese. I'm only threatening to join the law school to do medical law. So at 70, I hope the Vice Chancellor will allow me to pass quite smoothly. You don't make life hard for me. Because I passed from P1 up to through undergraduate and high and postgraduate levels. I want to think you are going to be fair to me when I finally join, so that I can speak with legal lenses. IT, have we failed to load the presentation? I should say these are the inequalities that the people I speak for continue facing. So to begin with, I'm going to share insights of the legal environment assessment report part 1 as that was conducted and was specific to the key priority and vulnerable populations that we are entitled to serve. Now, this, as I said, was supported by PEPFAR through CDC, but via Makerere University School of Public Health, and it was launched sometime in August, actually to be precise, on 2nd, and this was graced by Her Excellency the United States Ambassador to Uganda. Okay, but it's not displaying here. Okay, I could use this other screen. As you can see, the ambassador who was part of our symposium yesterday graced the launch of the first key population specific assessment report. But overall, we had a Justice of the High Court, Her Lordship Eva Luswata, who be presiding over the launch. Now, overall, the objective of this legal environment assessment report for key populations was they sought to identify and review HIV and key-related regulations, policies, and practices in Uganda with the intention of improving the availability of information and evidence of legal and regulatory facets in the context of HIV and AIDS, but also vis-a-vis the key populations that we serve. Specifically, the team set out to analyze existing HIV health and other related laws, regulations, and policy initiatives that impact the HIV response among the key populations, but also to assess the critical human rights issues affecting the same population. And finally, they wanted to analyze access to justice and law enforcement on HIV and human rights among key populations as they receive services from the service providers. This was largely a narrative, descriptive, qualitative study at the community level. It followed the formative assessment using key informant interviews and focus group discussions, and we relied mainly on the UNAIDS Manual for Legal Environment Assessment as published in 2014, and the study covered 5 regions, including at least 3 districts from each of the regions. These are the kind of populations that were reached using that formative assessment approach, and they included civil society, government officials, especially our colleagues from the just law and order sector were actually interrogated. Those are the regions that were visited. What did the team find, and what is obtaining? That the Constitution guarantees fundamental human rights and freedoms to be enjoyed by all human beings in Uganda. And a quote is made here that Article 20, which proclaims that fundamental rights and freedoms of the individual are inherent and not granted by the state. This nullifies all legislative, executive, or judicial actions that arbitrarily interfere with human rights. We know, and we are told by the learned friends, that if there is any conflict between any law and the Constitution, the supreme law of the land takes precedence, and that's the Constitution. So from time to time, we must always reflect on what the Constitution says. But on the contrary, this is what is obtaining, that rights relevant to key populations in the context of HIV as guaranteed under the Constitution are most often than not violated. And these include the equality of all persons and freedom from discrimination, the right to dignity, freedom from torture and inhuman and degrading treatment. The Article 27 provides for the right to privacy of persons and property, but significantly, affirmative action is provided for under Article 32. So, as I said, the people I speak for in the equity response continue to be impacted by restrictions, as evidenced from this human rights organization key informant interview that was conducted in Bushenyi somewhere. Key populations have several laws that do not favor them to access services. For example, under the Penal Code Act, we have provisions under which men who have sex with men and sex workers that are arrested. The Section 145 of the Penal Code Act on unnatural offenses is used to arrest men who have sex with fellow men because it says they have had sex under the order of nature. And that is what has been used to deny them their freedom to associate and to go about their life. So technology, as I said, is also discriminating the presenter, but also the people that he speaks for. So, but as I continue, you are all aware that the NGO Act generally imposes restrictions on civil society organizations' operations in Uganda. Section 30 of that act provides prohibits the registration of organizations perceived to work in contravention of the laws of Uganda. And I want to refer you to this quote that came from female sex work in Bushenyi. It was advised that I should start an organization or a group of my fellow girls who are sex workers. And the common name given to them is, they call them Nekolera Jang here in central Uganda. But I was told that when registering, I should not disclose that we are sex workers. I should instead say that it's a women's group, because if I had to say we are sex workers, the authorities would not sign on the forms allowing us to register. So some of the rights that are violated from time to time include rights to non-discrimination, right to health, access to justice, freedom from torture, and many others. These are some of the citations that came from the focus group discussions. And on one occasion, it was noted that our duty bearers, especially the police, call us names when we are paraded. For example, they like talking in Swahili. Nyinyi wabangi, toka, meaning you drug users, come out. In fact, drug users are used most in cleaning and doing other dirty chores at the police centers. When they come to the cells and want people to clean, they call out drug users to do that. And I will just limit myself to only that one, but it's not all lost. The Ministry of Health, working very closely with Uganda's Commission, has put in place frameworks that have actually enabled us to have these people access services. One of the most important policies we have is our national health policy, which is the most liberal one in sub-Saharan Africa and probably maybe planet Earth. In Uganda, for anyone to access health care, you don't need to produce a national insurance, an insurance card or a national ID. Here we are serving Congolese, we are serving people from South Sudan, and they go about their business freely, but they also access healthcare freely. But that said, we have other strategic frameworks in place. We have the key population programming framework as developed by us at the Uganda's Commission, the health sector HIV/AIDS strategic plan, the Uganda National Consolidated Guidelines for HIV prevention, treatment, and care, as revised in 2020, and we are working on a roadmap we are domesticating the UNA's global HIV prevention roadmap. There are many other rights of these people that are violated. Freedom to associate. Right now, key populations cannot freely associate and register as groups of people with common challenges. Therefore, laws should be enacted, allowing them to associate, form groups so that they can be empowered with income-generating activities. We are living in the era of the parish development model, where government is extending these grants to the people.
Give you a few more minutes.
I've already accepted the inequality in the room. After all,
we actually kept quiet, otherwise
so thank you so much.
Okay.
There is also a lot to do with the community stigma. Professor Canon Gideon is here. I'm glad you've spoken for me, and many other speakers have already spoken to this. There are key populations on treatment, but most of the key populations, especially the ones we have interacted with, don't get their treatment from facilities within their community or here. Actually, there are very few, especially the local girls involved in commercial sex around here, who get treatment from us. I think that what happens is that happens because of stigma, but also because of the nature of their work. So, ladies and gentlemen, what recommendations came through from our team that assisted us to do this legal environment assessment? That efforts should be made to ensure equality and non-discrimination, review of restrictive laws, including the HIV Prevention and Control Act. We need to sensitize key stakeholders, especially people who hold important positions in the government and I'm glad my elder brother here, Mondo Chateka, is here from the Ministry of Gender, a very, very senior colleague. So in the equity response, I'll be working very, very closely with you. I'm glad you are here to listen in. Efforts to ensure social norms and practices are improved should be put in place. And finally, service provision should take on the dimension of affirmative action. Yesterday, you heard from another keynote speaker, Betty Kwagala here. She told us that, maybe the design of our training curricula, right from pre-service. For example, she talked of the gap in terms of language sign language interpreters. Not many health workers in Uganda do understand the challenges the visually impaired colleagues or the deaf people go through. So we need to restructure ourselves right from that level going upwards. The other day we learned when we were doing a midterm review of the equity plan in Jinja that actually the whole institution of Uganda Police Force has only one sign language interpreter, the one who normally appears on the newscasts with the spokesperson of police, Enanga. But outside Kampala, they cannot afford to have a sign language interpreter. So those are some of the challenges that the people that we are planning for. And in the spirit of leaving no one behind, we must all agree and take action now. The time to act is now, that if that is the theme that we are following as a country. But I liked the Dean's presentation. IDI has taken the key populations at key result area number 1. And I want to congratulate you on that. I'll be working very closely with you. And I just want to request for support from my Director General. So ladies and gentlemen, I'll stop here for now. There was a second part which was a general. But in the interest of time, I'm going to refer you to our website, the Uganda Commission. These reports are there. I've just nibbled a few extracts from there, but you are at liberty to access the full and therefore detailed report and interrogate it. No questions for me because I don't wear legal lenses. Thank you very much.
Thank you so much, Sarongo, for that. You know, the time, it is not inequality in a way, but time doesn't go backwards. So we have a reference, so we could always go to those materials. So my co-chair will come in just briefly 1-2 minutes in case there is something very burning. You will handle that and then we'll proceed. Thank you.
Okay, thank you, my chair. I will not complain. Yes, now the duty I've been given is to check out if there are 1, 2, 3 questions that have been written down for transmission to our able panelists or speakers. Dr. Kambugu, on behalf of the Vice Chancellor, we heard of the keynote address from the UNA's Regional Director, and to Dr. Shaban Mugerwa. Are there any written down questions for transmission to the front? Because in the interest of time, we may not give the speaker phones out. As those notes are making their way to the front, allow me share with you, colleagues, that we have Ebola in the country, and it would be inappropriate, dear DG, not to get an opportunity to listen to a quick update and a few precautions that you should undertake. So Dr. Solomon Okwale from WHO, if your presentation is already uploaded, you may make your way to the podium to deliver. Please write down your questions. There is no microphone that is going to come to the floor in the interest of time. Thank you. Dr. Solomon, it is you here. Yes. Thank you. And you have not more than 5 minutes. Yes, because we have a panel discussion coming along. Thank you.
All right. Thank you very much. Good afternoon, colleagues, members, those in attendance. Making this presentation on behalf of the Incident Commander, Dr. Henry Chobe, who was not able to be here this afternoon. I don't know if we can put up the slides.
You can speak of hedge.
I just start off, eh? All right. Okay, just to give a brief while we are finding the slides. I think we are all aware that on 20th September, the Ministry of Health declared an outbreak of Ebola virus disease in Mubende, after identifying one case that was confirmed, as well as a cluster of deaths that had been identified, creating a bit of a complicated situation as we try to move forward with identifying the new cases, while also moving backwards to identify where these cases had come from. Since then, the country has reported 136 confirmed cases. Unfortunately, we've lost 53 of those lives, but we've reported 68 recoveries. In that time, we've also reported 34 of those who were children. It has refused to come up. Maybe it's a sign and it will help me use the 5 minutes only, Dr. Kagwa. We've reported cases in 8 districts currently, so counting Mubende, Chegegwa, Kasanda, Bunyangabo, Kagadi. I think Bunyangabo and Kagadi are a very good sign for us, reporting only single cases and never secondary transmission within those 2 districts, as well as cases in Kampala and Wakiso, and then more recently a case that had traveled to Masaka. In all these districts, the district task forces have been activated so that the response efforts can start, focusing mainly on building that coordination structure so that we can work collectively throughout the different pillars of the response, as well as strengthening surveillance to detect early and then respond early in all cases, and establishing ways of having case management capacity within those different areas. But I was told this is an HIV symposium, therefore I must link the two. From what we saw in Mubende and what the main worry is number one, will we make sure that we continue to provide care to those affected by HIV? Will we have a situation where a number of health workers have to be taken out of the system? For example, in some of the health facilities, we have observed that that a number of healthcare workers came in contact with a case, therefore we have to take them out as part of quarantine. And how will that affect the provision of essential health services to those affected by HIV? Secondly, also looking at the way these cases present. From the symptoms that we have seen over this period, and I think what we saw also with the last case that was reported in the DRC, some of the presentation is quite similar. The fever, the diarrhea, the vomiting, and many times these may be mistaken for other diseases. We've seen a lot of bouncing from facility to facility before a diagnosis is made, which sometimes delays the diagnosis. Other times we have seen that the healthcare workers are really put at risk at that time when that diagnosis is delayed. Another important area that we need to focus on as well, and the slides have come up at the end. Let me see if there's anything that we need to focus on. And up without the pictures. Okay. I'll focus only on the slides that are fully present. Number one is the symptoms, which I think that we all know are quite familiar. Secondly is on modes of transmission, which is through direct contact and then contact with objects that may have been contaminated with bodily fluids. Quite similar, again, to the risks that are observed in HIV. But the main thing is looking at the areas of overlap. Number one is provision of services. Number two is also poorer outcomes noted among those patients. And number three is the issue of similarity of presentation. I think the main message that we would want to get across is that in any case where we see a presentation with a patient with a febrile illness, it's important for us to dig deeper into where this person has been, the exposures that that person may have had, so that we provide the best possible care, and the care that puts the care providers at the least risk. I think Dr. Kagwa, those are the main updates. If there are any specific questions, we'd be happy to take them on.
Okay. Let us join hands for Solomon. Thank you very much. Yes, I was getting worried that Ugandans don't write, but we are celebrating at least 2 questions from Ruth, HIV prevention and research advocate. How are we, Uganda, involved in the research of DO prevention pill, since research is ongoing in Kenya, South Africa, and Zimbabwe? My senior doctor, that is to you. Then is there any room in the 30 billion fund? Dr. Solomon, Sabrina, this one will be shared with the Vice Chancellor. Is there any room in that 30 billion fund for resources to be allocated to conduct an implementation research on pharmacy distribution of PrEP and HIV self-testing kits? As an HIV prevention research advocate, how can I be involved in the DPP research? Thank you, my dear, for those questions. Yes, as the questions, we had requested for 2, but the law now has a question. Having sensitized the law enforcement every year and we get 0 case of SGBV, concluded with the penalty served, according to police report. Then the question 1, are we doing the right approach, or this is the time to change? Have I read your question properly? Having sensitized the law enforcement every year, and we get 0 case of SGBV concluded, and with the penalty served. Have you heard the writing? Yes, according to police report. Are we doing the right approach, or this is time to change? The question 2, how best have we sensitized the KP or priority populations to understand the legal barriers surrounding them and responses for enabling environment? Quickly answer these questions, dear colleagues. The mic is there. Thank you.
Thank you, and good afternoon once again. I'm grateful for the questions. Concerning the dual prevention, I showed a slide, I think it's slide 24, highlighting some of the ongoing work within our Kasangati Prevention Center. So perhaps I just would recommend that Ruth gets interested in the work that we do at Kasangati. There are opportunities to participate as a participant. There might even be opportunities to participate as a community advisory board member. The second question, let me attempt to answer it on behalf of Dr. Chitaka. Those resources can only be applied for if you're a faculty member of the university. So Ruth, I encourage you to identify a suitable faculty member and sell that idea, because that's the way the funding is structured. Thank you.
So I just want to add that there is no equity in the distribution of those resources. So, but I had one question or 2 saying that having sensitized the law enforcement agents year in, year out, and I think they made reference to a police report that I think zero cases were registered. I don't know whether I understood the question very well.
or not concluded. It's quite a challenge, kind of understanding what was at the back of your mind. I'm sorry, but just to say that Uganda's commission has provided a platform for engagement with all the duty bearers, and what we are doing in the presence of the equity framework that was developed by the country, signed up to by the Honorable Minister of Health. We have set up a multi-sectoral steering committee that has representation from all stakeholders, including police, UPDF, and others, but also people from the justice, law, and order sector. And we have agreed that we are going to address one or two, three things. One, issues to do with the human rights, equity, and gender-based violence. Two, we have also agreed to take on the leadership for fast-tracking the UNA's global 10-10-10 targets. They were mentioned here yesterday, but also the global plan of action for elimination of all forms of stigma and discrimination. So we are not moving alone. For us, our theme is leaving no one behind. And lastly, have we done enough to sensitize the key populations themselves about these barriers? My answer is yes. They are represented on all our technical working groups at the Ugandese Commission. We have a key population technical working group, but also in the Ministry of Health, they are represented. Ministry of Health is a service delivery entity there. For us, we are addressing the structure, legal, but from the biomedical point of view, I've told you the guidelines have been revised. For example, the harm reduction guidelines to do with the drop-in centers for key and priority populations have been revised and already approved, and we are going to disseminate them. So, but we are not doing these things alone. We are working with the key population leadership, especially their leaders, and they are represented on all the fronts. Whatever we do, we are including everybody. And we hope that when they are represented, this information will percolate and reach them in their own communities where they operate from. But we are going out aggressively to popularize the provisions of the equity plan across the country in the short future. Thank you so much.
Thank you very much. Dear colleagues, members, we have heard from Dr. Kambugu on behalf of the university as we conclude this session the need to work with big data and to learn a new type of butterfly. We have also heard from the UNA's regional director's message that 200 new HIV infections occur among our adolescents, girls and boys every day in Uganda. We have also picked from Dr. Shaban on the legal framework that they are going to work together such that information on the law percolates further down. Lastly, we have listened from an Ebola epidemiologist, Dr. Solomon Okware, that it is true Ebola is with us. We have registered more than 130 confirmed cases and registered more than 130 deaths. Please leave with that message from here. I said more than 30 because I was not sure of the number. Please, my words are calculated. Or else you begin correcting me, eh? Yes. The key message is that health is becoming a security issue, and you are responsible for your own health. Protect yourself from Ebola by observing the key SOPs. With those words, join me to thank our presenters with a hand clap. Thank you very much, colleagues. And I think we have earned lunch. As they walk down the podium, allow me to thank my chair for giving me an opportunity and call her to invite the panelists and then state the way forward. Thank you very much.
Thank you so much, the richest man at World Health Organization, Dr. Bugaga. And as members go to eat, I hope people will be able to tell them that the sessions are still on. At this juncture, I'm going to call my Muramu, Mr. Henry Semakula, to come and take over from us. Thank you. But I think we may need to stand up and stretch a bit. Let us stand up and stretch a bit as he comes over. We need to do that. Been sitting. Stand and stretch, stand and stretch, stand and stretch, so that we do good service. Thank you. And over to you, Mr. Semakula.
Thank you very much, outgoing chair. When she came in, she said that the previous chairs were medical, and then she came in as a teacher. For your information, she's a teacher but of science. Coming in right now is a teacher of arts, all the way from the Ministry of Education and Sports. My name is Semakula Henry. I work with the department in charge of guidance and counseling. I can see that we are time bad at this event, and so I don't intend to waste any much time. Let me begin by inviting my panelists over here so that we can make good use of the next 30 minutes that have been given to us for this session. My first panelist is none other than the Assistant Commissioner in charge of youth at the Sister Ministry of Gender, Labor and Social Development. My senior brother, Mr. Mondo, you are welcome. I know that I need to invite you first because I know your walking steps. You are not faster than me at any event. So kindly begin the walk up to this panel area. Our second panelist is going to be Madam Ruth Awori from UNIPA. Ruth, kindly come over. And then the third panelist is going to be our team, Christine, from Makerere University Water Read Project. Welcome, Christine. My fourth panelist will be Macklin Kiomia. I know that the doctor who has just been up here has been speaking for key populations, but I know that my sister, Macklin Chomia, is even going to speak more for them as she comes up here. She comes from the Alliance of Women Advocating for Change, and yes, through her we shall hear their voice a little stronger. Okay. Oh, thank you very much. I mixed up a team's name to Christine, but she's actually Caroline. And then my final panelist will be Victor Nalule, the ED of Tunaweza. Victor, do I have you? Yes, as she makes her way here. I also happen to be a panelist in this session, only that in the circumstances I've been requested to stand in for the person meant to chair this session, who was supposed to be the moderator was supposed to be one Emma Ofono, a board member at Uganda AIDS Commission. Otherwise, all the same, I've been a scout before, and I know that even when there's no long time notice, somebody can do something. I also happen to be a Rotarian, and in Rotary, I believe in service above self. Anytime you are given an opportunity, you wake up and grab it. I would like to take the honor as chair of this session to recognize a person I saw coming in a while ago, Owechitibwa Prosperous Nanchindu Kavuma from the Uganda government. I know that introduction will be made more formally later, but I think in the discussions that have just passed, we're talking of our key stakeholders, the cultural leaders and the religious leaders, and I just saw a team of religious leaders also around. I don't know where they've gone. So my dear panelists, unlike the previous presenters who have had a full 30 minutes, for us we have only 5. And me, I am a teacher. When you're a teacher, you know your lesson ends 40 minutes away. You don't encroach on the next teacher's lesson. But I also know that the people at the panel are people who have been at international panels, and they know that if you have been given 4 minutes and you speak for 8, the last 4 will be wasted, because then people will not hear what you are out to say. So I'll take us right into the discussions. We have had scientific presentations in the past. We've had a lot of work being carried on around the issue of prevention. We appreciate Uganda AIDS Commission for rallying us in a multi-sectoral response. I come from the education sector, and we know that we are doing quite a lot from that side, but there are many other government sectors doing a lot, much as we may not expect them to be doing the same. But we also know that government alone can't accomplish all the work, so we have beautiful partners, among whom we've selected the few who are here. So as we begin making use of our 5 minutes, I don't know, where's the moving mic? Oh, the moving mic is already here. So as we make use of the moving mic, I want to begin with my brother Mondo Chateka, the Assistant Commissioner from the Ministry of Gender. We know that you are in charge of all the young people, especially those out of school, because when they're in school, myself and the rest of the people at Ministry of Education are in charge. So I would like to find out from you, Mr. Mondo, what economic empowerment programs are available that benefit adolescents and young women, as well as boys? Because from the previous discussions, it seems like poverty is one of the key factors that is keeping this challenge of HIV and AIDS around. So your time begins now at exactly 52 past 2.
Thank you very much, Mr. Chair. Allow me to ride on the already established protocol, and I want to thank the Director General and the Board of Uganda AIDS Commission for putting this together, but also for choosing to focus on the adolescent, the younger people. The adolescent age is an age which oftentimes is neglected. It is not normally focused on. We talk about children, and after children, we go and talk about youth. So we jump this very important and sensitive age of growth to, I don't know who to look after them. And therefore, I'm so happy that my big brother, the Director General, Nelson, has been so sensitive to the extent of influencing board and others to think about targeting and focusing on the adolescent girls and young women and boys. And also, I want to thank you for adding the boys, because again, Dr. Kambugo will know that oftentimes for the boys, we are left to fumble. We are left to look after ourselves and find ways of doing things, and many times in not the right way. Of course, you may all be knowing that data does indicate that a quarter of girls in Uganda, aged 15 to 19 years, have had a child or are pregnant. 34% of Ugandan girls are married by age of 18 years. And young people are responsible for 34% of all new HIV infections annually. Or anybody ask why we are focusing on this category of people? Data is pregnant that we need to focus here if we are going to have interventions that will help us root HIV/AIDS from our midst. I want also to say that the adolescent girls and boys, they need quite different interventions from the younger women. And let me start with the young women. For the young women, what economic activities have we put in place for them to benefit from? You may want to know that part of the causal factors of HIV/AIDS, especially among the young girls, is poverty. Poverty has made them to be careless, sometimes with their lives, but also the question of targeting. Somebody pointed out here that the big men who have money are targeting the young girls. You find lots of cars parked at Makerere University, even when people are not vice chancellor, even when people are not enrolled for any program. You start trying to find out what exactly is happening here. And so a number of young girls, a number of adolescents have been misled into sexual activities, and hence the 34% responsibility that they shoulder on infecting others. Quality education or access to quality education is one of the best equalizers. Talking about equalizers, quality education and skills development among these adolescents is one of the things that can help us if the young girls, if the young boys are given education, they are skilled, and they can
fend for themselves, then they will have limited space for people to misdirect them. Therefore, government put in place UPE, USE, but also vocational education. With vocational education, we are still suffering with deconstructing the mindset of people. There are people who believe that everybody must go to where Professor Kambugu comes from, must go to Makerere, get a degree, regardless of which degree. But we are struggling to ensure that the young girls, especially those who have dropped out of school, they are accessed to quality vocational education, to enable them fit in society, to enable them earn a living, to enable them live independent lives untampered with other people. It is also in the interest of promoting education for the girl child that the 1.5 for all public institutions was introduced to keep the girl child in school, consistent with Article 34, Clause 2 of the Constitution of the Republic of Uganda. So, variously, young girls, adolescent girls, and boys have been targeted for life skills, soft skills, and the parents, we have targeted them with the construction of their mindset. For the young women and young boys, the package is different. These ones we are targeting for economic empowerment through UWEP, Uganda Women Enterprise Fund, through YLP, through Uganda Venture Capital Fund, and through Operation Wealth Creation, Emyoga, among others. We have also tried to ensure that these young people get the information that they need, because we find that many of them, despite the existence of these programs, one, sometimes they want to go in for semantics. They think that a program which does not carry the nomenclature, youth, does not target them. And therefore, we are struggling to ensure that when we are talking about PDM, for instance, is targeting both the people like the chairperson who is about to stop me from speaking, but also targeting the young people whom we are targeting to ensure that they are.
You actually saw me, Mr. Mondo, but I only wanted to give you one bonus minute, not to stop.
Thank you very much. We know that when we are struggling with PDM, we are talking about the 39% of people who are living within subsistence agriculture. That translates into 3.5 households and 17.5 million people. We are saying that if we drive these people out of subsistence agriculture to a money economy, and they learn to be friends with money, so that money does not shock them when somebody appears with a bundle of so many, they call it vizike, you know, and I changed my thinking, and you see, and things happen. And so we are saying that all these programs are aimed at helping the young people access employment, access something to do, access money, and therefore money does not become a stranger to them. We are talking about foreign direct investment, we are talking about agro-industrialization, but we're also talking about liberalization of the economy. When I was growing up, Dr. Kambugu, the Vice Chancellor today, there was only one university, as you know. Right now, you can talk about 40 plus universities. All these are aimed at scaling and educating the younger girls and the younger boys to be able to be self-reliant, to be independent, and to be able to live on their own. The problem we still get with this category of people, if you talk to them about vocational training, they will say no. Vocational training must be for those who have failed, whose brains don't move in gear 1, and so they should not be part of us. And so as parents and as young people, we have a big duty to work on the mindset of the young people, because doctors are very important, engineers are very important, but the nurses are equally important, and these mechanics are equally important. And so we need them to help the doctor do a good job. A doctor without nurses will do but half of the job. Just
Thank you
as an
very much.
engineer, without these mechanics, will not complete the job.
I can see
so
you
everything
getting
possible is being done to ensure that we economically empower the young people to live independent lives. I thank you for harassing me.
Thank you very much. Mr. Mondo clearly knows that what I'm doing here, he does more often, especially at international and national events. And this idea of giving only 5 minutes to a person who understands his subject is really very disastrous. Otherwise, we want to thank you for summarizing. He claims to be an elder, but he's so youthful. I know that in many occasions he has introduced himself as a young person as well. Mr. Mondo, I come from the education sector, and you mentioned that we have over 40 universities, but the fact is that the current count has 41 private and 9 government, so we have around 50. So when you talk of the challenges around the young people in those institutions, we understand. Let's move on to our second panelist, who is none other than Ruth Awori from UNIPA. Ruth, you've been the other side doing the emceeing, reminding people how time has passed, and you are part of the organizers of this event, which provided 5 minutes. Let us see how you utilize the 5, beginning now. Mr. Mondo, don't worry, I'll give you a closure moment. I give each of us a closure moment later for us to put up what would have left. My sister, you start now.
I was really hoping I would be giving an extra minute for having been the other side. But thank you. The question I'm supposed to answer to is a question of stigma and discrimination, which has been central, and I think most of us have had it since morning, since yesterday, as one of the pertinent issues that are affecting young people living with HIV. As an organization, during the introductions, I was introduced as the executive director for the Uganda Network of Young People Living with HIV. One of the central things that we look at is creating an enabling environment for young people living with HIV. And what is enabling, if at all there is stigma and discrimination? So one of the things that we do is implement a campaign that has brought most of the young people that you're seeing here today. That is the Y Plus Beauty Pageant. The Y Plus Beauty Pageant was designed to address and challenge stigma related to living with HIV. And this is done by working with the young people themselves. That's why you hear them saying that nothing for us without us. The campaign looks at collecting a great mass of young people living with HIV who are ready to disclose their statuses. Please note, it's voluntary. We do not force anyone to disclose their statuses. And when they come out, we empower them with the skills, we empower them with the platforms to be able to speak about the issues that affect their fellows, but also challenge stigma and discrimination in their respective communities. When we are doing the pageant, we are targeting young people living with HIV as the contestants, but of course in the due process of the campaign, we do not restrict it to only those living with HIV. We do engage with the different communities because we know the challenges that young people living with HIV face are mostly brought about by those who are not living with it. So we recognize the need for us to work with each and everyone who is a key player in the response. When we are doing the pageantry, most of you would think that, okay, this is a beauty pageant, so it's all about beauty and glamour, but it's a campaign that is designed to address different issues. For example, when we are starting the campaign, we start with the launch, and at this launch is where we lay our roadmap of what we shall be doing. And then we proceed to the regional auditions. It's not just purely auditions. In the auditions, we do community dialogues where we engage with the district representatives, where we engage with the schools, where we engage with the parents of these young people to create awareness about a key issue. And this changes every year. You will find that in 1 year we are looking at gender-based violence, the other year we are looking at mental health. So each and every year we tackle different issues that are affecting young people. Then when we do the auditions, we select young people who then proceed to the boot camp. And this is like the training ground for the young people, preparing them to be advocates in the communities and be able to advocate, use the different platforms available to them to speak and cause change in their respective communities. At the grand finales, we usually get the winners, who would be like the coordinators for the year that would lead their fellows. The initiative does not end at the grand finale. We empower young people to develop their own action plans of what they're intending to do in their respective communities. what kind of support they need, and throughout the year of them being ambassadors, they go ahead to implement these programs, to implement these action plans. That's why when Fiona was speaking, you had her talk about, that's why I went to the TV, that's why I'm talking to university students. Those are things that they plan during the boot camp. So implementing the activity is not always just fun. Of course, there are those challenges, most of which have already been spoken to. I'm very happy that one question was raised about the perceptions of the community. Most of the times the campaign is misunderstood. You may have come across different posts from a prominent pastor criticizing the campaign, which we understand not everyone will appreciate the concept the way it is. And we do understand that sometimes, even if you're lying down for someone, they'll say you're not flat enough. So part of the challenges we face are the misunderstandings of the campaign, the opposition, but also the criticism that comes with it. In the due process, we have been able to register some successes that we are really happy about. Over the years, I remember when the campaign started in 2014, there were only 8 participants because of the stigma. But to date, you realize that many young people are coming out, over 100 coming to contest. That shows that the young people are actually appreciating the fact that they are living with HIV and there is something they can do about it. We have seen young people taking up spaces, owning the response. Many young people have started up their regional, their district level networks of young people living with HIV, and these are the ones that are coordinating activities at that level.
Okay, my sister Ruth, just one more minute for you to sum it up for us.
Thank you very much. So besides the district networks that they have started up, we have also seen them in the COVID-19 period. Many young people were struggling, but it was these ambassadors, I remember that call came directly to me. One of them reached out and was like, Ruth, young people are not getting treatment, what can we do? And that's how the idea of peer-led service delivery was done in the COVID-19 period. At first they had to walk on foot, and of course with time, many partners came on board, supported us with bicycles, but where did the whole idea start from? It was from these ambassadors who now are owning the response. I know that I need to look out for my sister, I need to look out for my brother. So what we would really look out for in this period, or what we call to action, what our call to action is, first and foremost, we need to own this campaign as a nation. We do recognize that stigma is an issue. We do know that we all have something that we can do. Addressing stigma and discrimination shouldn't be a role of those living with HIV, it should be a collective responsibility. So in whatever capacities that we hold, let's own the campaign, let's be responsible for addressing stigma in our different spaces. We know stigma shows face in different faces. You may think that it's only about calling names, but it could be in your workspace where you're criticizing someone because they have missed a day at work because they had gone for HIV treatment. So we call to action, our call to action is let's own the response, let's support the scale up of the activity, the campaign itself, and let's provide the platforms for the young people to actually do what they are called to do. Thank you very much.
Thank you very much, Ruth. Only wondering if Miss Y Plus also includes Mr.
Yes, please.
It does. It does. Yes. Okay. Thank you very much. And you talked of champions that really moved out in the communities to deliver HIV information. And I remember the one, Quraish, I think it was Quraish. He really had to sacrifice his car. One time I found him stuck somewhere along the express highway, and immediately I said, no, this one is a champion in the other struggle. So we go together. Thank you very much for sharing those insights. I have learned that one of the participants coming shortly after this panel, the presenters, is one of our very respectable pastors and artists, and that is around already, and that he has a strict program to also be somewhere else later. So that adds to the speed I'm now increasing as far as my panel is concerned. Let's get to you, my sister from Makerere University Water Read Project. And I know that the boss from Makerere has already spoken a lot. I'm sure he even stole some of your answers already. But I want you to draw your attention to what researches have been conducted that have informed policy and programs for delivery of HIV and AIDS services, targeting adolescent girls and boys, with specific reference to Makerere University Water Read Project.
Okay, thank you so much.
And the 5 minutes have begun now at 3:11.
I hope I will also get a bonus. Thank you so much. I am Caroline Atim. I work for the Makerere University Water Read Project. I am a technical advisor for the gender and youth programs in the organization. All protocol observed, I would want to appreciate the Uganda AIDS Commission for putting this up. And also, Kambogo, thank you for recognizing Makerere University Walter Reed Project being one of the research organizations in the country, and we are here to keep informing policy, informing programming on issues to do with emerging and re-emerging infections. So for Walter Reed specific and to the 5 minutes, we conducted a research in 2017 on PrEP, and this basically was looking at how feasible is it to give PrEP to adolescent girls and young women. And this was looking at the girls who were 18 years to 24. So the research started in 2017 and was completed in 2019. So what did this research give us? What did this research inform us? It did inform us that you can actually give PrEP to girls who are at risk to HIV infection. It did also inform us that the PrEP can be, the uptake is there. The girls can really come in for the drug. And it did inform policy, and that's the reason we have the PrEP policy coming in and rolling out and saying that we have to give PrEP to adolescent girls and young women. I would like to also appreciate that the research did inform what the university is doing, that it is increasing on research to see what more can we give besides the pills, because the research that Walter Reed did was on pills, girls taking up PrEP for pills. And so that informed programming, informed policy, and everything. But besides that, we've had dreams has been talked to about from, I think, yesterday to today. And I want to say Makerere University Walter Reed Project was among the first organizations that participated in the pilot from 2015, 2016, and to date, the pilot informed, so the pilot went from 2015 to 2018, and it went further to inform programming to what we are doing. And the DREAMS program, we've heard about it, it was specific to adolescent girls. But it didn't look at the girl alone. It looked at the girl and the people around. Commissioner Mond has been telling us that we have adolescent girls are surrounded with all prey around them. So we need to reach out to those men, to the boys, to the parents, to all the leaders and the stakeholders that need to talk about how do we protect. One of the questions that was raised was, we are looking at girls, how about boys? Yes, we look at the girls, because when statistics are displayed, for this year the Spectrum data was showing us that for the girls who are 10 to 14, about 11,000 are undiagnosed. So we have girls who are HIV positive and they are not yet on treatment. We have about 13,000, those who are 20 to 24, who are out there and they are not yet diagnosed. And yet the age group of the boys in the same categories are half the girls. So we focus on such girls to do. So the research, the pilot of the DREAMS that looked at what are those age-appropriate structural interventions that we need to give the girls. And this focused on first identifying the inequalities. What are those inequalities that the girls do have? Things to do with structural inequalities at community level, the norms that do exist. We still see our girls. When we go to our health facilities, we see girls 10, 14 years to 24 being pregnant. So if we do not understand that, one may be because of the early marriage, sexual and gender-based violence that these girls have experienced. We also see...
Okay, I'll give you 49 seconds.
Okay, thank you so much. We also see that some of these girls have little knowledge. And so as a program, through the PEPFAR program, we do give a lot of evidence-based interventions that the girls do utilize to understand what do we know about HIV. how should we go, where do we go to receive our different tests to know our status? What are some of, Monda has talked of the economic ventures, and we've talked about vocational skilling. So as a program, we give informal skilling for the girls, where they can be able to get skills. And I'm proud to say one of the tents in the exhibition is for the girls from Walter Reed. So please, as the day ends, please pass by, and they shouldn't take those things back to Mukono.
In fact, I've had the chance to tour that stall, and as an educationist, I've appreciated the handwork shown by the girls you're engaging.
Thank you so much for appreciating. So for that, I'll wait for the closure.
Thank you very much.
Because
Thank you very much.
concluded for me. Thank you.
Thank you very much. And as Minister of Education, we also interacted a lot with the DREAMS project. For those who are just hearing the acronym for the first time, the full word is determined, empowered. I've started from the wrong side. DREAMS. Determined, resilient, empowered,
AIDS-free, mentored, safe adolescent girl and young woman.
Thank you very much. If you've participated there, then you've really fought for our young people. Let's move into my sister from AWAC. And AWAC is Alliance of Women Advocating for Change. And I know that this is where the women who we sometimes call members of the other side, the key populations also. Okay. Oh, she tells me that they have adopted another name for them, pleasure consultants. And I think that is the way to go, Mr. Mondo. As we look at the employment issues, we need to have a change in some of these names that we use at office level. Why shouldn't the office messenger become a communications messenger, conveyor? Why shouldn't the driver be called a chauffeur? Why shouldn't the office attendant be, which other name can be beautiful? Front desk manager. Instead, and askari can be security consultant. Yes, some of those names are really beautiful. Please, my sister, proceed to use your 5 minutes, starting now.
Thank you so much. Kiomia McLean, I work with AWAC, but I'm also vice chair of the community-led monitoring, and also I'm on the board of Uganda Key Population Consortium, which coordinates key populations in Uganda. I work with female sex workers, but I'm here to speak for key populations entirely. And before I proceed, I really want to appreciate Uganda AIDS Commission for this platform. 10 years back, we were even restricted to have an exhibition in same spaces. We were restricted as key population to access such a platform just because of the legal environment. I want to appreciate the implementing partners, PEPFAR. If I say PEPFAR stroke CDC, IDI, Rakai Health Science Project, MJAB and Uganda UPMB for the support that has actually improved the access and availability of services for key populations. I also don't want to forget Ministry of Health for the good policies that we have, though we need them to be practicalized.
And Maclean, just excuse me, I forgot to actually ask you. I know that you already stole the exams and have the answers, but I really want you to tell us, give your assessment of availability and accessibility of HIV and AIDS services for key populations. So now get to the answer. We've had all the preamble. Thank you.
Yeah, so thank you so much. So I still have the 5 minutes. Yeah.
They are now 4. They are now 4.
So I just want to say that, yes, the reason I was appreciating these implementing partners, but when we talk about access and availability, it means that you access something which is available. So when you look at the grassroots structures that we've been enabled with at key populations, among them is the drop-in centers, which we call the DICs. And as we speak right now, we have 49 drop-in centers which are KP-led across the country, and we really appreciate, we do not take this for granted. We want to also look at the availability of ARTs or antiviral and PrEP, which is also very high accessed by key populations. Of course, with other constraints, but the reality is if you really want to access these services, they're available in government facilities and KCCA in Kampala, and of course, government facilities beyond Kampala City or Kampala Metropolitan. When you talk about condoms and lubricants, you've seen in the exhibitions, most of the key population exhibitions like WONETHA, like AWAC, you go there, we are even educating very many other people to access lubricants, how to use them, the condoms, and everybody's asking questions. Initially, people thought all these were actually meant for key populations, it will promote promiscuity, yes, thank you. But unfortunately, we realize because of the pressure, the stress, mental health issues, many women end up actually losing a lot of lubrication. And what we have to do to enjoy is actually to supplement with those lubricants. The other issue that we can't forget about availability is we've got the DACs I've talked about. We've got the community monitoring monitors who are supporting to pass on the information to the communities, to engage dialoguing with other stakeholders, like, for example, health workers, police officers, and, of course, the key populations within the community at the grassroots. And also not forgetting, again, the previous speaker talked about the legal assessment environment. It has equally contributed to enabling the environment of key population to access services. What has it done? That the act is not the issue actually, but most people have been targeting the practice, which is a very key limitation, but also fuels discrimination and stigma. So you find most of us, instead of going to seek or access the services, we choose to go in the hideouts or to run away to places where we would access these services as key populations because of that legal environment. But this bold step taken by our government, Uganda's Commission, the PEP First Step itself, and created an enabling environment to some extent that even health workers use this as a reference to actually provide services to key populations. And even police feel that, okay, if Ministry of Health is doing this, Uganda's Commission is doing this, what do we have to do, including Ministry of Gender as well. And we hope things will change as we go forward.
And with that hope, we have 1 minute to go.
Yes. Just on the other hand, in terms of accessibility, again, we still have a challenge of supply chain. You find that we have the ART, we have PrEP, but family planning is not available. STIs drug is really a dream. Whoever sees this, it's like a miracle happening to key populations. Then the other thing is also that most of the facilities do not provide integrated or comprehensive package. We still call upon that we need this to be integrated, including economic empowerment. Long due, you've given us condom, thank you, lubricant, thank you, but right now we are looking at sustainable and economic empowerment.
And you are seated with the person who makes decisions around that.
That's why I feel lucky, and I think from here definitely we shall have the resources from you.
Thank you very much, McLean, for sharing what is coming from that section.
You cheated though.
No, I've not.
Yeah, my time.
I've not, only
I hope
that.
it's not inequality, but I will reserve it.
Okay, 30 seconds for you.
Yes, I wanted to talk about long distances. Again, when you come in Kampala, things seem to be happening very well, but when you go up country, the distance are very long for key population to travel, but also some facilities are also not getting the commodities like condoms, lubricants that we are looking at in Kampala. Then my last submission is the punitive law. It's still a reality. In Kampala, we are seeing this because we know our rights, we've been empowered, we have all these opportunities, but in the rural districts, the story is completely different. So we are still saying we have the legal assessment done, now can we touch the penal code? Thank you.
Okay, and from the submissions of McLean, you can really see a very empowered KPI, and so we are looking forward to getting all those solutions as suggested. Let me get to my second last panelist, who is none other than yes, my second last panelist is Victor Narule, the Executive Director, Tunaweza. Victor is not the last because I'm also a panelist. Don't forget I'm also a panelist. But me, I'm very mindful of the time. So Victor, what challenges are faced by people with disabilities in accessing HIV and AIDS services? And what interventions are in place to address them? We listened into a lot coming from Madame Betty yesterday, but we are glad to receive that supplement from you as well. The next 5 minutes are for you. And if you can check your watch to be sure that I've not cheated. It is 3:26.
Okay, thank you so much. Once again, Victor Nale. For those who are blind and they can't see, I'm Victor Nale. I'm a polio victim and I sit in a wheelchair. I have small legs and I'm a very confident woman. And for those who know, I'm happy I'm with here, the commissioner. Some of them know me from the Umeme, and we've been working together with the ministry and the health part of it and safety. So I'm in the safe space, really. I want to thank the Director General for this opportunity. Leaving no one behind, I think I see this, we are getting to the next step and we are getting closer. Globally, we are 1 million people living with disability. And sometimes when we talk about inclusion, maybe sometimes people see, for example, maybe here, by show of hand, we may have only 2% of persons living with disability in this big congregation. And sometimes because of that, you think that as we're getting the services, these people are always left behind because you don't see them on a daily basis, just like the way we are here. But just to bring you closer, from the TASO register, client register, we have 13,000 of persons living with disability who get services. What does that mean? It means we are also affected and infected of what we are talking about, the HIV. From our organization, Tunaweza Foundation, which I funded and I lead, we are having a PEFA program which is ongoing in Kawempe. And in the past 6 months right now, we've been there trying to give access to people with disability with HIV services. And through our research, 50% of the persons we are working with are affected by HIV. From today's morning, we've had different panelists talking about different age groups. Among the 50%, we have people who are elderly, we are having the young children with disability who are having HIV, the youth, but then the majority, the women with disability, but then also living with HIV. What does that mean? It means we are facing the same challenges just like my sisters and brothers here on this panel discussed. And I'm not here basically to rainbow watch what has been talked about, but to give a voice, to add onto the voice what is happening, and to call upon the policymakers to really give a more focus onto the person living with disability. And I think I'm going to be mingling the challenges with the intervention that we want to see in place. Some of the challenges we are having are disability-related discrimination, and that brings about the stigma. Most of the people think a person living with disability, that 13,000, by the way, they think that mostly we get sex by choice, not by a chance. As you saw yesterday, we had a presentation when we were beginning. You said a woman was approached by a gentleman, but secretly. And that is what is happening on the ground. It's not just a drama. It is what we are facing as persons living with disability. Talking about the communication. As I was starting, I was talking about my disability, and I was trying to tell the person who are blind to understand the person who is talking to them. How many of us can practice that? But then, before I said my presentation, I went on to the distribution, and then I wanted to get the services. I always like using examples, live examples. Here with me, I have different types of pills, the family planning. And this family planning, they have instruction on how to use them. But then, also I have condoms with me. And the condoms still, they have instruction on how to use the condom. I have for the men, but then also for the ladies. And we still have information that is going out right now in our same spaces that shows of how to use the different methods on avoiding HIV. Why am I bringing all this? Where are the inclusivity when it comes to accessing the information? And in that space, I want to call upon the policymakers, the different organizations, to embrace such kind of opportunities. Platform, for example, using drills. My cards are drill, and we are having different kind of items that we use that are supposed to be inclusive. So as we're trying to pass on to the information out there on HIV, let's try as much as possible to be as inclusive as much as possible. And lastly...
Yes, lastly indeed.
Thank you. The movement and the mobility. I'm happy, Dr. Nelson. Today I was treated like the Prime Minister by providing me with a moving ramp. What am I talking about? We're having a lot of challenges as person living disability when it comes to mobility. You know, you find like you go to hospitals, we do not have ramps, the toilets are very small. It's all about a tick box. When you talk about the counters, we're having the little people, they cannot come and access the services they want. So in the long run, you find that we are really left behind when it comes to accessibility. But as I'm concluding, let's not keep on laminating and coming back from one year to another year, talking about the same challenges. I believe I'm talking with the like-minded, policymakers and the leaders. And I'm requesting the next year, we want to see the implementation. We want to see researchers coming out.
Okay.
I've seen different researchers coming out, but we want to see more intentional of talking about person living with disability, what has been done, what are the researchers from the Makelele, and we are happy as to Naweza Foundation that we want to work with each one of us to see that these are basically implemented. I thank you so much.
Thank you very much. Thank you very much, Victor. And Victor began by finding out whether there are many people with disabilities in this space. But just remind her that there are also invisible disabilities, and many of us actually have them. Yes, we do. It is very, very likely that a big percentage of us in this room actually have a kind of disability. All we are potential candidates for disability. So let's listen to their message very strongly. Thank you very much. I liked the sign language. Can you repeat your sign name? Okay, and for those who don't understand sign language is normally, your name is normally picked from a feature that is so outstanding around you. And for me, mine is this one. Yes, so you can tell, hey, if you find me, you can do this, I know you are talking about Semakula. Finally, the last presenter is from Ministry of Education and is none other than Semakula Henry himself, and is going to use 5 minutes. I want Mr. Mondo to time the 5 minutes. And the question to Mr. Semakula is, now where is the question? What efforts are in place to ensure that HIV/AIDS messages reach all learners in schools and institutions? But it had 2 sections. What plans are in place to reduce HIV stigma and discrimination in the environment? My secondary school teacher told me that when you run out of time in the exam, don't go for essay, just outline. And so I would outline the following as the ways that ministry is reaching out to the young people to ensure they receive messages. 1, you've all heard of our famous PIASE program. PIASE is Presidential Initiative on AIDS Strategy for Communication to the Youth. That program was a package of so many things for us to do to reach out to the young people. The package had about 8 things to do, which we actually do up to now. 1 was to ensure that our schools have talking environments. When you enter our schools, you'll find a lot of those messages, including those that talk about other things, but of course HIV. 2 was about having routine assemblies to talk to the learners about not only chemistry and economics and Ebola, but also to talk about HIV, and we continue to do that. 3 was integration of HIV messages into curriculum. As I talk now, we've integrated a lot of HIV messaging in the revised lower secondary school curriculum, but even before the revised curriculum, we had integrated a lot of it. We had encouraged our teachers to ensure that even when you are teaching chemistry, even when you are teaching literature, you integrate something on adolescent health. What is wrong with a literature teacher requiring students to compose a poem on how HIV is transmitted? What is wrong with a fine art teacher telling young people to draw a picture of a situation where a teenage pregnancy can occur? So all that is part of how we are integrating the messaging. But the 4th is also integration of messages into co-curricular activities. And when we talk co-curricular in the school environment, we have a lot. We have debates, we have music, dance, and drama. We have talk shows. There are schools where they'll put up a scenario of a radio and people are calling in, but meantime they are describing something around maybe HIV stigma or adherence or anything around that. The 5th one is school family initiative. You could have heard, and we know the people in this space, that there are so many homes where there are absentee parents. I normally call them internally displaced parents. They are there, but they are never there to attend to their young ones. So as an education sector, we preferred to assume that for those who don't have physical parents at home or absentee parents, we support them to access information through what we call a school family initiative where a teacher is identified as the parent now, and that teacher has a section of around 40 learners to whom he has to attend as far as the psychosocial issues are concerned. The 60th aspect of that PSA program was about enforcing guidance and counseling in schools to ensure that we reach out, especially to the young people living with HIV, so that the messaging to them can enable them continue in school despite the stigma and all other things. But we are not doing it all alone. We are working with other sectors. My brother, Mr. Mondo, didn't tell us that Ministry of Gender is also finalizing the sexuality education framework for out of school. I'm informing you that we began it. They are copying from us. They have benchmarked us. They are about to conclude it, and we are very happy. But we are also working a lot with partners, including the 5 big UN bodies. UN Women of recent we launched. How am I doing in terms of time? 1 minute to go. Okay. Of recent, we launched the Education Plus initiative, which is supported by the 5 big UN, UNESCO, UNFPA, UN Women, UNAIDS, and whom have I forgotten? Of the big UN 5. Eh? UNESCO, UNICEF, UNFPA, UNAIDS, and UN Women. Yes, we are in an agreement to have something like an initiative that we really reach out to, especially our adolescent girls and young women. Finally, in the bonus minute that Mr. Mondo is going to give me, I should also inform you that out of the partnerships, we are being supported by Global Fund, and Global Fund has supported us to reach out to the young women and girls, especially those in the vulnerable positions. And part of the activities in there include provision of school subsidies. There's a pack of subsidies that are sent out to the adolescent girl to support her. Mr. Mondo told us poverty is a challenge. And then we have issues around reusable sanitary pads. We gave sewing machines under that arrangement, and we are currently developing a digital platform.
Thank you very much. Your time is over.
My time is over. Thank you very much.
Just do this.
I didn't hand over the chairmanship to you.
There's a lot of things happening about sexuality education, and people don't seem to know where we are.
Okay.
Can you, in 30 seconds, before I give back the chair to you, clarify on where we are with sexuality education?
Thank you very much. I didn't know people like power to that level. But yes, that is why we see some people really getting stuck in some places. Thank you very much, Mr. Mondo, for the reminder. Somebody mentioned earlier that Parliament banned sexuality education. Indeed, he even mentioned that in the year 2016, that is when the ban came. But when the ban came, Parliament required Ministry of Education to come up with a framework to guide the providers of sexuality education of how to do it. The framework, fast forward, came into existence in 2018 in the month of May. And that framework clearly guides all the players around sexuality education on the content that is age appropriate and also is also scientifically right, but also on the players who must get into our school and talk about sexuality. Is it everybody? It outlines the players. It also outlines the number of topics and areas of concern that we should have for the different. Challenge is that when the launch of the framework was done, dissenting voices also came from some sections of the public. Some people saying, no, you are going to teach the Abusiru to our young people. One media company had a very huge headline saying, Minister of Education comes up to teach young people how to bonk. Now that one diverted the whole discussion completely, because now people are thinking we are going to spoil children instead of giving them relevant information. But in short, the framework is functional because you're already doing a lot of what it calls for. We are doing a lot of menstrual hygiene management.
But we should also be cognizant of the mental well-being of young people living with HIV. Let's invest and support community initiatives that are addressing stigma and discrimination against people living with HIV. Thank you very much.
Thank you very much. Finally, to my big brother.
Thank you, Henry. Henry, I want to say that I want to appeal to all the parents, or all the mothers and fathers. Let us be parents once again. Let's love, let's care, let's provide, let us nurture, but also let us guide our young people. Let not be the absentee parents in our homes, but also let's invest in the adolescents. Let's provide as much information as possible via the multimedia approach, peer-to-peer, and any other methods that we can use to reach the young people with information. The crux of the problem starts with lack of information for the young people. Young people can decide to take safer measures if information is given to them anytime and correctly. Let's invest there. I thank you.
Thank you very much. And for those who want more information from all these people, they are available on Twitter, I guess. They are available on Facebook. Mr. Amondo, I don't know whether you're available on the two so far mentioned, but I know you're available on email and mobile money as well, 24/7. Thank you very much. From the Ministry of Education and Sports, we are glad that we are part of the multi-sector response. We are doing all that we can, especially as far as prevention is concerned. We are kind of struggling with the messaging because we have controls coming from our education founding bodies and so on. But I want to use this opportunity to thank the Honorable Minister of Education and the First Lady of this country for really leading us so well in the campaign. For those who may not know, she's leading a current campaign to end teenage pregnancy, early marriage, defilement, HIV, and positive parenting. And in there's a full dose of issues around HIV prevention. Thank you very much for listening to me. My panelists, kindly get back to your seats as I take the honor to invite the chair of the next session. I don't know whether the chair still stands as per this program, but if the chair still stands as per this program, then it should be now. Okay, the MC must have been briefed. Thank you.
Thank you so much, Honorable Semakura. Let's give them a round of applause.
Oh, I didn't know I was a honorable. I only thought I was.
I think this is among the best panels we have had so far. Not so. Let's appreciate the panelists once again. Thank you so much, the panelists, for the research you made. And indeed, during your presentation, it showed that you had really made research. And my co-MC, thank you so much for representing us. Now, in our next phase, we are going to be having a skip from Luigi's High School from Chileka. Before we go to the next plenary session, where are they? Luigi High School. Luigi High School. Luigi High School, let's keep time. Let's clap for them as they come. Luigi High School from Chireka.
Very much. Good afternoon, everyone. My name is Kaigo Betty. I'm a teacher from Luigi Giussani High School. As the young people get on stage, I would like to say something about the school. Luigi Giussani was an Italian priest who inspired the director of Meeting Point International. She's called Rose Businje. She works with women living with HIV/AIDS in the slums of Naguru and Chireka. Our school was founded by these parents. They gathered money that they had got from cracking stones in the quarry in Chireka and making paper beads. Together with some help from the Italian aid agency ABSI, they were able to construct a school which in the 10 years of our existence has managed to evolve and even now serves the community around us in providing quality education for the young people. So the young people that you see on stage are people who have been directly affected by HIV/AIDS. Some have parents living with HIV, and some have unfortunately lost parents to the disease. So the song they are going to sing is a song that their parents sing often because Rose is someone who touched their life. Because some of them had given up on life, they were sick but they were not taking medication. And with my experience working in this school, I can say that it's very important to have community-based organizations that can get to the grassroots. Thank you very much.
Thank you so much. Let's give them a chance.
on literature plus math. Here today with my colleagues, we are here to present to you a small skit. It's very brief. Its aim is to show you the African way. It's so sad to think that it is still existing, the way people perceive AIDS nowadays with all the technology that has taken place. We as the Luigi students, we are here to tell you and to show you that we the young people, we are optimistic, although that the statistics that you showed us, they are some discouraging, but we will believe that by 2030, depending on the UN sustainable goal of SDG 3, good health and well-being, we shall be done with this, with the HIV/AIDS. Thank you.
Hey, Mr. Utema, Mr. Utema. Wait, I haven't. He died.
I was surprised.
This disease is deadly.
But that is witchcraft. That is witchcraft.
It is true. And she calls it HIV.
It is for whites now. It is for whites.
The white man's disease.
Yes, but here I believe that is.
What is happening to our village? Mr. Chuli has been moving with those here, that young guy and that young wife of his.
By the way, they told me it's a witchcraft. Let us go and see. First, it's a witchcraft.
Mr. Otema, that is HIV.
Mr.
Hey, Mr. Otema.
Mommy, sorry. This is witchcraft. I told you all about this. It was bewitched. He was bewitched. That woman is a witch. Look, now we say that this is AIDS. He was bewitched. That one is the problem.
She killed my husband. She was the reason why my husband died. There's nothing you're telling me. You can't tell me anything right now. I'm not understanding. Madam, please stay back. This woman killed me.
Do I really deserve to live? Am I supposed to suffer like this? Is it me that chose the life that I'm living in? Am I really supposed to suffer like this? Ever since I was young, I've been suffering. Miss Okelo found me when I was very young and innocent. And he took me to his home. And now he's dead. Everyone is looking at me. Everyone has deserted me. Do I really supposed to live? Don't you think my life is worthless? Don't you think I should kill myself? I'm very tired of this suffering. I'm so tired. I think I should just kill myself. My life is so worthless.
Young girl, what are you doing here this time? I have been searching everywhere for you. Why are you crying, my dear? Why do you want to end your life?
I'm very tired. I'm tired of living. I'm tired.
Calm down, young girl. It will all be okay. It will all be okay, my dear.
It won't be okay.
Let's go and explain to these people. I know they will understand.
They've chased me.
No.
Everyone has deserted me.
Your life matters a lot. Your life matters a lot, my dear.
I know it.
Let us go. Let us go to the people. I know they will have to listen. They have to listen to us. Please let us go. Please stop. What is AIDS? Acquired immunodeficiency syndrome, commonly known as HIV, human immunodeficiency virus.
We know it as witchcraft.
No. It's not witchcraft. Neither is it a white man's disease. HIV has been there. Gone are the days when HIV used to be a killer disease. Right now, we have a solution to HIV. We can live longer with HIV. These are the ways that you can get HIV. First of all, by having sexual intercourse with an infected person. But also, one could get AIDS at birth. One would get AIDS at birth when their mother did not go for antenatal care.
How sure are we it's not AIDS? How sure are we it's not witchcraft? You're lying.
It's not witchcraft.
He was bewitched.
This is the importance of education.
But that girl has to be chased from the village.
No, you can't. Why the stigma? Why do you have to make her suffer?
She is a calamity to our village. She has caused Mr. Ochuli's death.
She did not also want it. How sure are you that Mr. Ochuli did not sleep somewhere else? You can't put the blame on the young girl. AIDS. No longer is it a killer disease. These are the ways that you can prevent AIDS using the ABC method. A for abstinence. This one goes directly to the students. Why would you have sex? Sex is for mature people. So please, young children, do not engage yourselves in sex. B is for be faithful to your partner. Why would you go and sleep with someone else when you have your own partner? In this way, you will be able to stop AIDS. Then C is use condoms. This one goes to any other people, even the casual sex workers who want to get money. Please use condoms even for the youth. In this way, we look forward to having an AIDS-free Uganda by 2030.
But how can we live without HIV victim among us, doctor?
You can't send her away.
We are tired.
AIDS cannot be got through sharing plates. Please, share a cup with her. Share a basin with her.
We're going to be infected.
You will not get AIDS. AIDS is only got by blood contact. So please, take in this young girl because she is very important to us. All lives matter to us. As the common goal goes, we need an AIDS-free world by 2030. By doing this, we shall have a world in turn without AIDS. That is all I had for you.
So, Mr. Otema, you were saying it is what? You say it again. Witchcraft.
We shall first inquire from our great grandfathers.
Now, boss, doctor, what is your name, please?
My name is Dr. Adam Rose, and this is the importance of education to us. So please, young children available, go and be educated. This is how you will be able to have a safer world, a world without new HIV victims. This is how we shall have a better world, a safer world, and a healthy world. Free, I'm now free. Free, I'm now free. Free, Rose.
When I was homeless, Rose set me free. Free, I'm now free. Free, I'm now free. Free, I'm now free. Rose set me free.
All in all, in order to curb HIV/AIDS, you should use the ABC method, where A is abstinence, B is be faithful to your partner, C is use condoms. Then we shall look forward to getting a world free of new AIDS victims. Thank you.
Rose set me free. Thank you, ladies and gentlemen. I hope we have done our best. And by 2030, just like the UN SDG 3 goal says, good health and well-being. We, the young people, believe AIDS can be erased from this world. Thank you very much for your audience.
Thank you very much. Let's give them a round of applause once again. Thank you so much. Without wasting any other time, let's go into the next session. And it's going to be chaired by Professor Reverend Canon Gideon Biamudisha. Let's give him a hand clap as he goes to the podium. Professor Gideon, a very interesting gentleman here, and you're going to be kindly requested to introduce the panelists of the day. The floor is yours, Professor.
Thank you very much. Assalamu alaikum. God is good, and all the time. Yeah, this is the day the Lord has made. And you know, with God there are no accidents. Everything by Him is planned. So there is a reason why you are in the room and the others are not. When God wants to do something, He does 4 things. You can write them down. He or she. God has no gender, by the way. God is God neutral. 1, God sets the time. I want something to be done. When should it be done? Number 2, He identifies the place. Where should it be done so that others can learn from? Number 3, mobilizes resources. Sometimes we want to do things and we're intimidated. But God cannot appoint you before He mobilizes the resources. So, time, space, resources, and then finally says, who will go there for me? Who will do it? So by the time you came here, you got a letter to say you are invited or you saw it, God was saying, this is for you. And for me today and yesterday, I am beginning something like a landmark, something like a milestone. I remember I tested something like this when we were launching the presidential fast track. I said, yeah, this is really a game changer. Now this is also a game changer. Now today afternoon, the holiday is devoted to Fidel Taya Memorial, and today we've been handling community aspects since morning and seeing how science can help us along the way, how young people can come in, how ministries are handling it. Now we want to focus again on what does remembering Fidel Taya add? Have we honored what he stood for? Our dear host, I want to introduce you 3 people in the house. Number 1 are my visitors, our visitors from the US. They are being led by the national coordinator of Together Towards 3 Zeros, Mr. Simon Peter Cheya. You can stand up for recognition. And then the team is Reverend Dr. David Williams, also a member of the TTZ, and Bishop Andrea Vaso. They have the 2 programs in Rwanda and Uganda, and now they've not even entered the hotel. From the airport, they came straight here. We're working with them to see that leave no one behind in Nansana municipality. The other group are young people from Friends of Canon Gideon. They heard that the DG has a great work being done. They said, we want to see. And they are led by the ED, Nisima, and team. The other one is the representative of Fidel Taya, Fidel Taya family, Mr. Kenneth Mulondo. The young people were saying nothing for young people without young people. So nothing about Philly without Philly's family. Well, welcome. Yeah, and we have a panel of speakers, but among them is Pastor Wilson Bugembe, my great friend, my young brother, my inspirer in his own way, and I'm really glad they chose you to be the keynote speaker. Give him a lot of other big clap. There is another guest speaker who will come after Pastor Wilson, and this is my honorable minister in the Buganda government, where I'm Semakula. Dr. Prosperous Nanchindu. So also we'll be very happy to listen to her. Right now, let's hear from Sarah Birungi. Sarah Birungi, testimony on singing alone and frightened. Sarah Birungi, if you're not there, then I will move ahead. But I was told that you are the one to do the curtain raiser before I invite the keynote speaker.
Good afternoon, everyone. My name is, I'll introduce myself and then go into very quickly the business for which I'm here. My name is Sarah Birungi, and I'm here to give a very short testimony what I did back then when I was in high school, when Phile Lutaya came back in his campaign, Alone and Frightened, to fight the AIDS epidemic then, give awareness to it, and also remove stigmatization. So my name is Sarah Birungi. Right now I'm married, so I'm Sarah Birungi Banage. At the moment, I work with the Uganda National Oil Company. We also have an AIDS policy there. We have programs for the communities where the oil is coming from in Hoima in terms of AIDS and how we treat the vulnerable people, ladies, old people, children, and AIDS. So we have a comprehensive program as far as work is concerned. But this afternoon, I'll talk about myself as a young girl back then. I loved singing. I loved listening to gospel music. I loved playing instruments. That was me. And so I went to Gayaza High School. And then in Gayaza High School, getting there when you love singing, playing instruments, you just flowed very well in that school. So that's where I was, singing in the choir. I used to play the flute. I used to play some traditional music. And so Phile Lutaya was coming, and we had an audition at school, the audition on who will sing with him. And so here I was as a young girl. We had an audition. We had a music teacher. She was English. She was called Miss Hobde. And so we had an audition, and I excelled at the audition and was selected with a colleague of mine, a pupil, another student, to sing the solo when he comes. So I didn't know much about Phile. What I knew is I loved singing. And so he came to our school, but nothing prepared us for what we were about to get into. We were a closed school. We didn't know about international media. His celebrity music we were not really part of, but here it was. He was beginning a campaign, and we were selected to sing with him. So I'm giving a recount of, at that time, what I saw and when I was involved. So he comes to our school, and yes, we are going to sing with him. He had a frenzy of media, international media, cameras, name it. It was a big campaign. But then he actually comes, and we see him. Up to today, I was telling a friend of mine, there are pictures that stuck in my mind that I would never forget. The size. He was really small. We were small children, but he was small. What I recall so vividly that I can't forget was he had a very nice watch. It was big. But on the arm, he had to tie a handkerchief several times around the wrist in order to put the watch and tie the watch. Now, as a young girl, this planted something on my mind up to today. because the size and the way he had to wear the watch. He had to put a handkerchief in order for the watch to stick. And even then, it kept rotating around the wrist. So that's what I remember. I was asked to give a recount of what I remember. Then we began the singing, Alone and Frightened. It was a beautiful song. The lyrics were nice. So we used to leave Gayaza and come to Kampala. But what stood out for me was the campaign that was at Nachivubo. Phile brought awareness to things we didn't know. AIDS was a word, but when we saw him, the way he looked and what he said, and then we came to Kampala from school to Nachivubo. Nachivubo was packed. I think some of the people came, one, to listen to the music, but also there was a believability thing going on. So they wanted to see him. Was it true what he was singing about? So Nachivubo was packed in terms of the audience, and they lit candles that whole night, because when they listened to him and he sang, then people's hearts were touched that yes, we need to fight together. So that night, the nice pictures up to today, when he's in when we're at Nachivubo, with everybody holding a candle, it's lit, and the thing being said was, we need to fight together. What did I learn as a young girl? I learned that this was a global disease, and it was serious, and it could affect the way you looked and your energy. I also learned that the fight was real, because when people came and listened and he sang, he touched their hearts. And there were people who had not got hope, but they finally came out, because he's the one, like you say, broke the stigmatization, brought the openness. And as young children, when we were growing up, we could not say we didn't know. 1, we had seen. 2, we had walked the trail with him. And 3, we had seen some people come out and finally open up about him. So what would I remember? His courage. What do I remember? His courage, his openness, his kindness, because he didn't want what he was going through to happen to other people. We went to different schools. We had an audience in Nachivubo, and it was all to let people not go through what he has gone through. And looking back, as a country, we've really had very serious strides, because people don't suffer the way he did. As young children, we were staring, we were in awe because of all the display that happened to him as a person in terms of his looks, his skin, but we've gone beyond that, and we thank God. I thank God that my country, when I stand here, is not what it was then in terms of awareness, in terms of treatment, and in terms of acceptability. Thank you. I would like if we have the lyrics. I don't remember all of them. Let me get my phone and get the lyrics.
Put it there, yeah.
There is background music, but I would love some lyrics.
You now prove the point I said, that when God wants something done, to someone to be there.
Let me get my
She was
phone.
there that time.
Yes, I was. Let me get my phone and go through the lyrics. Oh, okay. But the lyrics, I don't know them in my head. Yeah, let me just pick my phone, because I'll read.
So she says she will sing, but she has to get the lyrics. As she does that, I want to recognize my boss, Honorable General Henry Masiko. He's the Member of Parliament representing UPDF. And he's also a member of the Presidential Affairs Committee. And I also remember that I ate very good food, because I was invited at a place where they were honoring him with many more medals. So we share a platform on the presidential office that is with patriotism, where we go to teach young people. And we meet there by courtesy. I think you are the founder or something like that. But you are welcome, and I am just doing this on your behalf because I am co-chair, and I recognize that we are grateful that God gave us this chance to administer this place. So we thought that it would be good before our keynote speaker comes to think about, to talk about, we sing that song. Yeah. But let me, as they look for the music, let me also appreciate the Director General and his team for choosing the right speaker for us, the keynote speaker. Ask me why. Phile, I have seen some people trying to reduce him to only being a musician. Probably he's bigger than that. Yes, being a musician is important and it's right, but he's also a philosopher. And some philosophers are not musicians, but he combined both. For example, he was the first person to show us that it's not only disease, it's also dis-ease with the spiritual issues and emotional issues. So Wilson fits in that picture, that when you listen to him, he just doesn't think. He brings out philosophy, issues that are crucial to human beings to look at. Phile was a cultural man. He was an African. Harambe, muno mukabi, bulungi bwansi, obuntu bulamu, all that, you pick it from Phile. So, and Wilson has fitted in that picture of being an African, a true, trying to say, if I'm an African pastor, how do I communicate? How should the gospel be like in an era of pandemics? You know, how do I communicate this so that my people are conscious, they are competent, and are resilient, not only to prevent, but also to control. And Phile was also a social scientist. He was one of the first people to say, we can't win unless we bring young people on board. Hear them singing, let's give them everything in truth and love. And Wilson has done that. You know, his ministry wouldn't be what it is if his focus was not on young people and celebrities. And Phile was also a deeply spiritual person. Deeply spiritual person. When you listen to his Ngenda jali, that type of thing. Zukuka, ngenda jali. Tugende, munyumba yetu sinze. When you hear that. Or tumusinze. Hallelujah. You hear that these are songs that are being communicated by a deeply spiritual person. Maybe, Mr. DG, maybe that's why he said, I need to open up. Because spiritual people, when they see light, they don't want to hide it under the table. They want others to disclose. So you can see, you've brought us someone who is like, in all aspects, you know, spiritual, philosophy, focus on young people, you know, and all that. So we are grateful that you chose the right person for the right day and the right time. Clap for the organizers. I'm sure you are ready with the music? Yes. Okay. So she's going to lead in the music.
I think we should all sing. I have not done this in 40 years.
Yeah, we'll see.
All right.
the darkness. The days are long, life in hiding. Now I'm making new contacts. No more loving arms thrown around my neck. Take my hand now, I'm tired and lonely. Give me love, give me hope. Don't desert me, don't reject me. All I need is love and understanding. Today it's me, tomorrow someone else. It's me and you, together's love outside. We'll share a life in the fight against AIDS. Let's come on out, let's come together, fight AIDS. In times of joy, in times of sorrow, let's take a strong and fire to the end. We open hearts, let's stand up and speak out to the world. We'll save some lives, save the children of the world. Let's be open, advise the young ones, a new generation to protect and love. Hear them singing, playing, laughing. Let's give them everything in truth and love. Take the message. Cross the frontiers, break the barrier, fight together. Doors are open, we'll lead the struggle. We won't back down, keep the fight on. Today is me, tomorrow someone else. It's me and you, we gotta stand up and fight. We'll set a light in the fight against AIDS. Let's come all out, let's stand together, fight AIDS. In times of joy, in times of sorrow, let's take a stand and fight up to the end. We open hearts, let's stand up and speak out to the world. We'll save some lives, save our children all the world.
So commissioners in the house and the DG, you can see that what the gentleman prayed for is still valid. He said, I need love and understanding to fight this disease. We don't know if you had been given all the love, what could have happened. Mr. DG and commissioners, Uganet is in the house. We have been told that people are willing to give the love and understanding. It's only the legislative environment that is prohibitive. So you can commission Uganet again to lead into that area. How do we, when we talk of love and understanding and dignity in terms of the legal framework, what does that really mean? At this juncture, let me take the honor and the privilege of inviting our keynote speaker, who is going to deliver the lecture on File Lutaya Memorial Day, Pastor Wilson Bugembe.
Mama Jolly, Tata Jolly, Nange Jenja Kuma, Takumira Mpera, Chusi Jalia Lunga, Takumira Mpera. Webali kuza, waita wasita, Ngoma Gamba. Okay, Katonda, Yabate Mwene Songa.
Okay, thank you. Am I allowed to say praise God? For the Muslims, Assalamu alaikum. Amen. I'm so honored. I'm so humbled. I didn't know this was this serious. I was supposed to come in a suit. So as the Reverend was there, I was like, man, I have a nice shirt, you know. But I promise you next time I'll come in a suit and a tie. Respect to General. Nice to meet you, sir. I also want to honor the Director General. I want to honor, I know this gentleman. You're one of the best people in Uganda, isn't he? All protocol observed. I will not embarrass myself by trying to mention people's names here. Thank you, Sarah. Thank you so much. Now, I'll be brief. Hopefully that I can deliver something here today. My name is Wilson Bugembe. What an honor. What an honor. I'm also, when I was 19, I started music, and I had a calling to start a church. And the worship house started with about 9 members, 9 students. And now it's one of the fastest growing churches. I think we're about 5,000. In Nansana, where I hear you guys are doing a good job. What else? I started an orphanage. Literally, I'm everywhere where there is someone in need. But Master Child Care is I'm one of the founders there. I rarely say such, but I think on such a day it's important. Located somewhere in Wakiso, mainly Wakiso, we have, our church is located in Nansana. Drive about 30 more minutes, you find Master Child Care, where we have orphans, abandoned babies, you know, and I recently started a new home it's called Lifted, where I used to do that. I used to just pick kids that sell, you know, these kids that sell something for school fees or something. And then in COVID, we started a home for street children who didn't know where to go. Now, because some of them are still on drugs and stuff, you can't mix them with the other kids, so have a home for such. To go there, you have to be ready. But hopefully someday. Yeah, I don't know where even to start. I feel like the school's drama said all my speech here today. So I'll try to, I feel like I should just share the anger that I got when I was younger. And if the anger is channeled well, it can do good. I feel like the day the Uganda AIDS Commission people walked in my office, I was excited. I was tired. It was morning and I was tired. I had had a lot of meetings. But when these guys introduced themselves, something kicked in me. And I said, I would love to be part of that. Yes. My family, let me try to not just follow a speech. Let me just speak from my heart. Is that okay? So my father and my mother, it's my mother that got sick first. And yeah, and you know, when you've never been an orphan, you have your mom, you have your dad. Yes, we were poor, but we had clothes and what to eat. And there comes a day, and my mother gets sick, and 1 week, 2 weeks, 3 weeks, 4 weeks, 5 weeks, she's not coming home. And so here we are with our dad, who also needs help like us. Tamanyi stocks jeziri, tamanyi gato jeziri, tamanyi. So we started to kind of be like, when is mommy coming back? Because right now, emirimu gyeyongedde nnyo nnyo nnyo, tunanolabirira taata. So mom, 1 month, 2 months, 3 months, she's not coming home. But I remember a guy called Mr. Lubiai. He comes, we were living down, my dad was a teacher, somewhere in Masaka, where is that? Chimwanyi, Masaka. So Mr. Lubiai comes from my mother's side. We knew him. He used to bring us food, and he's like, he was talking to a neighbor, a teacher called Mr. Matovu, and he said to him, how is she? And Mr. Lubiai said, oh, we lost her last night. I was playing soccer around there. So I heard what he said. It was me, I was the first person to hear that. Yafude chiro. So before she died, like a week before, they took us there, and she wanted to see us. And when we reached in there, it was a family of only boys. And I was second born, because the first born was born with HIV, and he died, and I was the second born. And my follower, Dennis, was born with HIV, and he died at about 14. And his follower, Brian, made it. He now lives in Boston. And the last born, Isaac, died. So this is family, people dying. And so when we went, before all my brothers died, so we went to see mommy. She was very sick. She's like, "Njagala kulaba bana bange, come on." So they took us, and we didn't have money. We had to walk for over 5 miles, maybe more. So when we reached there, she was at our grandma's house. She didn't see us. She's like, take them out. Mubafurumi. So I was like, now why did she call us? Because we were missing her and we wanted to see her. Now, like Sarah said, she was too small that you couldn't recognize her in her bed. Like if you covered a blanket, you could think there is nobody. So when we walked into this room, like, where is mommy? Like, oh, mwali, momobikulekao. You know, and so when she saw us, she just cried and she said, Mobafurumi, just take them out. So they took us out. And she tells our grandmother and said, I thought I could see them, but I can't see them. I can't stand the fact that I'm dying. So she dies, and here we go, and we say goodbye. I think the worst thing on earth is a child to look into the grave of her mother. That thing will be stuck in your head forever. And the worst moment was when P3, this was 1993, when P3 class came, my fellow classmates, they came to comfort me, and that was tough. Fast forward, my father got sick shortly after, and they took him to Mulago Hospital, Masaka. When Dad got sick, being young, that was kind of good because our dad was tough. So, you know, like, so parents, it's good not to be too tough, but now. So when Dad got sick, we were like, finally someone can have peace. Teri kunaba, teri akubuza wanabye, teri wakoze. But when you are young, you're young. And Dad too never made it back. And I remember that day, I think there was elections called CA, something called CA. I remember it, 1994, CA something, elections. That's the day we buried my father. So AIDS was real. My father was the last born out of 8 girls, and 7 of them died. So I want you to see my entire early life. It is funeral after funeral after funeral after funeral. So literally I developed a heart. Is it a heart like, I don't care? You know, I like, I don't care. I didn't care about God. I didn't care about anyone. So that's how I ended up being a street child. But now here we come to Philly. Philly, this thing about, I even met recently when we went to State House for Youth Something Day. I asked the First Lady to please redo this thing they did for us in school. They brought Philly's movie. And they said afternoon there will be no classroom, there will be no teachings, and you know that's fun. Teri kusoma after lunch. Tugenda kulaba film ya movie ya Philly. So everyone was like, yeah, no school, no school. Then they brought a screen, you know, it was even our first time to see a big screen. Everything was fun. I was at Stella Maris Massacre. So we go in, like Sarah said, we just, Teri kusoma, they played some songs for Philly, and then the story starts. I feel like there was a certain silence that you could hear the pin drop. We who came into this classroom excited to see this story of a superstar, this guy opened up and you could feel everyone, like you could feel every heartbeat. And I want to think that Philly's story that was played all over Massacre region helped a lot, starting with me. Because, let's clap. Let's clap. He came out because I remember when my parents died, we could not, it was even shaming or embarrassing to say, Ntiyafude Silim. How can you say that died of HIV? It means unfaithfulness. I remember my brother Dennis, because for me it was real. Dennis got so small that one day he was standing under a tree and the wind blew him on the ground. Like boo. He was under a jackfruit tree. So it was a good day. Only to realize he had fallen. And then I was like, Dennis, why did you fall? He's like, Empewo. He could not stand a strong wind. And then I later on found out how most people got sick. Now I was lucky, I wasn't sick, and Brian, my other brother, wasn't sick. But we were so poor, that they gave us this needle. We could not afford to go to the hospital every day. You know, you had to go to the hospital almost every week. So the doctor advised us that you can get a needle and boil it. You had to boil the water to a certain degree, really, really hot. And then if you boil it, you get it out at some point, and then you can use it to someone else. So we became our own doctors. So you inject one brother, and then you boil it, and then you inject another. I feel like that's how everyone in our family got sick, because there was no money to go to the hospital all the time. So I'm explaining the anger that I got. So it's out of that I'll save you all the details of miracles happened in my life. Like you guys, you are watching me here. I am a miracle. I'm a living example of God. So at some point I gave my life to Christ. I will save you all that. It's not for today. And I started writing songs. And all my first songs were about HIV and death and anger and all that. Then I fell in love with the boldness and the courage Especially, right now it may look okay, but I'm talking about so many years ago. This is in the early 90s. A superstar to come forth and say, guys, this is not witchcraft. My father used to sing in the Anglican church, and on Monday he could get his bicycle and we go look for a witch doctor. Because there was a lot of, when the skin is itching too much and kwetakula. So rumor was it was witchcraft. So he went shrine after shrine. And at some point I remember I got angry because at home mommy didn't have food, but we could afford a goat to take it to a witch doctor. And at some point it didn't make sense because dad he had to sing on Sunday and then he had to find power on Monday. So if it wasn't for Phile Bongole Rutaya to break that curtain, to speak the truth, I believe even up to now we would have lost many. Recently we've just been through a pandemic, and I think in the early 90s we had a pandemic called HIV. And I remember Salongo John. Salongo John he was on CBS. He became a celebrity for reading dead people and reading it with passion. Anybody remembers that guy? Yeah, remember Salongo John? Yeah. He used to read, and my grandmother used to charge her batteries to wait for Salongo John because he could read like 100 people in just minutes. Those were lots of people dying. So this is why I need us to clap for Phile. Yes. And like Reverend said, maybe for the spiritual part of it, that he got the courage, if you put the times, to come and say, guys, it's not witchcraft. This is A, B, C, D. And in the same spirit, politics aside, I also like Ngatubi Jemwe before say, I want to honor also the president for coming up and fighting and telling us the truth. Because in 1997, 98, I'm talking about President Museveni, 1997, he came out and introduced that the kids we are talking about. And he said, I think he became the captain of not just the army, but also fighting this disease. For me, as a victim, because my family was a victim, I think I need to honor also the president for that. For coming forward and telling us, guys, if you do A, B, C, D, give honor where honor is due. Because sometimes we politicize everything that even we miss the good stuff. Now, here we are today. Miraculously, I made it out. And I remember they wrote at the funeral, at the house of my father and mother, that Abawa Nobo Nabafa, where they write, and that everyone here died. By the mercies of God, here I am today. And let me come to now. Right now, my daily work is literally to wake up in the morning and go to church and talk to people. Right now, at least like Sarah said, abantu tebakyakogga nnyo, but still there is a lot of infection. And I'm speaking from daily experience because I meet people every day. And I'll give one scenario of a girl who told me, she came and told me, I want you to be careful because my husband is very rich and he likes church girls. And she said they both have HIV. And he told me of a guy who was a very generous church member. So I had to choose between money or protect the sheep. And I asked him, if what they said was true, and he said it was true, and the rest is history. But we had to confront it. I know of a girl who came to me and said, she gave me like 3 boys that really, really wanted to use her, but she had HIV, but she didn't look like so. I want to honor a few that come forth and say, I will not pass it on to anyone else. I will speak out of 7 people. I think I would say in a week, 3 would say they have HIV. Being a pastor, it gives me, like, people open up and they tell you the truth. I know of a girl who also said, I pray that to such that are still angry, I give you a Bible verse in Ezekiel 36:26. It says that I'll give you a new heart and a new spirit. I also pray that if there is anyone out there who is a Christian that doesn't take medication, please do. I believe in miracles. Yes, I do. But I also believe that even medication is a miracle. Because if it wasn't, doctors wouldn't have died. I believe that medications come from creation of God. And I believe you should take it as you wait for your miracle. And I'm speaking out of experience. I know so many folks that say, I'm waiting on a miracle, and I take down my medicine. Please take your medicine. Because when my brother died, Dennis, before he died, I remember it like yesterday, when on my Judge's radio, someone said they found medicine for HIV. I don't know how I had it, but I had it. And I ran the entire house. I was so happy. At some point, I realized it was not true. I don't know how I had that. I also remember a day when I personally went in the garden and mixed things and prayed over them that they would heal my brother. And then my judge threw them away that maybe I had made poison instead. So we were desperate for medication. Because by then, bakwayo mululuza, and they give you some painkiller until you die. And I remember someday in school, when someone said, my brother, we said that my brother was in Tasso. And then some guy said, Tasso chigwayo tasobola kuona. It was my first time to hear that. And then they laughed about it, and I cried. But here we are today, where you can live 20, 30, 50 years if you take your medication. I wish my brother was in this era. I wish my father was in this era. But here you are today. Also, I always tell Christians especially that don't want to take a medication. Let us use the story of Daniel, who spent a night in a den of lions. Let us call HIV a lion. Let us call the den whatever you are going through. Finally, God redeemed him, but he had not died. At least he stood through the night. So maybe a miracle will come. Maybe we shall find cure someday. But don't die before we find it. Please take your medication. I would like to end with a few remarks. I want to thank you, people like Uganda AIDS Commission. Sometimes what we need, like a Phyllis sang, is to know that someone cares. Sometimes what people need, I want to say we, because there is a group out there. I believe, I found a girl recently at the airport, and she told me, hey Olson, hi, I'm going to pursue my dreams. Why? She had attended the other group, you know, the young people living with HIV, about 50,000 who have accepted it. I don't know what it's called, some group. She went to America. Now she's in Harvard University. She's pursuing her degree, even with HIV. So, you can still pursue your dreams. Though this does not give you a guarantee to please get sick. If you can abstain, yes, you can. I want to also say two more last things. I didn't follow my script, I just followed my heart. I believe that if we don't give up, someday Uganda will be without HIV. Whoever is not clapping, you are doubting Thomas. If you believe it, lift up your hands. I believe it. I believe it. I would like to, let me see if I didn't forget anything, sir, and I will be out of here. Yes. I don't want to be in my kind of like, man, I wish I said that. Yes. I'd like to call upon pastors, reverends, bishops. You don't need 10,000 people to change the world. If we started a song here and someone starts to dance, I'm a performer. I've seen this a lot. Sometimes you come on a boring party and you start singing and someone dances, especially the drunkards. I like them. They don't need, they start dancing, and then before you know it, the entire floor is full. But one person started it. I pray that everyone here today or following online, I pray that you'll be the one person that says, I'll do a fight. I don't need government to come to push me. I don't need finances. All I need is to do the right thing. And I call upon pastors, I call upon fellow pastors, fellow artists, musicians, to use your platforms. Because sometimes, even in politics, I've seen politicians that only care about the next election, but not the next generation. I pray that we also care about the next generation. Thank you all for listening to me. If you don't invite me again, it means I didn't do good. If you invite me again, it means I did good. And I've heard about this thing of being an ambassador with Uganda AIDS Commission, and my friend Rebecca was telling me, I wish you add me on that team. I would be glad to be part of the team. Yes. But I also heard that it comes with a certain pay. It's not for free. So don't clap like I'm offering. But at least I have the heart. Okay, I can do it for free, but I will not do it for free, please. I'm kidding. And everyone says, there's this song I wrote in COVID. Can we sing it? Omoyo we ale wano kate Mowulira ale wano lelo Omoyo we ale wano kate Mowulira ale wano lelo. I would like to end my speech with a prayer, if we can all stand up. Dear Heavenly Father, we thank you, for we believe that we are coming from the dark nights all the way to the days of light. And you said in 1 Corinthians 13:13, you say that faith, hope, and love should never leave a man. Lord, we pray for our country, Uganda, Africa, and the entire world living with HIV. We pray, Heavenly Father, that we don't walk into dark moments. We thank you for Uganda AIDS Commission. We thank you for the general here. Just him being here encourages people. We thank you for people that have flown in from all over. And we thank you today for Philly. In the next month, the songs of Philly Bongole Rutai are going to be all over this country. We pray that they also remind people of this hero we had. And we pray for many more heroes. Lord, we pray for our doctors that are working day and night all over the world to save lives. Please be with them so they come out of those laboratories not with COVID, but with solutions. Lord, we pray that anyone living with HIV, you remind them there is somebody who is not sick anywhere, yet he died in a plane crash, a car accident, and you who has HIV, you can take your medication and you live for many years. Dear Lord, we pray that now we are saying thank you for the medication. We just pray for healing because you turned the water into wine. It's you who commanded darkness to go and light came. You said in Jeremiah 32:27, I am the Lord of all with flesh. Is there anything too hard for me? Lord, we believe you are the creator of heaven and earth. And you said in Luke 18:1, don't faint, but pray. We thank you, Father. We believe that the future of this nation is brighter. We pray that the next generation and the other generation will not have to go through what Philly went through. In Jesus' name we pray, and God's people said, Amen. Thank you.
You can see why God chose Pastor Wilson. Another big clap. Pastor Wilson, before you go, there is a group that you touched on, a group that is HIV positive, but have made a commitment that the virus will stop with me. And that commitment needs reinforcement with prayer. If you are here and you are HIV positive and you have made that resolution and you want Bugembe to continue praying for you, stand up and wave so that he can see. As he raises his hands to God, he puts you up like I'm putting mine. Yes, they are there, they are there, they are there, they are there. They've made a resolution that the virus will stop with them. God bless you, and he has taken a note, and he will keep you in prayer. Now we are running short of time, but now I want really that we get some responses on the keynote, but also a perspective. We'll have a perspective from the family, few minutes. We are now going to be taught generosity, being generous with sharing time, the little time that is remaining. So the family will come and say their remarks of how they see the keynote, but also what the Lord has taught them. He talked about anger that is channeled well. We call it righteous anger, that brings things, and we can see that he has channeled his anger very well. Clap for him again. After the family, we will get a cultural response from my honorable minister, Antwale Mengo, Atenga mu Kakensa Echambogo. I can see her in the room already. So if I mention your name, come forward. Come forward so that we share the platform. So Kenneth Mulondo, come forward. Honorable Dr. Nanchindu Prosper, come forward and have a seat. And Honorable Galauzi, if you are in the room or you are a representative, also come and take a seat. And then my boss of civil society, Dr. Michael Etukoit, come in front. And then we will wrap it up with my chair, wrapping it up and asking if you have questions and comments, and then we'll hand over to the people, the MCs of the day. So, without more ado, family representative, come and give us your remarks.
Once again, good evening, everybody. On behalf of the family, first of all, I want to say thank you very much, Uganda AIDS Commission. Thank you, Government of Uganda. Thank you, partners, for honoring Phile Bongo retire. After 33 years, he's still honored. So I want to say thank you very much. The other thing I wanted to raise is last year, 2021, was again a difficult year for the family when we lost the elder brother to Phile retire, Abekit retire, died that year, and we had a different struggle that year. But we are positive, and we're giving thanks to God for the far He has brought the family and what He has seen us through. The pastor, when he was giving his remarks, he touched something pertinent, the thing of COVID-19 and its implications to HIV/AIDS. The family stays in Gomba, and we still do some little work in Gomba in remembrance of Phile retire. One thing we tried to do was to see what could we do in response to COVID-19, and I'll share in perspective of what the pastor shared in his keynote address. We learned a lot. We had calls being made. We had people who missed their prevention of mother-to-child treatment. And we had new infections coming up in Gomba, at least, but this was Gomba now. Imagine the perspective at the national level. So those were new infections coming up in Gomba, and people were reporting those cases of saying, I couldn't go, I couldn't access my ARVs because I use a border and I travel to Mpiji, that's where I pick my drugs from. I don't want people in Gomba to know about my status. So we still deal with the problem of stigma. And that's something that Phile had put his fight to. When we learned that, we're thinking we can do more. And we're thinking we can work together. In his last remarks, Phile retire said, this fight will be joined by many, and we are seeing everyone coming to join this fight in their own small way and big ways. As a family, the late Abekit retire, the bigger brother to Phile retire, devoted 2 acres of land next to the district and said anything HIV should be done in that location. Have we given up? Have we given up on the fight of Phile retire? Have we given up on the fight of Abekit retire? If you watch the video of Phile retire, there's always his brother on his next, who was sitting next to him. And that was part of the fight that they were doing together as a family. We're saying we haven't given up. And the family has come up. Initially, we had Phile retire cares, but now they're thinking more of saying, what can we do and what can we do differently? So there are many lessons. Today, when I was moving around, I saw the artists doing something about the music. I visited the New Vision tent. And the question that came to my mind was, what can we do differently? The answers came in Winston Bugembe's presentation. He told us we can do something differently, one person doing something small. What can we do differently? And that's a big question. Ladies and gentlemen, what can we do differently? Thank you very much.
Clap for the family member again, because he has also kept his remarks very short. So this exercise of being generous with sharing time, because we are really, and now I am constrained kubango no HTV sijja kumugana ntulekerawo naye yemanyi nti musomesa mutendeke. So she's also going to follow the example, and she's our guest speaker. So not just giving remarks, but she's a special guest from the kingdom and also from the academia. Which do you want? She's been so generous with me when I visit her office. Clap for her also for that. Jangu oyogere n'abantu.
Thank you so much, Session Chair. I would like to appreciate Uganda's Commission for the invite, but I want the members here to note that when we want to talk about HIV in the Kingdom of Buganda, we usually front the Kabaka, who is the UNAIDS Goodwill Ambassador for engaging men. My name is Prosperous Nanchindu Kavuma, the Minister in charge of Social Services, and I handle health, education, women and gender, and the Office of the Nabagereka. Considering the time constraints we have, we are going to display a documentary of 10 minutes, and that will be it. What is not in the documentary are two things. One, that we had a trip to Kalangala, which was in our presentation, which we are not able to present today. And we noted, we visited with Dr. Nelson Musaba, with the Katikiro of Buganda, and the Minister for Presidents, plus the UNAIDS country director. We visited sex workers, and we went to a landing site called Tibuvu, and they mentioned, I'm sure the concerned team is here, that the sizes of condoms are small. But they are using them very well, and many of them are not HIV positive. Out of the 9 we met physically in their rooms, only 1 was HIV positive. But they are strictly using condoms. And we know with our efforts all, we shall be able to end AIDS by 2030. And that is our commitment in the kingdom. That is the commitment of the Kabaka of Uganda. Let's have the documentary aired out. Thank you.
Cultural institutions and leaders play an important role in influencing behavior and the way of life of people in the communities. It was against this that UNAIDS engaged the King of Buganda as a UN Goodwill Ambassador in 2017 for engaging men as a game changer for prevention initiatives in the Eastern and Southern African region with a specific focus on Buganda region.
It is now my distinct honor and pleasure to confer on you the distinguished honor of UNAIDS Goodwill Ambassador for engaging men to end AIDS in the Buganda Kingdom.
Kabaka was also given an award to engage at least 1 million men to access HIV services as a contribution to the 2030 targets of ending AIDS among men. Building from the success of immunization, fistula and sickle cell campaigns of the Kabaka, Buganda Kingdom initiated advocacy campaigns through kingdom structures and cultural activities like the Kabaka Run, Masaza Cup, Royal Regatta and cultural events to create awareness on HIV.
First of all, the Kabaka being the Goodwill Ambassador, draws attention in the kingdom and in the country. We concentrated on 3 core areas. The first is awareness. The second is attitude. And the third is trust. Because you can make people aware of some situation. You can try to change their attitude. They must trust you.
The Uganda AIDS Indicator Survey regional demarcations indicated Buganda region with the highest HIV prevalence at 10.4%, with the highest numbers recorded particularly in the island districts of Kalangala, Buvuma, Chotera, and Wakiso districts. Buvuma Island was among the top 3 high-burden districts nationally in 2014 with a 16.5% HIV prevalence. This prompted the kingdom to launch its male engagement strategy in the fight against the spread of HIV here in 2017 with the King's visit at the island.
ku mulundi guno tugenda kwogera ku baami n'abavubuka abalenzi okubeera abasaale mu kulwanyisa okusaasaana kw'akawuka ka siriimu.
The visit attracted confessions from HIV expert clients at the islands who have taken a lead role in inspiring others to enroll on HIV services.
Kukyala kwa Kabaka ne programu eno gy'atambuliddemu nga ateekateeka ng'era akumaakuma abantu okulaba nti tuziyiza oba tukendeeza okusaasaanya akawuka ka mukenenya. Kituyambye nnyo olw'ensonga nti abantu kati bangi bavuddeyo mu mbeera ez'enjawulo, mu mikolo egy'enjawulo ne beekebera. Buli omu n'ategeera embeera ye.
Bwe nneekebeza ne bantegeeza nga bwe ndiki bwe nnina akawuka ka mukenenya. Nange ne nkola ki? Ne ŋŋamba nti kino nteekwa okukibuulirako n'abalala.
Abantu okusooka baali batya ng'omuntu akwatiddwa akawuka ka mukenenya kimuzibuwalira oba oliawo okuvaayo okwogera ekituufu butya lwanaabeerawo mu bulamu bwe.
They explained a number of strategies laid in seeking male involvement in reducing new infections and increase men's enrollment on ART.
Bwe mba nsomesanga nze expert client, abasajja bano oluusi tetubafuna bulungi. Katwekolemu omulimu ffe ng'abasajja, tufune guruupu yaffe ng'abasajja tugenda kulumba abasajja bannaffe tubasomeseze eyo.
Bwe twazuulanga omukyala akalina twamuwanga okubudaabudibwa ne tumusaba omulundi omulala ajje n'omwami we bongere okufuna amagezi aganaabayamba okukuza omwana oli mu lubuto nga takwatiddwa kawuka ate nabo bennyini okuyimirirawo nga bali ku ddagala.
Their efforts have led to a great improvement in the number of men going for testing, as evidenced by statistics from Buvuma Health Center 4, the biggest health center at the island, and Butolo Health Center 3 at Kamengo in Maukota County.
So far we have had 526 clients who come here for HIV testing. That is between the month of January to the month of March. But prior to that, in October to December 2021, we had 433 clients who came for HIV testing.
Today, the demand for condoms all over Buvuma is so high that people have known the use and the importance of these condoms, as compared to those times when the king had not come in, where people had a lot of myths about condoms. Men who are on treatment are doing better, they are taking their medication very well, and their suppression is at 90.
Engaging them was a core task for the king under his ambassadorial role, and a number of strategies were laid by the kingdom through the kingdom's well-established structures.
Kabaka's government is headed by the Katikiro, then you have the ministers, you've got the counter chiefs, you've got the Gombolola chiefs, you've got the Miruka chiefs, the Batongole in the villages. It is fairly easy to disseminate information and news along that chain.
And one of the strategies that was laid was to train them so that they can be able, when in their lines of office, be able to go and sensitize other people. And the other one was to do massive health camps, and in those, make sure that people come for HIV testing. And indeed, those were very successful at that time.
We have also engaged men working in garages, men working in salons. We have had to visit those places where we think there are more men than women, even fishermen.
During the COVID-19 lockdown, the country recorded a sharp rise in new HIV infections among adolescent girls and young women, especially in Buganda, which were attributed to sexual and gender-based violence. The kingdom responded with a more aggressive campaign, dubbed Men Are Stars, where the Kabaka ordered men to take a lead role in mending efforts to end HIV/AIDS by 2030.
Tetujja kuzimba Buganda nga tetuli balamu. N'olwekyo twongera okubakubiriza okwekuuma, okwekebeza n'okwejjanjaba obulwadde bwa siriimu n'endwadde endala.
The campaign has since been amplified through traditional campfires and kingdom-owned radio station CBS and BBS TV.
Obadde okimanyi obulwadde bwa mukenenya businga kwegirisiza wano mu Buganda. Okunoonyereza kulaga nti disitulikiti omuli Kampala, Wakiso, Masaka, Mukono, Kalangala n'Empigi obulwadde bweyongera ddala ng'eggwanga liri ku muggalo. Ffe abawangalira mu disitulikiti zino tusaanye tube basaale mu kaweefube eno nga tulambikibwa Ssaabasajja Kabaka. CBS FM awamu ne banywanyi baffe aba UNAIDS kaweefube wa Mukenenya tulina okumulinnya ku nfeete mu mwaka 2023.
The kingdom also prepared branded boards with Kabaka's HIV messages, which were distributed in schools and at all sub-counties across the 18 counties of Buganda.
Oba Kabaka bw'ateekateeka ebipande bino by'olaba bibunye wonna mu ssaza era tubitimba ku magombolola, ku miruka ate ne ku byalo.
Buno bwe bubaka bwa Ssaabasajja erimu abavubuka. Mwekuume Mukenenya.
Tukomye obutali bwenkanya, tumalewo obulwadde bwa Mukenenya mu Uganda.
Abamu tubeere munyenye mu byobulamu n'okulwanyisa Mukenenya.
Lekera okwekwasa, genda weekebeze.
Kozesa akapiira okwewala okukwatibwa obulwadde bwa Mukenenya n'endwadde endala ez'ekikaba.
Ate mmwe abalwadde mwekuumire ku ddagala, mujja kuwangaala.
When I look at that message and when I read it, it is so inspiring because despite the fact that Mengo is a school that collects children of different races, different cultures, different backgrounds, but they all collect in one place, it means that La Kabaka is aiming at ending AIDS not as a regional issue, but an issue countrywide. And the theme is Men for Good Health. We are training young men, roughly from senior 1. So this is a good start, a good foundation for the future men of Uganda.
And it starts with us. The moment it clears out of our generation, the rest of the generations will be safe.
The reception and implementation of the King's messages has been attributed to the well-structured flow of information, obedience, and love for the King from his subjects.
Here in Uganda, the structure is already set. When the King sends the message, it reaches us through the Katikiro, then to the Masaza chiefs, to the Gombola chiefs, to the Miruka chiefs, and to the Batongole.
There is no contestation whatsoever in the authority of the Kabaka, in the voice and the directive or guidance that that institution gives to its subjects.
When you seek platform from the church, from any function, you are given priority because you are not carrying your message as Mumioka, but you are carrying the message of the King. And all the subjects of the King wait anxiously and attentively and receive it wholeheartedly, and they implement.
Buganda's hospitable culture has attracted permanent settlement for people from other parts of the country who testified their strong attachment to the King and the impact he has had on their livelihoods.
Atuyambye mu ngeri nyingi kubikwataganye n'ebyobulamu kati ngaffe abavubuka ba bodaboda ka Mengo atuwadde obupiira obwekuumisi twekuume.
Kabaka doesn't segregate the tribes. That's why you find even in Mengo there, some ministers in his Lukiko are not Baganda, but he welcomes.
The Kabaka and his Luchiko further identified sports as a key vehicle in driving HIV messages to the youths and young men as co-partners under the male engagement strategy.
If you want to touch somebody's hand, you must reach his heart. Today we happen to be in what we call a celebrity-driven generation. You can hardly be in position to impact young people, especially the youth, without sports. So if at all you are going to encounter headlong in the fight against HIV/AIDS, you must go where the youth are. When you take the Rio Canriga to these places, they will come in big numbers. When you organize the Masaza tournament, the biggest tournament in East and Central Africa today in terms of numbers, young people will come in big numbers. When you organize the Kabaka's birthday run, the biggest run today in Africa, it is not easy to assemble 80,000 people, most of the majority being young people, at the same time
at 6 a.m. in the morning in the same place, waiting to be flagged off by His Majesty Kabaka. So when these people come together in these big numbers, it is easy to talk about HIV/AIDS.
As such, the Kabaka Birthday Run has been dedicated to the fight against HIV for the last 3 consecutive years, and the king has constantly reminded his subjects on the threat around the corner. According to the UNAIDS Country Progress Report, the country has registered progress from maltreatment cascade from 66.8% in 2017 to 86% in 2021. The country further registered a 22% decline in new infections between 2017 and 2021 to 54,000. These changes are partly attributed to the HIV
the message
malengagement
has
campaign
been delivered.
led by the Kabaka
Thank you
together
so much,
with other
the person.
HIV-related initiatives and HIV service providers in the country.
Yes, thank you so much. We wanted the 10 minutes. We would like to appreciate our partners, Uganda AIDS Commission, UNAIDS, for supporting the production of that documentary. Sabasajja Kabaka Awangale. The documentary is free, it can be shared, and we've already given it to the person who is in charge. So the press, feel free to take a copy if you need. Thank you.
Give more clap to HTUA. Thank you very, very much. And now, that was the Kingdom cultural perspective. Let's hear the presidential and also the parish development model perspective. That's local government. It's going to be delivered by Julius Kapwepwe, technical advisor, parish development model, but he's going to deliver it on behalf of Honorable Galavuzi Sozi. Welcome. And then my friend from the community will be give us the end.
Thank you very much, moderator. And as the Ugandans say, allow me to say all protocol observed, so that we are able to go straight to the point. But in a special way to thank the Uganda AIDS Commission that this far you have brought us. We sincerely thank the living God, and we thank God again that He has been able to work through you. He worked through people to get His messages out. So thank you very much. I would like that we clap for them. The other bit quickly is we had prepared this presentation knowing in mind that we have barely 10 minutes, even now reduced, but for purposes of having it shared out to the different actors by Uganda AIDS Commission, I think when time comes. So equally, you will allow me to speak partly from the script, but also from my heart, so that we are able to redeem the time, as the Bible says. The major aspect is not to preach about the parish development model today. So sorry that I'm disappointing you. The topic we were given is the parish development model. Where are those 2, 3, 4, 5 opportunities for the young people, for the youth? And also I don't want to go into the gymnastics of who is a young person versus a youth. I know there has been that intellectual discussion and conceptual aspect of but I don't want to delve into that. So let me generally say the young people, but also Ugandans, the rest of Ugandans, you and I. Even so, if you could push ahead if you are able, otherwise I'll say that the parish development model, because also for clarity, is a government of Uganda strategy to derive people especially those who are subsisting, those who are barely living, those who are just living hand to mouth, to be able to have more stable incomes, to be able to have a better quality of life. So all Ugandans, yes, but mainly those people who are still under the yoke of subsistence, who are basically living from hand to mouth, to be able so to enter into the money economy, into having a predictable income and a number of things. The objectives are basically 4, but also to say that that number that His Excellency President Museveni has committed to getting out of the subsisting situation is estimated at national level to be 39% of the Ugandans. So if you have 45 million people, you can have a rough picture of the people, the number of people that we are talking about. But the objectives basically are 4, and if we hear that the percentage is 39, it means government has been doing the rest of the work, the gymnastics, the development endeavors, and it is still the 39% that is still lingering as the national average. In other words, if you went to Mitiana, maybe to Simbi, you may find a different figure, could be 25, but if you went to another region or sub-region or district or even parish, you may find that that percentage is about 60%. So 39 is just the national average. And the objectives are basically 4. One is food security, as the first line of security for any society across the world. The second one is job creation. I don't have to talk about the situation of lack of jobs in this country. It is known to all of you looking at the audience today. It is also about wealth creation for ourselves without having to go and beg the others, I don't know from which country, from all over the world. When God has given so many things that we could be able to tap into here for our own good as the Ugandan people, as the African people. And the last one is improving the quality and quantity of service delivery. But that now happening more at the parish. Previously, we have said the district and sub-county. But His Excellency, the President, President Museveni, for avoidance of doubt, there are many excellencies. There is excellency, this excellence of Rotary, the other one. President Museveni has said, I would wish that the service is received by my people, by the Ugandans, at the parish level, and not at the higher levels as hitherto has been the case. So basically, that's the bit of conceptual clarity I would wish to bring, and then we can always be in discussion. And straight away then I want to go to, looking at the time that I have, I want to make one point that the parish development model is comprised of 7 components. And I'll just read them verbatim so that I'm able to go quickly to the main point. 1, agricultural value chain development, which basically is about production, productivity, and value addition to what we produce as Ugandans. The second one is infrastructure and economic services. That, thank you very much for Katunkuma in Sese Islands, but how are you going to cross it to where the market is? So the economic infrastructure, the roads, the internet to know where the market is, and some of these aspects. The energy to be able to process and add value to what has been produced. The third one is financial inclusion. And many people have tended to reduce the entire parish development model to just one element of financial inclusion, where the parish revolving fund, the famous 25 and 100 million falls. Yet it is bigger. The other aspect is social services. Number 5 is community mobilization and mindset change. You can hear the words speak for themselves, that unless we believe in ourselves, you and I, we are not able to do even much. And I like the Bugende message earlier on, that we can believe in ourselves and turn many of these different energies for a common purposeful and useful result. The number 6 one is parish-based management information system. Parish-based, as you can hear, basically having data upon which you can plan. If we have a number of children in this school, in this community, in this parish, under the social services, how many classrooms do we have of a certain standard? How many more do we still need? So basically, data collection. And the last one is governance and administration, basically ensuring that things happen. So I should also quickly add that you could go the next slide if you can. Just move ahead up to about slide 7. I will say that from the components that I have highlighted, the parish development model is for all Ugandans. There has been a bit of confusion, but us are being left behind. When a road is constructed, are you going to say for you, Catholics, please don't pass here, or you are the only ones privileged to pass here, or this one is a rich man's truck, or woman cannot pass here? No. It is just the parish revolving fund under the financial inclusion pillar, where His Excellency President Museveni has directed that let that be seed capital for that subsisting category of people that we highlighted. Some other people may be able to use the ordinary commercial banks and the other existing circles. But my people, that other percentage, let them have access to finances should they need it, just at the parish level. So where then would the youth come in? I'll quickly touch maybe on 2, 3, 4 things on farm, but not everyone has land, and therefore the other aspect of farm. For instance, looking at farming as a business, as an example, onion growing and harvesting, I've looked at that as a quick example. 3 to 4 months, you are harvesting on a very small piece of land, and you are able to have an income. Profitable tomatoes instead of the American GMOs and many of these things that we import. Having our own organic tomato grown here at a premium price in the market. Free-range chicken farming is an opportunity that the youth could take if there is a need for them, and working through groups to have a financial aspect, then they can quickly go to at their parish and are able to have funding that is required. The other aspect I would like to quickly go to, and that's what I'll end with, I don't have all the time. I think I am ahead of the person running the slide. Of farm, an example of where the parish, the youth would come in. Grain hauls, for instance, and linkages with the relevant producer enterprise groups that we are aware this group under PDM support is going for maize growing, is going for rice growing. But I come in as a group to have a grain milling capacity for packaging, so that from the same kilogram, the same sack of maize, which until yesterday was only so little, having processed it as flour, you are able to get so much and supply the schools and many other people. I'll end with just one. I know time is not on our side. The moderator is looking at me. What is, I have this as number 19, so it will be the list so you can see how quickly I've had to rush. I had about 20 examples, but I'll end with this. The youth who don't have land could say, we are going to come in as agro-dealers. So we convene through a group at our trading center. We are able to have this store for acaricides that is required in our particular community, and we are able to make money. So the PDM is basically for those that are off farm and on farm. I think that's what I'll end with. And then maybe lastly, the aspect that then where would we be coming from with all this and the, I think the main message here is that, as was said earlier by Mugembe, we need to keep alive so that we are able to see all these different interventions and support coming to fruition. I thank you very much.
Give him another clap for summarizing so many slides into a few minutes. And we are so grateful, and we are happy that you have said that people can access the presentation. I myself will invite you to speak to my young people who are trying to put up a youth city to see if youth were given opportunity to run their city, how would it look like? So I will call you. Now, the community. Dr. Michael, come and give us a perspective. Please bear with us here at the community. He has 5 minutes to do it, and then we will invite our general in the house to wrap up. And there won't be any other business after general has wrapped up.
So, thank you very much, Session Chair. I salute all of you that are present here, including colleagues who are there virtually and those that will follow this event's post-activity. My name, once again, I am Dr. Tukoit Bernard Michael. I am the Executive Director of TASO. I thank you once again for being present, the DG Uganda AIDS Commission and your team from Uganda AIDS Commission. Thank you very much for organizing and coordinating this community dialogue, which goes a long way in keeping us updated, but also in fellowshipping and sharing a lot of that has happened or will have happened by day 3. So I will, because of time, I will rush through a few highlights, not the full presentation as it should have been. But join me to honor the community activists over time since the HIV epidemic in this country, who have contributed a lot significantly to what we are seeing today. They birthed the current community interventions, and top in this list is the President, His Excellency, the President of Uganda. There are other people who were affected and infected who faced very extreme forms of stigma and humiliation. And top on that list, maybe even not really selfishly, the patron, the founder and the patron of the organization that I work for, and that is TASO, Dr. Noreen Kaleba. There have been many others in the celebrity performing arts where Philly Bongolo Lutea comes in, and many others that we know that have contributed significantly to shaping the community interventions that we see today. So I was asked to talk about community and community systems that need. No, I'm going to be very fast. That so these community systems, by definition, there are so many definitions of what community systems are, but community systems are community-led structures and mechanisms used by communities that enables members, community-based organizations and groups to interact, coordinate and respond to challenges and needs affecting their communities. They can be extensive networks of organizations. They serve as a critical component of the overall system that aims to protect and promote health and human rights. To date, community systems have been very critical in the HIV response from the start of the epidemic response in Uganda. Now, just looking at some of the areas where communities come in a nutshell without going into the details, they include addressing the barriers that affect service delivery, which include gender-related barriers, inequity in access, myth, including stigma. Adapting and innovating strategies and reach out to the most vulnerable populations with HIV services where health services cannot reach, and basing this on evidence because we have huge data now to pinpoint our interventions on the most vulnerable communities. Community roles will include supporting linkage to care of new identified cases, providing leadership and governance for effective resources mobilization and utilization. Routine governance of society is an integral part of a health system because it is a routine governance that enables communities to access information, to access services. Routine governance ensures that the girl child goes to school, the boy child goes to school, the communities they live in grow food that will sustain families, including those that are taking antiretroviral drugs. The members of the routine governance of the community ensures that the health facility has health workers, there are drugs, and services are provided. So routine governance of the community at community level is a key component in terms of roles of the community. And then the communities have very big roles in stigma reduction, encouraging openness, sensitization and awareness, engaging stakeholders, testimonies, name but a few, but also providing platforms for scaling up effective new interventions, and in a way, these effective new interventions feed into suppressing stigma, and then also supporting research and generations of new ideas, which also feeds into stigma. And then there's a whole range of providing psychosocial support for adherence, and in a very particular way to viral load suppression. You have supporting ART delivery and retention to care. We have a number of community interventions that support effective provision of ARVs and retention in care. And then the whole issue of conducting community-led monitoring to ensure the use of data by the communities to promote accountability and improve service delivery. And then also the other role of the community is pioneering into innovative approaches that will promote sustainability and ownership. But also very, very important is the role of community in boosting human resources for health. This is my last slide, just to give you a picture of how communities boost human resources for health. You have the village health teams, community linkages facilitators, mentor mothers, site-based project staff, PHA networks, expert clients, data volunteers, human resources for health funded by various development partners, surge counselors, young people and adolescent peer supporters, community-based organizations, community-based organizations led by various entities and affected individuals. So it is a very significant boost to human resources for health when communities are fully engaged. In a nutshell, I want to say that the community platforms, robust community platforms, are a very, very effective strategy. And over time, this has been demonstrated over and over that robust community strategies are very, very effective in interventions in HIV, but not only HIV, including in health, including the parish development model. The platform is still the community. So it is a very, very strategic intervention to have a robust community model in place with the communities involved. Thank you very much.
I can see why they trusted you with being executive director, because they saw someone who can also be efficient and economical with the resources. Because I was still thinking you have 2 minutes, but you have finished. So clap for him. And now his presentation brings us towards the end. But because there are young people in the room that may have a question to Mr. Kapwepwe, and the communities, I am only allowing one question each, just for the most burning one. As we invite Aloysius, champion Aloysius Matovu, to give us a poem, and then I invite the general to close us. Any question? Wow, it seems you have satisfied your audience. May God bless you all. Aloysius, come ahead. One of the powerful champions, historicals. Dr. Michael, you will be pleased with the Aloysius. He's one of the earliest community guys. I wish there was someone to take a picture here, so that I don't miss this chance. I can see the DG. Yes, thank you. Amen. Gwetwazirunda.
The Lord is good, and all the time. Katonda mwamukyayo okutuuka ku ekyo temukyamukubirana mu ngalo. I salute you, General. I initiated the Soldiers for Life HIV initiative that fights HIV/AIDS in the UPDF. Hello, Stylee. How is it over there, brother? I ain't being sarcastic, but it's your moment to shine. An unequivocal reminder, calendared for your immortality, a single stone double target. As Greater Massacre and beyond scrambles for grasshoppers, a consistent reminder the world over salutes a Ugandan hero, transiting from one year into another, a season of alone and frightened, a festivity of Tumusinze up to Happy New Year. Last night, and that's today, I reflected on what you did, how you did it, when you did it, never doing it as a particular deed for a specific target, as in recipient audience, age, color, tribe, faith, gender, and even ethnicity. A self-motivated lamb, unconditionally volunteering to majestically march into that slaughter arena, double-edged swords with shining sharp blades of stigma and discrimination, ridicule and hate, concretizing a bold statement that in light and darkness would legitimize a forever glittering legacy. No, we are no longer crying. We are no longer weeping. We are no longer regretting. We are no longer lamenting. We instead applaud your bravery louder than any thunder. We raise your banner higher than any other, rephrasing your cry and plea. We are no longer alone. We are no longer frightened. Your mighty warrior spirit, deep within us, keeps us fighting. It is a world war of witty strategies to declare and proclaim freedom by 2030 against all odds. Laxity and complacency expose the next generation to a resurgence of new infections, fresh with hostile intent. Our focus and attention distracted and diverted towards greener pastures like COVID and Ebola. Locking down the nation, loosening hungry hyenas to ruthlessly feast on vulnerable prey. Teenage pregnancies, thanks to peer pressure excitement, gender-based violence, climaxing with sexual assault, call it rape, situational stigma, rendering victims helpless, climate change, dictating terms for relocation and migration, artistic mitigation is practically impracticable because no funds to facilitate the likes of me. The coffers, also they say, are empty. Nobody is safe. Continue sleeping well, dear brother.
Amen, amen. Thank you for honoring Philae, and may he continue being alive in our spirit.
Chair.
Now, General.
Chair, I kindly seek for just a few minutes of your time before the General comes in. Permission granted, Chair.
Okay.
Yeah, this is a simple announcement. Tomorrow we have an action-packed day. We shall be having the great speaker by the names of A.O. Lumumba, and we shall also be having the Minister of Finance Planning and Economic Development. This will be the morning hours of 9:30. So let's kindly come in time so that we can hear from them. Chair, back to you. Thank you so much.
Thank you very much. General Masiko, come and speak on behalf of government and dismiss us. Director General, can you bring the General, please? Maybe you introduce him more further or something like that. Come. Yeah. DG, introduce us to the guest.
Thank you very much, Session Chair, colleagues, ladies and gentlemen, Major General Henry Masiko. First of all, he represents the UPDF in Parliament, and he's here on behalf of the Chair of the Presidential Affairs Committee of Parliament, which is the committee under which Uganda AIDS Commission falls. The committee oversees the presidency, and there are many entities under the presidency, and Uganda AIDS Commission is one of the entities. Afande, we are very pleased to have you here, and it's my honor and privilege to invite you now to speak to us and close this event.
I want to thank you, the Director General, Uganda AIDS Commission. I want to thank and salute Reverend, who I was supposed to co-chair with, for holding the fort. And thank you, the audience, especially the young people who have endured to come to the end of this day's session. Just a few comments as we wind up the day's session. As you've been told, I belong to the Committee of Presidential Affairs, which handles the sector under which Uganda AIDS Commission falls. I want to, in that vein, salute the Commission, because last weekend they gave us a treat. We had a full retreat with them for 3 days, in which they took us through the in-depth status of what they are doing. And I think we come here as full ambassadors, not only as their overseers in Parliament, but now as ambassadors because of the work you did to mobilize us. For those who were there, I don't know whether the chair chose me selectively because I was among the critics on some of the methodologies in the fight. Not because I don't value what has been achieved, but for the passion that we should do much better. So for those who are looking at me suspiciously why I have reappeared, I think in that deep interface, we now are close partners. I want to bring in an angle for us from the side I represent in Parliament, which is the side of defense and security. Whatever is presenting itself as a threat, we view it as an enemy, because we are trained to fight enemies. So these pandemics, these things which affect the well-being of humanity, for us, we see them in the perspective of enemy elements. And as such, in terms of strategy, we securitize them. There is the word securitization. Once you securitize an aspect, it means you handle it in a manner like you fight, like you are at war. And some people wonder why the president takes the measures he takes whenever any threat appears on the country scene. He's a seasoned, well-groomed commander-in-chief. He's not a commander-in-chief symbolically. He rose to this through works, and he knows it best how to handle threats. For him, anything he conceives to be a threat to our well-being, to our existence, it must be fought. And it's not only being fought, it must be defeated. He's not on record of losing wars and losing battles. And therefore, to the fighters, the co-fighters, the comrades in arms against HIV, you should only pay him by copying his strategic approach to these matters. So when we were making those interventions during our retreat, this is the background we have. For us, we see HIV as a security matter. It's a security concern. It affects all aspects of human existence. You may have some coping methods, some coping approaches, but the bottom line is that you are dealing with a devastating threat. So, what do we normally do to fight an enemy? First of all, you must master the ways of the enemy. And this is what the fight should keep on. People were smiling when I insisted that we sanitize this platform, because we are still in a fight. And one of the things to cope with this fight is maintaining the SOPs. So, when you are fighting, you must understand how the enemy operates. These pandemics can be deceptive. At times they reach a stage where you can be deceived that it's all over. But the enemy is reorganizing. And the message, I think, that should come through all agencies that are dealing with AIDS matters should be to ensure we maintain what we call the aim. Maintain the aim, maintain the focus. I listened to some captions of the Commander-in-Chief, His Excellency the President, Yoweri Museveni, when he was giving UNUGA recently. He said, we must aim at defeating HIV. And therefore, we need to talk more and more. Because right from that initial campaign stages, the intervention of the president was that this pandemic is about behavioral change. And behavioral change is about mindset change. And to achieve mindset change, you must convince, you must inspire, you must explain. So it's about sustaining the campaign of talking. And we, at times, can be critical when we see that we scatter the effort. We think the aim must be, or the main effort must be, in ensuring as much talking, as much explanation is made to know that this enemy is the same yesterday, today, and tomorrow. And the way to fight must be consistent through behavioral change. So I want to thank the AIDS Commission for not keeping us far. As an institution of parliament, many things happen there. Yesterday we were campaigning for our health workers, we don't normally talk. We are supposed to be listeners in that house. But there is an MP who made a passionate appeal to government to really see that the health workers are well looked after. But when he was ending, unfortunately that was not captured, he said, yes, the health workers must be cared for, but that should not make them abandon their professional spirit. Many of them on graduation take what is called hypocritical oath. At times I get frightened to see our behavior moving away from some of those tested professional standards. Yes, it's important to fight for your rights, but you must also remain ethical and professional. So I really shudder about the new mentality that if I am not served, if I don't get mine, I would rather kill humanity. I think it is something we need to think through. So, behavior change with discipline, with patriotic outlook is the way to go. With those many words from the political house, I want to thank all those who have made a contribution. Pastor Bugembe in absentia, the Kingdom, TASO, the Ministry of Local Government, and the powerful Aloysius. I've come a long way with Aloysius. He was my fan, and I was his fan. There is when I went to theater, and he dramatized me. It's very amusing to see people making drama of you. I only saw it through Aloysius. I am happy to see that you've remained steadfast, and your poem was amazing. Keep on that. I want to salute you, among you, those coping with the problem. Keep that resolution to say, let me be the last. Let's maintain and aim that 2030, come 2030, we have defeated this scourge. I say all this for God and my country. I, Barney Dezamanyi, the wonderful moderator, and I know your story. We are very proud of you. Keep on the fight.
So, blessed are those who wait until the end. You have earned yourself a group photo with men in uniform. Yes. So, join the commissioners, and we come, I think we go out. Yeah, we go out there, and we have a very nice picture, men in uniform, and the commissioners, and the young people in the house, and all the heroes, champions, and these days Uganda Commission gave us another word, nobleists. Yes.